Ever notice how we kind of take those basic vital signs for granted?
You mean like temperature, heart rate?
Yeah, exactly. We learn them in like, what, elementary school? But here's the thing,
There's more to it.
way more. What's normal for a tiny tot is totally different for, say, someone my age.
Ah, makes sense. You're talking about those age variations in medicine, right?
Exactly. And today's deep dive, what we're going headfirst into a medical directive for paramedics. This thing, it's all about assessing patients of all ages.
Sounds intense. Paramedics on the front lines gotta be prepared for anything, huh?
Absolutely. So right off the bat, this directive draws a hard line at 18 years old. Like, boom, under 18. You're pediatric and the whole game changes.
Oh yeah, pediatrics, it's a whole different ballgame. But why 18? What's so magical about that number?
Right. What makes that age such a crucial turning point in emergency medicine?
Well, think of it this way. Kids are still cooking, right? Their bodies are literally under construction.
Organs, bones, the whole shebang.
Yep. Everything's still developing, which means their systems react way differently compared to us grown-ups.
So, like, their tolerance levels for medications.
Totally different.
Right.
And how they respond to injuries, even their normal ranges for vital signs,
Yeah.
it's all a different playbook.
And paramedics need to know this stuff instantly.
Yeah.
Talk about pressure.
Absolutely. A misdiagnosis, a wrong dosage, it can have much more serious consequences for a child.
Makes you realize those paramedics, they could be like walking encyclopedias.
Mm-hmm.
Okay, so this directive goes deep on blood pressure, even lays out a specific formula for what's considered normal in kids. You ready for this? Systolic blood pressure should be greater than or equal to 90 millimeters of mercury PLUS, twice their age in years.
Ah, the good old SBP formula. It's pretty elegant, actually.
Elegant, huh? Break it down for me.
Well, it basically shows that as a kid grows, their blood pressure naturally rises too. Makes sense, right? Bigger body, more vascular system to cover.
Okay, that's logical.
But here's the catch. If paramedics were using adult blood pressure guidelines on a 5-year-old,
Yikes. They could totally miss something.
exactly, could easily misdiagnose hypotension, which is low blood pressure, and then you're talking unnecessary interventions, maybe even harmful treatments.
Wow, okay, so blood pressure check. But let's talk heart rates for a second.
Yeah.
Because seriously, the difference between adults and kids is mind-blowing.
Oh yeah, that always gets people.
Like a resting heart rate of 120 beats per minute. If I had that, I'd be freaking out. But for a little baby, totally normal. How is that even possible?
It's all about the engine, my friend. A child's heart, it's tiny compared to an adult's.
Because it's got to work harder to keep up.
Think of it as a smaller engine, revving higher to get the same job done.
Right.
It's pumped in the same volume of blood, but it's got to beat faster to do it.
Fascinating.
Yeah.
So it's not just about how fast it's beating, but also,
The amount of blood being pushed out with each beat, right? That's called stroke volume. And it's much smaller in kids, too.
so smaller heart, faster beats, smaller amount of blood per beat. It all adds up.
Exactly. And that's why context is key. Like if a kid's running around excited, maybe a little feverish,
Yeah, their heart rate's going to be up there.
totally normal.
Yeah.
But if they're chilled out, calm as can be, and their heart's racing, red flag. Time to investigate further.
Gotcha. Makes sense. Now, another thing that jumped out at me from this directive was the whole blood sugar thing. Specifically, how they define hypoglycemia in kids under 2 versus those older than 2. Why would just a year or two make such a big difference?
Ah, yeah, the blood sugar puzzle. It's all about how those tiny humans regulate glucose. See, their liver glycogen stores, those are like emergency glucose reserves. So they're smaller in infants and toddlers.
And glycogen, that's what gets converted to glucose when they need a quick energy boost, right?
Bingo. And their hormonal systems, the ones that control blood sugar, still developing, not as efficient. So their blood sugar can plummet way faster than in older kids.
So they're more vulnerable to those sudden drops,
Yeah.
like even a small difference in blood sugar level.
Can be a huge deal for a little one. We're talking potential seizures, even brain damage if it gets severe enough. That's why paramedics need to be super vigilant with those little guys.
Wow, it's amazing how much changes in those first few years of life. This directive also dives into assessing neurological function, specifically using the Glasgow Coma Scale, or GCS for short.
The GCS, yeah, it's a standard tool for assessing level of awareness. Helps us understand if someone's brain's functioning as it should.
Okay, and it's a 15-point scale, right? 15 being the best, most alert, and...
And lower scores indicate decreasing levels of consciousness. But here's where it gets interesting.
Because a score below 15 doesn't always mean something's wrong.
Right. The directive emphasizes that even a GCS slightly below 15 could be totally normal for some folks.
So it's not just about the number itself, but...
It's about knowing the individual's baseline. Someone with a pre-existing neurological condition, they might always score a little lower on the GCS. That's their normal.
So a drop from their usual score, even if it's still technically within the normal range.
Could be a big red flag and might mean their condition's getting worse, even if that lower number wouldn't raise eyebrows in someone else.
It's like you got to know where they started to understand where they are now.
Exactly. And that's why it's so important for everyone, no matter their age, to know their own normal vital signs, their health history, all that good stuff.
Knowledge is power, right? Especially when it comes to your health.
Absolutely. Knowing your body, understanding your own numbers, that's how you can advocate for yourself or even for your loved ones in a medical situation.
Man, this deep dive has really opened my eyes. I mean, we always hear that age is just a number, but in medicine,
It's a whole different story.
it's like the key to understanding what's truly normal and how to provide the right care at the right time. It really makes you think, as we all get older, how will our own normal vital signs change? And what can we do to stay informed, to be proactive about our health?
Great questions to ponder. It's a journey, for sure, but being aware and informed is half the battle.
Definitely food for thought. Thanks for diving deep with me today.
My pleasure. Always happy to geek out about medical stuff.
Okay, so today we're going deep on something pretty intense.
Yeah.
We're looking at a medical directive for paramedics.
Mm-hmm.
And this one, it's all about how to deal with a suspected adrenal crisis.
Right.
You know, a real high-stakes situation.
Oh, absolutely. This is life or death stuff.
Exactly. And what's really cool is this directive. It's not just theoretical.
Right.
It's a real document that paramedics in Ontario, Canada actually use out in the field.
Yeah, they rely on this every day.
Yeah.
Oh.
So it gives us a real glimpse into, you know, the decisions they have to make.
Mm-hmm. The pressure they're under.
So before we get into the nitty-gritty of the directive,
Okay.
let's just make sure everyone's on the same page. When we say adrenal crisis, what exactly are we talking about?
So basically, an adrenal crisis happens when your adrenal glands.
Those are the little guys that sit on top of your kidneys.
Right, exactly. They just stop producing enough cortisol.
And cortisol, that's like a major hormone, right?
Oh, yeah. It's involved in like a ton of stuff, like how your body deals with stress,
Mm-hmm.
blood pressure regulation, energy levels, immune function.
Wow, so it's kind of a big deal.
It's a really big deal.
Yeah.
And when cortisol levels plummet, suddenly your body can't cope.
And that's when you get an adrenal crisis.
Exactly.
So this directive is specifically for primary care paramedics in Ontario.
Yep, that's right.
And it's interesting because it doesn't just say, give hydrocortisone.
No.
It actually lays out a whole bunch of specific conditions that paramedics should be looking for.
Right.
I was looking through it, and it mentions things like age-related hypoglycemia,
Mm-hmm.
gastrointestinal issues, altered awareness. It's pretty comprehensive.
It is. And that's because the symptoms of an adrenal crisis can be so varied.
Yeah, I could see how that would make things tricky for paramedics.
Oh, definitely. Think about it. You've
Yeah.
got an elderly patient with low blood sugar
Right.
or someone with vomiting and abdominal pain.
Doesn't exactly scream adrenal crisis at first glance.
Nope. But those could be signs of adrenal insufficiency leading to a crisis.
So paramedics really have to be on their toes.
All the time.
Okay, so let's say a paramedic suspects an adrenal crisis.
Right.
What's the go-to treatment?
Well, according to the directive, it's hydrocortisone.
Hydrocortisone. Most people probably know it as that cream you put on rashes.
Yeah, but in this case, we're talking about an injectable form.
Oh, right. So it
Oh,
goes
yeah.
straight into the bloodstream.
Exactly. It's a corticosteroid. So basically, it's a synthetic version of the cortisol that the body's missing.
I see. So it's like giving the body a boost of what it desperately needs.
Precisely.
And I noticed that the directive is very specific about the dosage.
Oh, yeah.
It says 2 milligrams per kilogram of body weight, up to a maximum of 100 milligrams.
Mm-hmm.
There must be a reason for that level of detail.
Oh, absolutely. In emergency medicine, every milligram counts.
Right.
Too little, and it might not be effective. Too much, and you risk side effects.
So paramedics have to do these calculations on the spot.
That's right. In a high-pressure situation, no easy feat.
Wow. There was this phrase in the directive that I found really interesting.
Okay.
It says, PCP, autonomous the V.
Ah, yes. That's a key part of the directive.
What does that even mean?
So it means that some paramedics in Ontario have this advanced training,
Yeah.
and this training allows them to give IV meds even without getting direct orders from a doctor.
Oh, really?
Yep. In certain specific situations, of course.
That's a lot of responsibility.
It is. It really highlights how the role of paramedics is evolving. They're not just transporting patients anymore.
Yeah, they're making critical medical decisions,
Exactly.
but that must put a lot of pressure on them to get it right.
Oh, for sure. I mean, there's always the risk of misdiagnosis.
And in a situation like adrenal crisis, the consequences could be severe.
Absolutely. That's why ongoing training and, keeping their knowledge up to date is so important for paramedics.
This directive really drives that point home.
It does.
It's not just a set of rules. It's like a framework for making life or death decisions in the field.
Yeah.
So for our listeners out there, what's the key takeaway from all of this?
I think the biggest takeaway is that recognizing the signs of an adrenal crisis early is absolutely crucial.
Because it's a serious condition. But if it's caught and treated quickly,
The outcome can be much, much better.
so if you or someone you know has adrenal insufficiency,
It's really important to be aware of those red flags.
like dizziness, weakness, confusion,
Severe vomiting, low blood pressure, things like that.
and knowing about this directive, it can actually empower people to advocate for themselves or their loved ones in an emergency.
Absolutely. Knowledge is power, especially in these time-sensitive situations.
Well, this has been a fascinating glimpse into the world of paramedics and the tough calls they have to make.
It has.
Big thanks to you for walking us through this directive.
My pleasure.
And to our listeners, we'll leave you with this. Imagine you're a paramedic responding to a potential adrenal crisis.
Okay.
What would be the most challenging part of putting this directive into action? Think about it beyond just the medical procedures. What else would be tough?
That's a great question.
Keep that in mind until our next deep dive.
I will.
See you then.
Bye.
Bye. Ever notice how we kind of take those basic vital signs for granted?
You mean like temperature, heart rate?
Yeah, exactly. We learn them in elementary school? But here's the thing.
There's more to it.
Way more. What's normal for a tiny tot is totally different for, say, someone my age.
Ah, makes sense. You're talking about those age variations in medicine, right?
Exactly. And today's deep dive, we're going headfirst into a medical directive for paramedics. This thing, it's all about assessing patients of all ages.
Sounds intense. Paramedics on the front lines gotta be prepared for anything, huh?
Absolutely. So right off the bat, this directive draws a hard line at 18 years old. Like, boom, under 18. You're pediatric and the whole game changes.
Oh yeah, pediatrics. It's a whole different ballgame. But why 18? What's so magical about that number?
Right. What makes that age such a crucial turning point in emergency medicine?
Well, think of it this way. Kids are still cooking, right? Their bodies are literally under construction.
Organs, bones, the whole shebang.
Yep. Everything's still developing, which means their systems react way differently compared to us grown-ups.
So, their tolerance levels for medications.
Totally different. And how they respond to injuries, even their normal ranges for vital signs,
Yeah.
it's all a different playbook.
And paramedics need to know this stuff instantly.
Yeah.
Talk about pressure.
Absolutely. A misdiagnosis, a wrong dosage, it can have much more serious consequences for a child.
Makes you realize those paramedics, they could be like walking encyclopedias.
Mm-hmm.
Okay, so this directive goes deep on blood pressure, even lays out a specific formula for what's considered normal in kids. You ready for this? Systolic blood pressure should be greater than or equal to 90 millimeters of mercury PLUS, twice their age in years.
Ah, the good old SBP formula. It's pretty elegant, actually.
Elegant, huh? Break it down for me.
Well, it basically shows that as a kid grows, their blood pressure naturally rises too. Makes sense, right? Bigger body, more vascular system to cover.
Okay, that's logical.
But here's the catch. If paramedics were using adult blood pressure guidelines on a 5-year-old...
Yikes. They could totally miss something.
Exactly. Could easily misdiagnose hypotension, which is low blood pressure, and then you're talking unnecessary interventions, maybe even harmful treatments.
Wow, okay, so blood pressure check. But let's talk heart rates for a second.
Yeah.
Because seriously, the difference between adults and kids is mind-blowing.
Oh, yeah, that always gets people.
Like a resting heart rate of 120 beats per minute. If I had that, I'd be freaking out. But for a little baby, totally normal. How is that even possible?
It's all about the engine, my friend. A child's heart. It's tiny compared to an adult's.
Because it's got to work harder to keep up.
Think of it as a smaller engine, revving higher to get the same job done.
Right.
It's pumping the same volume of blood, but it's got to beat faster to do it.
Fascinating.
Yeah.
So it's not just about how fast it's beating, but also...
The amount of blood being pushed out with each beat, right? That's called stroke volume. And it's much smaller in kids, too.
So smaller heart, faster beats, smaller amount of blood per beat. It all adds up.
Exactly, and that's why context is key. Like if a kid's running around excited, maybe a little feverish,
Yeah, their heart rate's going to be up there.
totally normal.
Yeah.
But if they're chilled out, calm as can be, and their heart's racing, red flag. Time to investigate further.
Gotcha. Makes sense. Now, another thing that jumped out at me from this directive was the whole blood sugar thing. Specifically, how they define hypoglycemia in kids under 2 versus those older than 2. Why would just a year or two make such a big difference?
Ah, yeah, the blood sugar puzzle. It's all about how those tiny humans regulate glucose. See, they're liver glycogen stores. Those are like emergency glucose reserves, so they're smaller in infants and toddlers.
And glycogen, that's what gets converted to glucose when they need a quick energy boost, right?
Bingo. And their hormonal systems, the ones that control blood sugar, still developing, not as efficient. So their blood sugar can plummet way faster than in older kids.
So they're more vulnerable to those sudden drops,
Yeah.
like even a small difference in blood sugar level.
Can be a huge deal for a little one. We're talking potential seizures, even brain damage if it gets severe enough. That's why paramedics need to be super vigilant with those little guys.
Wow, it's amazing how much changes in those first few years of life. This directive also dives into assessing neurological function, specifically using the Glasgow Coma Scale, or GCS for short.
The GCS, yeah, it's a standard tool for assessing level of awareness. Helps us understand if someone's brain's functioning as it should.
Okay, and it's a 15-point scale, right? 15 being the best, most alert, and...
And lower scores indicate decreasing levels of consciousness. But here's where it gets interesting.
Because a score below 15 doesn't always mean something's wrong.
Right. The directive emphasizes that even a GCS slightly below 15 could be totally normal for some folks.
So it's not just about the number itself, but...
It's about knowing the individual's baseline. Someone with a pre-existing neurological condition, they might always score a little lower on the GCS. That's their normal.
So a drop from their usual score, even if it's still technically within the normal range.
Could be a big red flag. It might mean their condition's getting worse, even if that lower number wouldn't raise eyebrows in someone else.
It's like you got to know where they started to understand where they are now.
Exactly. And that's why it's so important for everyone, no matter their age, to know their own normal vital signs, their health history, all that good stuff.
Knowledge is power, right? Especially when it comes to your health.
Absolutely. Knowing your body, understanding your own numbers, that's how you can advocate for yourself or even for your loved ones in a medical situation.
Man, this deep dive has really opened my eyes. I mean, we always hear that age is just a number, but in medicine,
It's a whole different story.
it's like the key to understanding what's truly normal and how to provide the right care at the right time. It really makes you think, as we all get older, how will our own normal vital signs change? And what can we do to stay informed, to be proactive about our health?
Great questions to ponder. It's a journey, for sure, but being aware and informed is half the battle.
Definitely food for thought. Thanks for diving deep with me today.
My pleasure. Always happy to geek out about medical stuff.
All right, let's jump right in today. We're taking a deep dive into something pretty fascinating. It's the Bronchoconstriction Medical Directive from the Ontario Ministry of Health.
Yeah.
Basically like a paramedic's go-to guide when they're dealing with someone having serious trouble breathing.
Right.
We're going to get into some pretty interesting stuff here, like dosages for different medications, all the ways they can actually give those medications.
Mm-hmm.
Have you ever heard of a NEB?
Hmm.
And then there's this kind of medical mystery. The document says paramedics can't use a nebulizer if the patient has a fever.
Oh, yeah, that's a good one. It's all about making those critical decisions when you're under a ton of pressure. So these directives, they basically lay out the rules for paramedics when they're in those situations where every second really does count.
Okay, so let's break it down. So this directive, it focuses on 3 main medications. Epinephrine, salbutamol, and then dexamethasone. And each section of the document, it's kind of like a cheat sheet for the paramedics, you know. It tells them when they should use each medication, when they absolutely shouldn't use it,
Right.
and then all the important details about like the right dosage and the different ways to give it to the patient.
It's like a specialized cookbook for dealing with airways that have just completely clamped shut.
Okay, so first up is epinephrine. Now, isn't this the same stuff that they use for like those really serious allergic reactions? But here it's like the first thing a paramedic would use if someone has completely stopped breathing. Why is that?
Well, epinephrine is what we call a bronchodilator. And it's actually a really powerful one. It's almost like it unlocks those airways and just forces them open really fast.
Hmm.
And when someone's not breathing, obviously, like, getting oxygen back into the system is the most important thing. So you really have to work quickly.
Oh, okay. That makes a lot of sense. So then we've got salbutamol. And this one has like a bunch of different ways it can be given. So you got the MDI, which I'm guessing is just like your regular inhaler.
Right.
Then there's the NEB or nebulizer. And then there's this thing called the BVM MDI adapter. Why are there so many options? Like,
Yep.
why not just use one method?
Well, imagine you've got a patient who literally can't breathe on their own. Like, an inhaler's not going to do anything. That's where this BVM adapter comes in. It lets you basically hook an inhaler up to what's called a bag valve mask. It's like one of those manual breathing bags.
Oh, okay.
So that lets you give the medication even when the patient, like, physically cannot breathe in on their own.
Wow, that's pretty incredible. So it's almost like you have like a backup for your backup.
Exactly. So each one of these methods, they have pros and cons. And which one the paramedic chooses really comes down to how bad the breathing problem is and the overall condition of the patient, right?
Yeah. Okay, so now dexamethasone, this one seems to be in its own category because the directive says it's only given once.
Right.
Why is that?
Well, dexamethasone is a steroid,
Mm-mm.
and it's more of a long-term solution, so it helps to reduce inflammation in the airways, whereas epinephrine and salbutamol, they're more for immediate relief. Think of it this way. Epinephrine is like jump-starting a car, salbutamol is like giving it a push, and dexamethasone is like taking it in for a full tune-up.
Oh, okay. So it's not just about like treating the symptoms.
Right.
It's also about like addressing the root of the problem.
Exactly.
Okay, so speaking of getting to the root of the problem, let's go back to that whole nebulizer mystery.
Okay.
If someone has a fever, why would that be like a no-go for using the nebulizer? Is it something to do with the actual medication?
It's not about the medication itself. It's more about the way that it's given. You see, nebulizers, they create this fine mist, right? And that's how the medicine gets into the lungs. But that same mist, it can spread germs. And obviously, when someone has a fever, there's a higher chance that they have an infection that could then be passed on to other people.
Oh, okay. So it's almost like infection control is built into their decision-making process.
Exactly. So they have to weigh the needs of the patient right in front of them against the risk of potentially spreading illness to other people, especially, if there's an outbreak going on or something like that.
Okay, so now let's look at the dosages because this is where things get really specific. It's not like everyone just gets the same amount. Right?
No, not at all. Dosages are very carefully calculated, especially for epinephrine, and it's mainly based on the patient's weight.
Oh, okay.
There are also maximum doses for each medication, to make sure that things stay safe. You wouldn't want to give an adult dose to a small child, for instance.
Right, of course. So it's almost like this delicate balance between giving enough of the medication to be effective,
Yeah.
but not so much that it could actually cause harm.
Yeah, that's a good way to put it. It requires a really deep understanding of not just the medications themselves, but also how the human body works.
So for epinephrine, the dosage is 0.01 milligrams per kilogram of body weight.
That seems like such a tiny amount. It is a small amount, but even tiny doses can have a huge impact, right? It's
Yeah.
all about getting the right amount to open up those airways without overdoing it.
Okay. And the maximum single dose is 0.5 milligrams, no matter how much the person weighs.
Exactly. Safety is paramount, right? And notice, even the document says that the dose should be rounded to the nearest 0.05 milligrams. I imagine that makes those on-the-spot calculations a bit easier when you're in a high-pressure situation.
Oh, that makes sense, yeah. So for salbutamol, paramedics have those three choices we talked about before, right? The MDI, the NED, and then that special BVM adapter thing.
Right.
Does the dosage change depending on which method they choose?
Yeah, absolutely. So the dosages, they vary depending on both the delivery method and the patient's weight, just like with epinephrine.
Okay, so for someone who weighs less than 25 kilograms, the maximum dose of salbutamol using an MDI is 600 micrograms,
Mm-hmm.
which is basically 6 puffs, since each puff is 100 micrograms, right?
Exactly. And if they're using a nebulizer instead, the maximum dose goes up to 2.5 milligrams for that same weight category.
Okay. And for someone 25 kilograms or more, the maximum MDI dose goes up to 800 micrograms,
Right, which is 8 puffs.
8 puffs. And then the nebulizer dose is 5 milligrams.
Yep, you got it. What's interesting here is that no matter how much the patient weighs or which method is used, salbutamol can be given every 5 to 15 minutes as needed,
Oh, wow.
up to a maximum of 3 doses.
Okay, so they have a lot of flexibility then in how they actually administer the salbutamol.
Yeah, they do. That's crucial when you're dealing with a situation that can change so quickly.
Right. Okay, so we've covered the basic dosages for both epinephrine and salbutamol, and we've talked about how those dosages can change based on the patient's weight and how the medication is given. Seems like a lot of this just comes down to really careful calculations and making really fast decisions when you're under pressure.
Yeah, I think you're picking up on something important here. This directive, it's not just a list of instructions. It's more like a framework for how to think critically in these really high-stakes situations.
It's like they're playing this high-stakes game of medical chess, They're constantly evaluating the situation. They're adapting their moves based on what's happening with the patient.
That's a great way to put it.
So we've covered 2 of the 3 medications that are in this directive.
Right.
Let's move on to dexamethasone and see how that one works. And maybe we can finally solve that nebulizer puzzle.
Sounds good. So before we jump into dexamethasone, remember we were looking at those dosage charts, right?
Yeah.
And how they're really specific to each patient.
All right.
There's this one entry that always kind of makes me pause, and it's the one about a pack year smoking history.
Yeah, that one was a little bit mysterious. It's not something you hear every day. What exactly is a pack year? And why does it matter when we're talking about this stuff?
Okay, so a pack year, it's basically a way to measure how much someone has smoked over their lifetime. And it takes into account both how much they smoke and for how long. So think of it like this. 1 pack year is equal to smoking 1 pack of cigarettes. So 20 cigarettes every single day for a year.
So if someone smoked like half a pack a day for 20 years, they would still have a 10-pack year history.
Exactly. So it's not just about the number of years, it's about the total amount of smoking.
Okay.
It's actually a pretty simple calculation. You just multiply the number of packs that they smoke every day by the number of years they've been smoking.
Okay, the math makes sense. But why is this pack year history important for paramedics when they're dealing with someone having trouble breathing?
Okay, so this is where it gets interesting. The directive specifically mentions that dexamethasone should be considered for patients who have a history of asthma, COPD, or a 20-pack year smoking history.
Wait, so even if someone isn't having an asthma attack right now, just their smoking history alone could mean that they would get dexamethasone?
Exactly. It's about recognizing that smoking, especially heavily over a long period of time, it can really damage the lungs, and it can make them much more prone to inflammation and those constricted airways that we've been talking about.
So the dexamethasone, it helps to kind of calm that inflammation down and open things up, even if they're not having like an active asthma attack at that moment.
Exactly, you got it. So it's really addressing that underlying damage that can lead to these problems.
I'm starting to see how paramedics are almost like detectives. They're putting together all these clues about the patient's lungs,
Yeah.
and pack years are just one piece of that puzzle.
Yeah. It's fascinating to me that these directives, they really encourage paramedics to think beyond just the immediate crisis. They have to consider the patient's history, their lifestyle, all these factors that might be playing a role.
Yeah, they're always thinking a few steps ahead then, looking for those clues that can help them anticipate any potential problems based on, like, the patient's medical history, right? It's like they're always preparing for a worst-case scenario, even while they're dealing with the current one.
Right. And remember, this isn't just about following instructions from a book. They're using their knowledge, their experience, and their critical thinking skills to make these really important decisions in real time.
Right, because knowledge is power, right? The more information a paramedic has about the patient, the better equipped they are to make those life-saving decisions.
Absolutely. And that's exactly why these medical directives are so important. They provide a framework for making those decisions, especially in these high-pressure situations. And it makes sure that paramedics across Ontario are giving the same quality of care to every patient every single time.
Okay, let's go back to the different ways to give salbutamol, the MDI, the NEB, and then that BVM MDI adapter. Can you remind us again what each one of those is? And why would a paramedic choose one over the others? It seems like having so many options could be really overwhelming if you're in an emergency situation.
I see your point, but having these options actually gives paramedics the flexibility to really tailor the treatment to each situation. So the MDI, that's your typical inhaler. You know, that small handheld device that delivers a measured dose of medication with every puff. Pretty much everyone's seen one of those before, right?
Yeah, like the classic
Right,
inhaler.
right. And then the NEB, which is short for nebulizer, that one turns liquid medication into a fine mist that you inhale through a mask or a mouthpiece.
Okay.
It's basically delivering a higher dose of the medication over a longer period of time. So that makes it really helpful for patients who are having a really hard time breathing on their own.
So it's like stepping up the treatment when a regular inhaler just isn't enough.
Exactly. And then there's that BVM MDI adapter we keep talking about.
Right.
Remember those bag valve masks, the ones that help a patient breathe when they can't do it themselves? This adapter lets paramedics connect an MDI right to that mask so they can deliver the medication straight to the lungs, even when the patient can't inhale on their own.
Oh, okay. So it's almost like a last resort then, when someone is in really, really bad shape.
Yeah, you could think of it that way, and it really highlights how adaptable and resourceful paramedics have to be. They're trained to handle so many different challenges. And these medical directives give them the tools and the knowledge to make the best possible choices for their patients.
It seems like paramedics need a really high level of skill and knowledge, especially when you're looking at all these different delivery methods. It's not just about following a checklist, is it? It's about understanding the nuances of each method and knowing when to use which one.
Absolutely. Paramedics aren't just blindly following instructions. They're constantly assessing the situation and making decisions based on what they're seeing and how the patient is responding.
It really is like they're medical detectives, like we said before. They're putting together all these clues to figure out the best way to help each individual patient. It's a lot more complicated than I think most people realize.
It is, and they're doing all of this under incredible pressure, knowing that their decisions could actually mean the difference between life and death.
Okay, so we've talked about the medications, the dosages, all the different ways to give the medications. We talked about pack years and how important that is for understanding lung health.
Mm-hmm.
Is there anything else in this bronchoconstriction directive that really stands out to you?
There is one more interesting detail that's worth mentioning. So the document specifically says that nebulization is contraindicated in patients with a known or suspected fever, or during a declared febrile respiratory illness outbreak.
Wait, so you're saying if someone has a fever, paramedics can't use a nebulizer on them? That seems kind of counterintuitive. Why is that?
That's a great question. And it brings us back to something we talked about earlier, the risk of spreading germs.
Oh, right.
Nebulizers, they create that fine mist, right?
Wow.
And while that's great for getting medicine into the lungs, it can also spread those tiny droplets that carry germs. And when someone has a fever, there's a good chance they've got an infection that could be spread to other people.
So it's like a precaution, especially during outbreaks, to protect not just the patient, but everyone else too.
Exactly. It's all part of the bigger picture. Paramedics aren't just treating individuals, they're playing a crucial role in protecting public health.
I'm realizing just how much responsibility they have. It's not just about medical knowledge. It's about ethics and understanding how their actions can impact other people.
That's a great point. It takes a very special kind of person to be a paramedic. Someone who can handle the pressure, the uncertainty, and the weight of knowing that their decisions have real consequences.
Yeah. We've covered a lot of ground today. We went from deciphering medical terminology to like understanding really specific drug dosages and how they're given. And even the whole concept of pack years and public health. I have a much better appreciation for these medical directives now.
Me too. They represent the collective knowledge of all these medical professionals who are dedicated to making sure that patients in Ontario get the best possible care. It's almost like having a whole team of experts out there in the field with those paramedics guiding them.
Yeah, it's been a really fascinating deep dive into the world of paramedics. I have so much respect for the work they do and all the knowledge they have to have.
Absolutely. It's a real privilege to get a glimpse into what they do and understand the incredible challenges they face every day and the skills they have to handle those situations.
Okay, before we wrap up, I want to go back to that pack year thing again. It really got me thinking about the long-term effects of smoking and how difficult it must be to treat those lung conditions that develop over time.
That's a really good point. And it really speaks to the bigger issue of public health and prevention. Maybe this deep dive will inspire you to learn more about those things.
Yeah, absolutely. There's always more to learn and more to explore. But for now, this is the end of our deep dive into the bronchoconstriction medical directive.
It's amazing, right? All the things that paramedics have to know and all the decisions they have to make out in the field.
Yeah, it really is.
Like so much responsibility.
They're the ones on the front lines, literally, dealing with these really intense situations. And they have to, think on their feet and make those decisions that could, saves someone's life.
And we've covered so much in this deep dive. Like, remember at the beginning when we were trying to figure out all that medical jargon?
Yeah.
And then we got into the nitty-gritty of, like, how much of each medication to give.
Right, and all the different ways to give the medications?
Yeah, I never realized there were so many different ways to, like, get salbutamol into someone's lungs.
And the way they have to, like, tailor the treatment for each patient based on their weight and their medical history and even, like, how much they've smoked with that whole pack year calculation.
Right, right. And then don't forget about that nebulizer thing. Oh, yeah.
It's kind of crazy that if someone has a fever, paramedics can't use a nebulizer, right?
It is. But it shows that they're not just focused on the patient right in front of them.
Right.
They also have to think about the bigger picture, like public health and preventing the spread of infections.
So it's been a pretty wild ride, hasn't it? What do you think is the biggest takeaway from all of this?
I think for me, it's just like a newfound appreciation for paramedics and everything they do. They have to know so much, and they have to be able to use that knowledge in these incredibly stressful situations.
Yeah, I totally agree. It's like next time you see a paramedic, you should just like give them a nod or something.
Yeah.
They really are
Yeah.
like the unsung heroes of healthcare.
And if anyone listening is feeling, inspired after this deep dive, I'd say just keep learning and keep exploring these topics. Like, we touched on the effects of smoking on the lungs. There's a ton of information out there about respiratory illnesses, too.
Right. That's what we always hope for with these deep dives. Just to like spark people's curiosity and get them thinking about these things.
Oh, exactly.
So that's it for our deep dive into the Bronchoconstriction Medical Directive.
Thanks for listening, everyone.
We'll catch you on the next one. Welcome back, everyone. Today, we're going deep into something you probably haven't seen before.
Yeah, this is pretty cool.
We're looking at the guidelines for paramedics in Ontario, specifically how they deal with cardiac ischemia.
Out in the field,
Yeah.
Yeah.
Talk about high-pressure situations.
Yeah.
And we're going to see what medications they use and how they make those split-second decisions.
It's all laid out in this medical directive. It's like their playbook, right?
Like their Bible.
Yeah.
I mean, this isn't something the average person ever comes across.
Nope. But it dictates how they use some serious drugs like nitroglycerin, aspirin, even when things are really intense.
Okay, so paint the picture for our listeners who, maybe aren't doctors. Someone's got chest pain, they think they're having a heart attack. Paramedics arrive.
Yeah.
This directive is what guides them, right?
Exactly. You might think, oh, chest pain, give him some nitro. Pretty simple.
Makes sense to me.
But there are actually very specific conditions that need to be met before the paramedics can administer it.
Oh, real?
It's not just about giving the medication, it's about making sure it's safe and appropriate for that individual patient.
So it's like a decision tree then.
Right.
They're running through a checklist in their heads. What kind of things are we talking about?
So they're checking the patient's age, right? Their heart rate, blood pressure, whether they've used nitro recently.
Wow.
They're also checking if the patient has an IV line in place, that's an intravenous line, to deliver medication directly into the bloodstream.
Okay.
And there are some medications you can't give nitro alongside, like some of the medications used for erectile dysfunction, because it can cause a really dangerous drop in blood pressure.
Oh, wow. I had no idea.
Yeah. So it's all about understanding the interactions between different drugs and the potential risks.
So even in an emergency, there's this whole thought process, this methodical approach.
Absolutely.
Never realized how much goes into it. But earlier you mentioned nitro can actually be dangerous in some cases. Seems kind of counterintuitive, right?
It is. See, we tend to think of a heart attack as just one thing, but there are different types.
Okay.
And one that's particularly tricky is a right ventricular myocardial infarction. So that's where the blockage is specifically affecting the right ventricle of the heart.
Hold on. Just to refresh my memory.
Yeah.
What does the right ventricle do again?
So the right ventricle pumps blood to the lungs to pick up oxygen.
Right, of course.
Now, here's the thing. Nitroglycerin, which usually helps by widening blood vessels,
Yeah.
it can actually make things worse in a right ventricular MI.
Really? How so?
Well, because it lowers blood pressure. The right ventricle is already having a tough time pumping blood because of the blockage. If you then go and drop the blood pressure with nitro, you're basically cutting back the amount of blood returning to the heart. And that can make the blood flow to the right ventricle even worse. Like you're cutting off its supply line even more.
That's interesting. So how do paramedics even know if it's this specific type of heart attack?
That's where the 12-lead ECG comes in. It's basically like a map of the heart's electrical activity.
Right.
And it can show which part of the heart is affected. This directive, it emphasizes how important it is to get this ECG done fast, within 10 minutes if possible.
Wow. Every minute counts. Is there anything specific they look for on the ECG to diagnose this particular type of heart attack?
Absolutely. There's a specific lead on the ECG called V4R.
V4R.
Yeah. It's placed on the right side of the chest. This lead gives a unique view of the right ventricle's electrical activity. It can pick up on subtle changes that you might otherwise miss.
So it's kind of like having a magnifying glass, just on that area of the heart.
Precisely.
Fascinating. We've talked about nitro. Let's talk about aspirin. Now, everyone knows aspirin is often given for suspected heart attacks, but the directive mentions situations where it shouldn't be used. Why is that?
Well, aspirin's great for preventing blood clots.
Right.
But there are times when it can cause more problems than it solves. For instance, if someone has a bleed, giving them aspirin could make it worse.
Oh, I see.
Same goes for someone who's recently had a stroke or even a head injury. Aspirin could increase the risk of bleeding.
So even something like aspirin, an over-the-counter medication,
Yeah.
has all these rules for its use in an emergency.
Absolutely.
It really shows how complex these decisions are that paramedics have to make.
Right. They have to weigh the benefits against the risks, all while acting quickly under pressure. It's a tough job.
It really is.
Yeah.
So for our listeners, what's the key takeaway here? What should they remember from all this?
I think the biggest thing is just how important standardized protocols and clear guidelines are in emergency medicine.
Yeah.
You know, this medical directive, while it's specific to Ontario paramedics, it really shows the thought process that goes behind even what seems like a simple treatment.
Absolutely.
It's a good reminder that paramedics are highly trained professionals. They use evidence-based practices to make these life-saving decisions.
It definitely makes you appreciate their work even more. And it makes you wonder what kind of decision trees are behind all sorts of other medical treatments, right?
Absolutely. You know, it highlights how even what seem like simple medical decisions, they're often based on a lot of different factors and considerations. It's pretty amazing.
It is. It is. Thanks for this deep dive. It's been really eye-opening.
My pleasure.
Until next time.
See ya.
Bye. Ever try to catch your breath after, like, I don't know, maybe sprinting up a flight of stairs or something?
Oh, yeah, definitely.
So now imagine that, but like way worse.
Oh, wow.
That feeling of just like air hunger, really not being able to breathe,
Yeah.
it can be super scary.
Yeah, I bet.
That's basically what pulmonary edema is.
Okay.
It's when fluid builds up in your lungs
Uh-huh.
and it makes it really, really hard to breathe. And today, we're going even deeper, talking about a specific kind of pulmonary edema.
Okay.
It's called acute cardiogenic pulmonary edema.
All right.
And it's basically when that fluid buildup is happening because there's a problem with your heart.
I see.
So it can be really serious.
Yeah.
It can be a life-threatening situation. And so what we're going to do is we're going to take a look at how paramedics in Ontario are trained to deal with this.
Cool.
And get this,
Yeah.
one of the things that they use to treat this is something that you might associate more with like dynamite than saving lives.
Oh, really?
Nitroglycerin.
Wow.
Yeah. So we've got the Ontario Ministry of Health's guidelines for paramedics right here.
Perfect. Oh.
And yeah, let's just dive right in.
Yeah, let's do it. That association with dynamite is interesting, for sure. Like, how does that even work?
Yeah, right?
It's not like they're, blowing something up to fix
Well,
it.
exactly. So imagine this, right?
Okay.
Sirens blaring. Paramedic shows up at a scene. Somebody's having trouble breathing. Now, you might think, okay, their main job is just get that person to the hospital as quickly as possible.
Yeah, seems logical.
Right?
Right?
Get them to the experts.
But there's a lot more to it than that.
Real.
There's so much more.
Oh, interesting.
Because paramedics, they're like mini emergency rooms.
Oh, wow.
They can do so much more than just transport somebody.
I see, yeah.
Wow.
Makes sense. They're often the first on the scene.
Exactly. So they have to be prepared to provide that critical care right on the spot.
Right.
They follow these super specific protocols. They're called medical directives.
And basically what those are very, very detailed instructions for how to handle different medical emergencies.
So like a rule book for different situations.
Exactly.
Yeah, okay, got it.
And the one that we're looking at today is the medical directive for using nitroglycerin for suspected acute cardiogenic pulmonary edema.
Okay, lots of big words in there.
I know.
We should probably unpack that a bit.
Yeah, we should. So first of all, we're not talking about just like a little bit of shortness of breath.
Okay.
The guidelines specifically talk about moderate to severe respiratory distress.
So like really struggling to breathe.
Oh,
Can
yeah.
you give me a picture of what that looks like?
Yeah, so like imagine somebody gasping for air, like every breath is a struggle.
Oh, wow.
Their chest is heaving.
Hmm.
They're really working hard to try and get air in.
Yeah, I can see how that would be really scary.
Definitely. And when we say suspected acute cardiogenic pulmonary edema, basically what we mean is that the heart is not pumping blood efficiently.
Okay.
And as a result, fluid starts backing up into the lungs.
So like a traffic jam, but in your blood vessels.
Exactly. Perfect analogy.
So, okay, I get the picture now. Someone is in serious trouble, they can't breathe, and it's all because their heart isn't doing its job properly.
Exactly.
But I'm still stuck on this nitroglycerin thing.
Yeah.
Isn't that like the stuff in dynamite?
It is.
So how does that help someone who's basically drowning in their own fluids?
That's a great question. And it seems counterintuitive, right?
Yeah, especially because isn't nitroglycerin supposed to lower blood pressure? Wouldn't that be dangerous in this situation?
Right. You would think.
So what's the deal?
Okay. So there's a delicate balance here. While low blood pressure can definitely be a concern, the immediate danger in acute cardiogenic pulmonary edema is the strain on the heart and that fluid backup in the lungs.
Okay, so it's a trade-off.
Exactly.
You're trying to fix the bigger problem.
Yeah.
Okay.
And the way nitroglycerin helps is that it relaxes and widens the blood vessels.
Okay, so it's like creating more space for the blood to flow, so the heart doesn't have to work so hard.
Exactly. It's like a pressure release valve, basically.
That makes a lot more sense. So it's not about blowing up the problem, it's about opening things up.
Yeah.
Okay, got it.
It gives the heart a chance to pump more efficiently, and it lets the lungs start to clear out some of that fluid.
So how do paramedics know when it's safe to use nitroglycerin? Like, are there specific guidelines or something?
Oh, absolutely. Yeah.
Hmm.
The medical directive, it outlines some very clear conditions that have to be met. So first and foremost, the patient has to be over 18.
Okay, so adults only. Makes sense.
Right. Then they check the heart rate, and it has to be between 60 and 159 beats per minute.
So not too fast, not too slow.
Right. Right in the sweet spot.
Yeah.
And their blood pressure also needs to be in a normal range. We call that normotensive.
Okay, so no crazy fluctuations in either direction.
Exactly, yeah.
It sounds like a pretty detailed checklist.
Yeah, there's a lot of factors to consider.
Are there situations where they absolutely shouldn't give nitroglycerin?
Yeah, good question. So there are contraindications, that's what we call them.
Okay.
And that basically means situations where nitroglycerin could actually be harmful.
So red flags, basically.
Exactly. So, for example, if the patient is allergic to nitrates,
Okay, that makes sense.
obviously, or if they've taken certain medications like phosphodiesterase inhibitors within the last 48 hours.
I see. So some drugs just don't mix.
Exactly. It could cause a really dangerous interaction.
So let me get this straight. If someone is having trouble breathing and their heart isn't working properly and they're over 18, their heart rate and blood pressure are normal, and there are no allergies or weird drug interactions, then it's time to think about the nitroglycerin.
Yeah, basically, that's when this really cool decision tree comes in.
Decision tree.
Yeah. Think of it like a flea chart.
Okay, so it guides the paramedic through the steps.
Exactly. So first, they look at the patient's systolic blood pressure.
That's the top number, right?
Yeah, it's the top number. And if it's below 140, they give a lower dose of nitro, either 0.3 or 0.4 milligrams, depending on the type of tablet they're using.
Okay, so lower blood pressure, lower dose.
Yeah.
What if the blood pressure is higher, though?
Then they have to consider the patient's history with nitroglycerin.
Okay.
So, like, have they been using it regularly?
Right.
Are they currently on, like, an IV drip of nitroglycerin?
I see.
Because if someone's been taking it regularly, they might need a higher dose because their body's gotten used to it.
So they've built up a tolerance.
Exactly, yeah.
So in those cases, they might get a higher dose.
Yeah, up to 0.8 milligrams.
Yeah.
But of course, always being very, very careful, watching out for side effects like a sudden drop in blood pressure.
Right, of course. Safety first.
Always.
This is all super interesting. But I still keep coming back to the fact that we're talking about the same stuff that's in dynamite.
I know, it's wild, right?
How did anyone even figure out that this could be used to help people with heart problems?
Well, it's a funny story, actually. Back in the 1800s, people who worked in factories that made nitroglycerin noticed that they got headaches and dizziness.
From handling the dynamite.
Yeah, they would actually absorb it through their skin. And some of them even noticed that it relieved their angina, which is chest pain caused by reduced blood flow to the heart.
So they accidentally discovered its medical benefits.
Pretty much.
Yeah.
And over time, scientists figured out how to use it safely and effectively for different heart conditions.
It's amazing how something so potentially dangerous can be so helpful in the right hands.
It really is.
And in the right doses, obviously.
Exactly. So we've talked about how paramedics use these detailed guidelines, their extensive training, and yeah, even something as crazy as nitroglycerin to manage acute cardiogenic pulmonary edema.
It's a lot to take in, for sure.
It really is.
But it's also fascinating to see how paramedics make these split-second decisions in such high-pressure situations.
It really is.
And they have to consider so many factors.
They do, yeah.
It's not just about checking boxes on a list. They have to use their judgment.
Right. Like, what if the patient is really anxious or scared?
Exactly. Or what if they're in a lot of pain? Those things matter, too.
They do, yeah. And sometimes even the environment itself can be a factor, right?
Oh, yeah.
Imagine trying to provide care in a tiny, cramped space or in the middle of like a chaotic scene, with lots of distractions.
It makes you really appreciate the challenges that paramedics face every day.
It does. And it really makes you wonder, what are all those other factors that a paramedic has to weigh?
Yeah, beyond just the medical guidelines.
Exactly. Beyond the textbook stuff.
Mm-hmm.
Like what goes into those split-second decisions in a real-life emergency?
It's a question that really gets at the heart of what it means to be a paramedic, I think. It's about combining knowledge with experience and compassion.
Absolutely.
It's about making tough calls in the face of uncertainty.
It's true. Well, this has been really fascinating. Thanks for joining me for this deep dive.
My pleasure. Always happy to talk about the amazing work that paramedics do.
Me too. Until next time, folks. Okay, so welcome back for another deep dive into some fascinating stuff that we found.
Yeah.
So today we're going to be looking at emergency medical care in Ontario, Canada.
Right.
And specifically, we're focusing on adults
Okay.
who are experiencing both a STEMI heart attack and cardiogenic shock.
Wow.
And our source material is a medical directive straight from the Ontario Ministry of Health for paramedics.
Oh, cool.
So
This is like a literal
Yeah.
peek behind the curtain.
yeah, it's a peek behind the curtain to see
Yeah.
what they're actually doing in the field when lives are on the line.
This will be good.
Yeah.
Yeah, I mean, these directives, they provide, clear guidance
Mhm.
in like really high pressure situations. Like,
Right.
imagine arriving on scene and your patient is in immense pain.
Yeah.
Blood pressure's plummeting.
Right.
These directives give paramedics a roadmap to follow.
Yeah, they really do.
Yeah.
And it really
Yeah.
paints a picture of the gravity of the situation.
Right.
Because we're not just talking about any heart attack here.
Yeah.
We're talking about a STEMI, which has a particular EKG signature.
Right. Yeah.
And then on top of that, they're also experiencing cardiogenic shock,
Okay.
meaning that the heart is struggling to pump blood effectively.
Oh, wow.
So what makes this combination so dangerous?
Well, it's like a perfect storm, really.
Okay.
The STEMI itself, indicates a serious blockage in
Yeah.
a major coronary artery.
Right.
And that's cutting off the blood supply to a large section of the heart.
So part of the heart is basically
Yeah, it's not
bad.
getting the blood it needs.
right.
And then with cardiogenic shock on top of that, you've got a heart that's already been weakened by the attack.
All right.
And now it's unable to maintain adequate blood flow to the rest of the body.
Wow.
So then the vital organs start to shut
Oh
down.
my God.
And time becomes absolutely critical.
Yeah, this sounds very serious.
Very serious.
So the directive mentions clear chest auscultation as a key factor.
Right.
Can you clarify what that means
Yes.
and why it's so important?
So auscultation just means listening with a stethoscope.
Okay.
So clear chest auscultation means that the paramedic isn't hearing any abnormal sounds in the lungs.
Okay.
So think about it.
Yeah.
Someone in shock could be struggling to breathe for any number of reasons.
Right.
It could be a collapsed lung fluid buildup,
All sorts of things.
any number of things.
Yeah.
But in this specific case, we're looking at the heart as the primary culprit.
Okay.
So that clear chest tells the paramedic that they can focus their efforts on treating the cardiogenic shock.
So it helps them narrow down the problem
Exactly.
immediately.
Yeah.
Fascinating.
Yeah.
Okay. So let's get into the treatment
Yeah.
that's laid out in this directive.
Yeah.
It mentions a saline fluid bolus,
Yeah. Okay.
and the directive is super precise.
Okay.
10 milligrams per kilogram of body weight.
Okay.
Reassess every 250 milliliter administered
Right.
with a hard limit of 1,000 milliliter.
Okay.
So what's the rationale behind this approach?
So the saline fluid bolus is essentially a rapid infusion of fluid directly into the bloodstream.
Okay.
And the goal is to increase the volume of blood circulating in the body.
So they're basically trying to get more blood flowing.
Exactly.
Those
Yeah,
being-
like imagine a pump struggling to push water through a system of pipes.
Okay.
If there isn't enough water, the pressure drops.
Right.
So by adding more fluid,
Uh-huh.
we're trying to boost that pressure and get the blood flowing more effectively to those vital organs.
So like priming the pump, basically.
Yeah, exactly.
But why the reassessment after every 250 milliliter,
Right.
and especially that maximum limit?
Okay. Yeah.
Because it seems counterintuitive.
Yeah.
Like, wouldn't more fluid always be better?
Well, that's where the complexity of cardiogenic shock comes in.
Okay.
You're absolutely right. In some situations, more fluid might be the answer.
Ah,
But in this case, we have a heart that's already weakened and struggling.
Right, yeah.
So flooding it with too much fluid can actually overload it, making it work harder and potentially causing more harm than good.
so it's like trying to fill a leaky bucket.
Exactly.
You have to pour carefully,
Yeah, you got to be careful.
or you'll just make the problem worse.
Exactly.
Now, another thing that jumps out is the age restriction.
Okay.
This directive is only for adults 18 and older.
Right.
So why is that?
That's a great observation.
Thanks.
Children and adolescents have very different physiological responses to shock,
Okay.
and their bodies handle fluid administration differently.
Right.
Their circulatory systems are still developing, their hearts are smaller,
Yeah.
and what might be a beneficial amount of fluid for an adult could be overwhelming for a younger patient.
Yeah. That makes sense.
Yeah. So paramedics need to follow a completely different set of guidelines for pediatric cases.
So it's important to follow the guidelines and know who you're dealing with.
Absolutely.
Okay, cool. So it really highlights the delicate balance paramedics have to strike
Yes.
in these situations.
It's true.
They have to be decisive, yet constantly evaluating and adjusting their approach
Yeah,
based on the patient's specific needs.
precisely. And while this directive provides a solid framework,
Yeah.
there's always more to consider.
Right.
The patient's overall health,
Uh-huh.
their medical history, even the environment they're in.
Oh, wow.
All these factors can influence the paramedic's decision-making.
It's incredible to see how much goes into providing effective emergency care.
It is. It's amazing.
And that brings me to a question for you, our listeners.
Okay.
Knowing that every second counts in these scenarios,
Right.
what other factors do you think paramedics need to consider when making those split-second life-saving decisions?
Yeah. What do you think?
Leave us your thoughts in the comments below,
Yeah.
and we'll see you next time for another deep dive.
See ya.
Bye.
Bye.
All right. Ever wonder what guidelines paramedics use out in the field, like for something like CPAP?
Oh, yeah, absolutely. It's fascinating, right?
Totally. Today, we got this really interesting document from the Ontario Ministry of Health, and it's all about their CPAP medical directive for paramedics. So we're gonna do a deep dive.
Awesome.
So first things first, for anyone who might not know, what exactly is CPAP? I mean, we hear it all the time, but
Right. So CPAP stands for continuous positive airway pressure, and it's basically a way to deliver constant air pressure to help a patient breathe. It's like giving their lungs a little extra support.
makes sense. So are we talking about all our paramedics in Ontario using this?
Mhm.
Or is it more specific?
Good question. This particular directive is specifically for primary care paramedics. They're the folks who are usually first on the scene.
Right, the front line. So they're making some pretty critical decisions. And this document is like their guidebook for CPAP, right?
Exactly. It lays out very specific guidelines for when they can and cannot use CPAP. And it's important to note, it's only for adult patients, 18 years or older.
Okay, so adults only. So when we talk about these guidelines, when exactly would a paramedic decide that CPAP is the right move? What are they looking for in a patient?
They need to see two main things. First, the patient has to be in severe respiratory distress, like they're really struggling to breathe.
Got it. So it's not just like mild breathing difficulty. It has to be serious.
Exactly. And the second thing is there need to be signs of certain conditions like acute pulmonary edema or COPD.
Okay, so that's where the specific conditions come in. Now, for our listeners who might not be familiar with those, can you break those down a bit? Like, what is pulmonary edema and what makes it so serious that it might require CPAP?
Sure. So pulmonary edema is basically a buildup of fluid in the lungs. It's almost like the lungs are drowning.
Wow, that's intense.
Yeah, and this fluid, it prevents oxygen from getting into the bloodstream. And that's obviously a huge problem. What CPAP does is it increases the pressure in the lungs, and that forces the fluid back into the capillaries.
So it's like pushing that fluid out of the way so the oxygen can get through.
Exactly.
And what about COPD?
COPD, or chronic obstructive pulmonary disease, is a group of lung diseases. They're usually caused by long-term damage to the lungs, making airflow difficult.
Like damage from smoking, for example.
Right, smoking is a common cause,
I-
but there are others too.
So how does CPAP help with COPD?
Imagine trying to breathe through a straw. That's kind of the resistance someone with COPD faces. CPAP helps by providing that extra pressure to overcome that resistance and make breathing easier.
So in both of these cases, pulmonary edema and COPD, CPAP is all about improving oxygen intake. That makes a lot of sense. But I'm guessing there are also times when using CPAP would not be a good idea.
Oh, absolutely. The directive is very clear about situations where CPAP is a no-go. We call these contraindications.
Okay, so like red flags, basically. When would a paramedic see those red flags and know not to use CPAP?
Well, for example, if a patient is having an asthma attack, CPAP could actually make things worse.
Really? Why is that?
Because asthma involves constricted airways. CPAP increases pressure, which could further restrict airflow.
Ah, I see. So it's like squeezing an already narrow tube.
Exactly. Another big one is a pneumothorax or a collapsed lung. CPAP would just make that worse too.
Because it's pushing more air into a lung that's already having trouble.
Right. And of course, if someone has an unstable airway or they're unconscious and can't cooperate, CPAP is off the table.
That makes sense. I noticed the directive also lists some pretty specific situations like major trauma to the head or torso, tracheostomy.
Right. Those are all situations where CPAP could be dangerous.
So a lot for a paramedic to consider.
Absolutely. They have to make a quick assessment and decide whether CPAP is the right call.
Okay, so let's say the paramedic considered everything and decides that CPAP IS appropriate. What happens next? How do they actually administer it?
Well, the directive lays out the steps. They start with a CPAP setting of 5 centimeters of water pressure. That's often written as centimeters H2O.
Okay, 5 centimeter H2O to start.
Right. And then, if needed, they can increase the pressure in increments. Every 5 minutes, they can go up by 2.5 centimeters H2O, but the maximum is 15 centimeter H2O.
So they're carefully monitoring the patient and adjusting as needed.
Exactly. There's also this interesting part that mentions adjusting the flow rate as directed by RBHP.
RBHP, what's that?
It's not actually defined in this document. It could be a regional base hospital program or some other internal guideline.
Huh. A bit of a mystery then.
Yeah, but it shows how much specialized knowledge paramedics need to have.
Absolutely. It's like there's this whole other layer of protocols and procedures behind the scenes.
Definitely. And along with adjusting the CPAP pressure, they also have to keep a close eye on the patient's oxygen levels. Sometimes they might need to give supplemental oxygen along with the CPAP.
Right, the directive mentions FiO2.
Yes. FiO2 stands for fraction of inspired oxygen, which basically means the concentration of oxygen the patient is breathing in.
Okay, so by adjusting the FiO2, they're basically fine-tuning the amount of oxygen the patient gets.
Exactly. It's crucial because too little oxygen is obviously bad, but too much oxygen can also be harmful in some cases.
A delicate balance then. So do they have specific starting points for FiO2?
The directive says they can start anywhere from 50% to 100% and then adjust based on the patient's response. If the oxygen saturation stays below 92%, they can increase the FiO2.
And the maximum is 100%.
Right.
There's also this part about confirming the pressure with a manometer if one is available. What's a manometer?
It's just a device for measuring pressure, so it's like a double check, making sure the CPAP pressure is accurate.
But it sounds like they might not always have one on hand.
Yeah, it says if available.
Yeah.
So maybe not every ambulance is fully equipped.
Interesting. So, big picture, what does all this tell us about how paramedics use CPAP?
Well, it's obviously a really valuable tool, but it's not something they take lightly.
They have to be so careful.
Exactly. They have to understand all the ins and outs, know when it's appropriate and when it's not.
And they have to know how to use it safely and effectively. It's a lot of responsibility.
Definitely. Paramedics have a tough job.
Absolutely. We've covered a lot today. We've seen the what's and the how of this CPAP directive. But I think it raises a bigger question, doesn't it? The why. Why are these rules so specific? What are the potential consequences if CPAP is used incorrectly? That's something for our listeners to ponder. Thanks for joining us for another deep dive.
My pleasure. Until next time.
All right, everyone, welcome back for another deep dive. You know that sound, right? That like just awful barking cough that just like takes you back to those like late nights with a sick kid or even to your own childhood, maybe?
Yeah.
It's Kroops, and today we're going to go a little bit beyond, the vapor rubs and the humidifiers.
Right.
And we're going to really look at how paramedics tackle this
Okay.
really common but pretty scary childhood ailment. And we're using the Ontario Ministry of Health guidelines for paramedic treatment of croup as our guide for this one.
Sounds good. So
Excited.
to look at these.
I think what's so interesting about these guidelines is that they give us a little glimpse into the quick decisions that paramedics have to make in the field.
Yeah.
It's not just about treatment. It's about that balance between urgent care
Right.
and making sure that the child is absolutely safe.
Yeah, that's a really good point. They have to think on their feet and make these really important decisions quickly.
Exactly. So let's jump right in.
Oh,
This indication section kind of goes right into what paramedics are looking for. And, it's no surprise here. It's that history of a respiratory infection
Right.
paired with that, like, unmistakable
That classic croupy
cough. Yeah.
But what I'm curious about is, are there any other conditions that can kind of mimic croup, and how do paramedics, like, rule those out?
That's a great question.
Yeah.
While the cough is, like you said, really a hallmark of croup,
Right.
there are other conditions that can present similarly. And one of those is epiglottitis.
Oh, gosh. Yeah, I heard of that one.
Yeah, it's the inflammation of the tissue
Yeah.
above the vocal cords. And it can sound very similar to croup, but it's much more serious. Yeah. And can actually obstruct breathing entirely.
Oh, wow.
So paramedics are trained to assess the child's overall condition, looking for signs of distress beyond just the cough, to make those really critical distinctions.
Right. So they have to look at the whole picture.
Exactly, not just focus on that one symptom. Okay. Yeah, that makes a lot of sense. So let's get to the action part, the treatment section. It outlines 2 medications.
Right.
Epinephrine, it's also known as adrenaline,
right,
and dexamethasone, which is a steroid. So it's kind of like we're hitting croup with a quick-acting airway opener and a longer-term inflammation reducer.
Yeah, like a 1-2 punch.
Yeah. Why this combo?
So that's a good question. Croup is essentially, an inflammation of the airways. And in children, their airways are much narrower to begin with. So you've got this swelling in an already tiny space, making it really hard to breathe. So epinephrine works really fast to open up those airways, offer immediate relief, while dexamethasone kind of works in the background to calm the inflammation down.
Okay. So one's like the immediate, and then the other one's kind of the...
Exact, the long game.
Long game, yeah.
Okay. Now, this is where I got really curious.
Good.
The dosage for epinephrine is incredibly specific, and it's based on the child's weight.
So, for instance, a child under 10 kilograms is a much smaller dose than a child over 10 kilograms. Why such precise measurements, especially?
That's a great question, and it's really important. In a high-pressure situation, it all comes down to safety and effectiveness. Children aren't just, small adults. Their bodies process medications differently.
Right.
Too much epinephrine can have adverse effects, especially on their heart rate. So these weight-based dosages are designed to deliver the right amount of medication to be effective, but also to minimize any potential risks.
So they have to be really careful.
Exactly. It's a delicate balance.
Yeah. It's amazing how much goes into these seemingly simple guidelines. And here's another thing that stood out to me.
Okay.
Both medications are limited to a single dose.
Right.
So it's not a cure. It's more like buying time.
You got it. That's exactly right. Think of it as stabilizing the situation. Paramedics are trained to administer these medications, assess the child's response, and if needed, transport them to a hospital for further evaluation and treatment. So it's all about teamwork, with the paramedics providing that initial critical care.
Okay, so they're starting the process.
Exactly.
And then sending them on to the next.
Yeah, handing it off to the experts at the hospital.
Right. Okay, that makes sense. All right, let's move on to the contraindications section. And this is pretty straightforward. Allergies, recent steroid use.
Right.
Basically situations where giving those meds could do more harm than good.
Yeah, absolutely.
But this made me wonder, are there other situations where even with a croup diagnosis, paramedics wouldn't administer either medication?
Yes, definitely. Remember, these guidelines provide a framework, but every child's is different. So let's say a child has a known heart condition. In that case, administering epinephrine, even at a low dose, could be risky. So paramedics are trained to consider each child's, medical history and current state, making a judgment call based on all the factors involved.
Oh, it really is, taking all of that.
It is. It's really individualized medicine.
Into account.
Yeah.
Okay, yeah. So we've learned that paramedics approach croup with this 2-pronged treatment strategy, aiming to open airways quickly Yeah. Reduce inflammation over time, all while carefully considering the child's individual needs. And medical history.
Right.
They're not just following a checklist. They're really using their knowledge and skills to make informed decisions in real time.
Yeah, they're highly trained professionals who can adapt to different situations.
Right. It's amazing. I'm really glad that we had a chance to look at this.
Me too. It's been fascinating.
So this deep dive kind of gives us this glimpse
It does.
into their world.
Yeah, it does.
Now imagine, you're a parent facing a croup situation.
Right.
What questions would you ask your doctor?
Ooh, that's a good one. I like that question.
To understand the next steps
Yeah.
in your child's care. Because you know that an initial emergency response is done.
Right.
You're at the hospital now. What comes next?
Yeah. What's the long-term plan? What are the things to watch out for? What are the follow-up appointments? You know, what are the potential complications? All really important things to consider.
Yeah. I think that's a really valuable exercise that empowers you
It does.
to be an active participant in your child's health journey.
Absolutely. Knowledge is power.
It really is. So thanks for joining us for this deep dive,
Thanks for having me.
and we'll catch you next time. Hey, everyone, and welcome to this deep dive. Today, we're going to be tackling a topic that's both fascinating and, let's be honest, a little bit nerve-wracking. Emergency childbirth.
Yeah.
We're talking babies arriving unexpectedly.
Definitely.
Maybe not even in a hospital.
Right.
Our source material: the Ontario Ministry of Health's guidelines for paramedics assisting with childbirth. Now, you might be thinking, wait, I'm not training to be a paramedic.
Right.
But trust me, this is about more than just medical procedures.
Yeah.
These guidelines give us a peek into the incredible complexity of birth
Exactly.
and the skills required to handle even the most surprising deliveries.
Absolutely. Childbirth is this amazing natural process, but it doesn't always go according to plan, which
Right.
is why paramedics need to be prepared for anything. And what's so interesting about these guidelines is the frequent use of the word consider.
Yeah, I noticed that too. It's almost like they're built-in reminders for the paramedics to think on their feet.
Exactly. That consider is highlighting the need to assess each situation individually. They're constantly evaluating things like the mother's condition, how far along labor is, and even the environment they're in.
Okay.
There's no one-size-fits-all approach here.
Okay, so let's say a paramedic encounters a woman in labor. What are some of the major complications that could arise during delivery itself?
Well, the guidelines specifically mention 3 scenarios that can really complicate things: shoulder dystocia, breech delivery, and prolapsed cord.
Okay.
Shoulder dystocia is basically when the baby's shoulder gets stuck behind the mother's pelvic bone.
Ouch, that sounds difficult.
It definitely can be.
Yeah.
Then there's breech delivery,
Right.
where the baby is positioned to come out feet or bottom first instead of head first.
I've heard of that one, but I don't really understand why it's so tricky.
Well, imagine trying to squeeze through a narrow doorway head first versus feet first.
Okay.
It changes the whole mechanics of things. And the baby's head, being the largest part, needs to be carefully guided out to avoid injury.
That makes sense. Okay, and what about a prolapsed cord?
This is when the umbilical cord slips down in front of the baby,
Right.
which is a big concern because it can cut off the baby's oxygen supply if it gets compressed.
So the paramedics need to act fast in those situations.
Absolutely. Time is of the essence. They need to relieve pressure on the cord as quickly as possible to ensure the baby continues to receive oxygen.
It's amazing how paramedics are trained to handle these high-pressure situations.
Oh, yeah.
They're like medical first responders and childbirth experts all rolled into one.
Exactly.
Let's go back to those 3 delivery complications.
Okay.
What do the guidelines say about how paramedics should actually manage them?
Let's start with shoulder dystocia. Paramedics are trained to use a specific maneuver called, get this, the alarm maneuver. It's a systematic approach to help dislodge the baby's shoulder.
Alarm. Is that an acronym?
You bet it is. And what's fascinating is that this maneuver is designed to be intuitive, helping paramedics remember the steps even under pressure.
What are the steps?
The A stands for ask for help, because you definitely need an extra set of hands in this situation. Then L is for leg elevation, where you flex the mother's legs up towards her abdomen to try and create more space for the shoulder.
So it's almost like they're trying to change the angle of the pelvis.
Exactly, that's the logic. Then the second A is anterior shoulder disimpaction,
Oh.
which involves carefully applying pressure to help free the shoulder. Next, R is for rotation, where they'll try to rotate the baby's body to dislodge the shoulder. And finally, M stands for maneuvers. Think of this as the wildcard step, where they might use additional techniques to help guide that shoulder out.
Wow, it's quite a sequence. I'm guessing this takes a lot of practice to get right.
Oh, absolutely. And they need to be able to think clearly and act quickly, all while ensuring the safety of both the mother and baby.
Okay, so we've tackled shoulder dystocia.
Right.
What about breech deliveries?
Now, this one might surprise you. The guidelines actually recommend a hands-off approach initially.
Wait, hands off? What do you mean?
It might seem counterintuitive, but intervening too early or forcefully can actually be more dangerous for the baby.
Right.
Remember, the head is the last part to come out in a breech delivery, and any pulling or manipulation could potentially cause injury.
So the paramedics are essentially allowing the baby to descend naturally until it reaches a certain point.
Precisely. The idea is to minimize unnecessary interventions.
Okay.
This hands-off approach highlights a core principle of emergency medicine. First, do no harm. They're letting nature take its course as much as possible and only intervening when absolutely necessary.
I never thought about it that way, but it makes a lot of sense.
They will, however, usually be preparing for the possibility of needing to perform the Marceau smelly feet maneuver.
I have to admit that one sounds a little intimidating. What is that exactly?
Think of it like carefully guiding the baby's head out, making sure the chin's tucked in to prevent injury to the neck and spine. It's a delicate maneuver that requires specific training and expertise.
So they're basically orchestrating the safest possible exit for the baby. What factors determine when they might need to use this maneuver?
The guidelines recommend waiting until a specific point in the delivery before even considering it. The baby needs to have descended naturally to a certain point, usually when the belly button is visible and the legs and arms have been delivered.
That's incredible. It's like they're constantly assessing the situation, making judgment calls based on the baby's progress.
Exactly. And speaking of judgment calls, one of the most crucial decisions paramedics face is knowing when to transport the mother to the hospital.
Right, because sometimes getting to a hospital quickly is the safest option,
Exactly.
even if the baby seems ready to be born. What influences that decision?
It's a complex decision-making process, weighing a multitude of factors. The paramedic considers the mother's overall condition, how labor is progressing, the presence of any complications, and even the distance to the hospital.
That must be a lot of pressure, deciding whether to stay on scene or rush to the hospital.
Yeah.
What are some scenarios where transport before delivery would be the priority?
Let's say the mother is experiencing complications like high blood pressure or excessive bleeding. Or imagine a scenario where labor isn't progressing as expected. Maybe the baby's heart rate is concerning. And of course, distance plays a role.
Sure.
If the hospital is far away, they might decide to transport sooner rather than later. It's about balancing the risks and benefits of each option.
So it's a constant assessment, a delicate dance between managing the situation at hand and getting to a more controlled environment.
Precisely. And these paramedics, they're trained to navigate those gray areas, make those tough calls, and ultimately prioritize the well-being of both mother and baby.
It's amazing how much knowledge and expertise they bring to those critical moments.
And you know, it's not just about the technical skills. They're also there to provide emotional support, answer questions, and make sure everyone stays calm in what is undoubtedly a very stressful situation.
It's a holistic approach that goes far beyond just the medical procedures.
Definitely.
Speaking of procedures, one final detail from the guidelines caught my eye. And it's something that honestly seemed a little mundane at first glance, transporting the placenta with the mother or baby. Is there more to this than meets the eye?
You bet there is.
Okay.
We'll dive into that and more right after we
to-
get back. You know that seemingly insignificant placenta
Right.
is actually a treasure trove of information for doctors.
Really? I never would have thought of it that way.
It's true. By examining it, doctors can get a better understanding of the overall health of both the mother and the baby.
Okay.
They can check for any signs of infection, see if the baby was receiving enough nutrients, and even determine if the placenta was functioning properly throughout the pregnancy.
Wow, so it's like a hidden record of the entire pregnancy. It really emphasizes how every detail matters.
Absolutely. And it highlights the importance of thorough documentation and follow-through in healthcare.
Right.
Sometimes the most valuable insights come from the seemingly less dramatic aspects of a situation.
Okay, so we've covered some pretty intense delivery complications. What other challenges do paramedics face when assisting with emergency childbirth?
Well, think about it. They're dealing with a woman in labor, potentially experiencing a lot of pain and anxiety, and they're trying to make sure everything progresses safely for both her and the baby.
That must require some serious multitasking skills.
Definitely. And it's not just about the physical aspects of childbirth.
Yeah.
They're also there to provide emotional support, answer questions, and maintain a calm and reassuring presence in what is undoubtedly a highly stressful situation.
It's like they're part medical professional, part coach, part therapist. They wear a lot of hats.
They really do. And let's not forget, all of this is happening outside of a hospital setting. They might be in someone's home,
Oh, gosh.
a car, or even a public place.
That adds a whole other layer of complexity. I'm starting to think these paramedics deserve some kind of superhero award. Speaking of the environment, let's go back to that decision-making process around transporting the mother to the hospital. How do they weigh those factors when they're out in the field?
Imagine you're the paramedic. You're assessing the situation, taking in all the information, the mother's vital signs, the stage of labor, any visible complications. And you're also considering things like traffic, road conditions, and the distance to the hospital. It's like a mental equation with a lot of variables.
That's a high-stakes decision, for sure. Do the guidelines offer any specific criteria to help them make that call?
They do, but there's also a lot of room for individual judgment. It's about recognizing those red flags, those signs that indicate transport is the priority, even if the baby seems ready to be born.
Can you give us an example of what a red flag might look like?
Sure, let's say the mother's blood pressure is dangerously high,
Yeah.
or she's showing signs of a serious infection. Those would be immediate causes for concern and would likely trigger a decision to transport.
So it's about recognizing when the potential benefits of getting to a hospital outweigh the risks of staying on scene.
Exactly. And it's not just about the mother's health. Imagine a scenario where the baby's heart rate is irregular or showing signs of distress.
Right.
That would be another clear indicator for transport.
What about the logistics of the transport itself? Do they deliver babies in the ambulance?
Sometimes. But the goal is usually to get the mother to the hospital before delivery if possible.
Okay.
It's about giving her access to a more controlled environment with specialized equipment and medical professionals who can handle any complications that might arise.
It makes sense. It's about providing the best possible care for both mother and baby, even in an emergency situation.
Right. But let's say the baby decides to make a grand entrance before they reach the hospital. What then?
Well, I'm guessing that's where all that training and preparation comes in. They've got to be ready to deliver a baby in the back of an ambulance.
You got it. And it's not just about catching the baby.
Right.
They also have to make sure the mother is stable, manage any potential complications, and provide the necessary care for the newborn.
It's like having a mini delivery room on wheels.
It is. And it really speaks to the incredible skill and adaptability of paramedics. They're trained to handle a wide range of medical situations, and childbirth is just one of the many challenges they face on a daily basis.
It's truly remarkable. So we've talked about the potential complications during delivery, the decision-making process for transport, and even the logistics of delivering a baby in an ambulance. What else do these guidelines highlight when it comes to emergency childbirth?
One aspect we haven't touched on yet is the post-delivery care for the mother. That's just as critical as the delivery itself.
Makes sense. Childbirth is a huge physical feat. What are some of the key interventions paramedics focus on after the baby is born?
The guidelines emphasize two main interventions: external uterine massage and the administration of oxytocin.
Okay.
Both of these play a crucial role in helping the mother's body recover after delivery.
We briefly touched on these earlier, but can you remind us why they're so important?
Sure. So after the baby is delivered, the placenta also needs to be expelled.
Okay.
The uterus, which has stretched significantly during pregnancy, needs to contract back down to its normal size. External uterine massage helps facilitate this process, ensuring that the uterus contracts effectively and reduces the risk of bleeding.
So it's almost like encouraging the uterus to do its job.
Exactly. And oxytocin, which is a hormone that naturally stimulates uterine contractions, provides an extra boost to that process. By administering oxytocin, paramedics can further minimize the risk of postpartum hemorrhage, which is a serious complication that can occur after childbirth.
It sounds like these interventions are working in tandem to help control bleeding and support the mother's recovery.
That's exactly right. And it reinforces the idea that childbirth is a process, not just a single event.
Right. The care continues well after the baby is born.
It's fascinating how these seemingly small interventions can have such a big impact on the mother's health.
Yeah.
It really emphasizes the importance of that post-delivery period.
Absolutely. And it speaks to the holistic approach that these guidelines promote. It's not just about getting the baby delivered safely, it's about ensuring the well-being of the mother throughout the entire process.
It's amazing how much we can learn from these guidelines, even if we're not paramedics ourselves.
I agree. It gives us a deeper appreciation for the complexity of childbirth, the expertise of those who are trained to handle emergency situations, and the resilience of the human body.
So we've delved into the intricate world of emergency childbirth, from those heart-stopping delivery complications to the crucial post-delivery care for the mother. It's been quite a journey. What are some key takeaways you hope our listeners are walking away with? Well, I hope they're feeling a sense of awe at the incredible work that paramedics do day in and day out. And I hope they're also feeling a newfound appreciation for the amazing process of childbirth, even when it takes an unexpected turn.
I couldn't have said it better myself.
But there's one last thing I want to mention, something that I think is particularly relevant for our listeners, even those who may never find themselves assisting with an emergency birth. And that is the importance of basic knowledge.
Yeah.
You never know when you might encounter a situation where someone needs help, whether it's a friend, a family member, or even a stranger.
That's a really important point. Just having some basic understanding of childbirth could empower anyone to provide support or comfort in an unexpected situation.
Exactly. And while we've focused on the paramedics' perspective in this deep dive, understanding the basics of childbirth can equip anyone to be a better support person during labor and delivery, whether it's planned or unplanned.
So what's the best way for someone to gain that basic knowledge?
Well, there are lots of great resources available. There are childbirth classes, books, online articles, even videos that can walk you through the stages of labor,
Right.
common complications, and basic comfort measures. It's knowledge that's empowering, and it could potentially make a real difference in someone's life.
I love that. It's like you're encouraging our listeners to be more informed and prepared just in case they ever find themselves in a situation where their knowledge could help.
That's exactly it. We
Yeah.
never know when that knowledge might come in handy.
Well said. This deep dive has been an eye-opening exploration of emergency childbirth, and I hope our listeners are feeling equally informed and inspired. We've covered a lot of ground, but I think there's always more to learn, wouldn't you say?
Absolutely. And that's the beauty of it all. There's always more to explore, more to discover, more to understand. But for now, let's wrap up this incredible journey into the world of emergency childbirth.
Okay, everyone, get ready for those final takeaways, because we're about to land this deep dive. And we're back, wrapping up our deep dive into this fascinating world of emergency childbirth.
Yeah.
I don't know about you, but I'm feeling a newfound respect for paramedics and everyone involved
Yeah.
in bringing babies safely into the world.
It's truly remarkable, isn't it? We've covered a lot of ground, from those unexpected delivery complications to those critical decisions paramedics face in the field.
Yeah.
It's a testament to their training and expertise that they can navigate those high-stakes situations with such skill and composure.
Absolutely. And speaking of navigating tricky situations, one of the themes that's really stood out to me throughout this deep dive is the balance between following protocol and adapting to the unpredictable nature of childbirth.
That's such a keen observation. These paramedics, they're working with these established guidelines, but they also need to be ready to think on their feet to adjust their approach based on the unique circumstances of each situation.
Right. It's like they have this roadmap, but they also need to be prepared to veer off course when the situation demands it.
Exactly. And that consider wording we talked about earlier, it's almost like a built-in reminder to stay flexible,
Right.
to recognize that every birth is different.
It's like they're saying, here's the ideal scenario, but be prepared for anything.
Precisely. And that adaptability, that ability to think critically and make sound judgments under pressure, it's a hallmark of skilled emergency medical care.
I'm also struck by the holistic approach that these guidelines emphasize. It's not just about the technical procedures.
Right.
It's about understanding the emotional and psychological aspects of childbirth as well.
That's so important. Remember, these paramedics are interacting with women who are experiencing one of the most intense and transformative events of their lives. They need to be able to provide reassurance, answer questions, and create a sense of safety and trust.
It's a level of care that extends far beyond just the medical interventions.
Yeah.
They're supporting the whole person, not just the physical body.
Exactly. It's about recognizing that childbirth is a deeply personal and emotional experience, and that sensitivity and compassion are just as crucial as technical skills.
Well said. So, as we wrap up this deep dive, what are some key takeaways you hope our listeners are walking away with?
I hope they're feeling a sense of awe at the incredible work that paramedics do day in and day out. And I hope they're also feeling a newfound appreciation for the amazing process of childbirth, even when it takes an unexpected turn.
Couldn't agree more. And for our listeners who might be thinking, this was fascinating, but I'm never going to deliver a baby in an emergency situation, what's one final thought you'd like to leave them with?
Even if you're not a medical professional, understanding the basics of childbirth can be incredibly empowering. It could equip you to be a better support person for a friend or family member who's going through labor, or even help you stay calm and collected if you ever find yourself in a situation where someone needs assistance.
That's a great point. Just having that basic knowledge can make a real difference.
Absolutely. And it's knowledge that's readily available. There are childbirth classes, books, online resources. There's a wealth of information out there for anyone who's interested in learning more.
I love that. It's like you're encouraging our listeners to be more informed and prepared just in case they ever find themselves in a situation where their knowledge could help.
Exactly. We never know when that knowledge might come in handy.
Well said. This deep dive has been an eye-opening exploration of emergency childbirth, and I hope our listeners are feeling equally informed and inspired. A huge thank you to all our listeners for joining us on this deep dive into emergency childbirth. We hope you've enjoyed the journey.
Until next time, stay curious, stay informed, and keep diving deep.
All right, so welcome to the deep dive, everybody. Today we're going to do something really cool. We're going to be looking at a document that outlines some essential medical procedures.
Oh, that's great.
And basically our goal is to try to help you guys, our listeners, to feel a little bit more empowered, maybe even a little bit smarter next time you go to talk to your doctor.
Sounds like a good plan.
So this document, covers a range of things from like IVs to injections to defibrillation even.
Wow.
Yeah, pretty intense stuff. So let's dive in and see what we can learn, huh?
Absolutely. Let's do it.
So let's start with something I think most of us are probably familiar with, IVs.
Okay.
That whole needle in the arm thing.
Right.
What exactly is going on there?
Well, that's called intravenous cannulation.
Cannulation.
Cannulation, yeah.
Wow.
And it's super important in hospitals and emergency settings.
Right.
Because it's the way we get fluids and medications directly into the bloodstream.
Makes sense.
Yeah, which is vital, in emergencies and when people can't take things by mouth.
Okay, so it's like a direct line to the system.
Exactly.
Makes sense. Now, the document mentions avoiding certain areas for IVs, like burn sites, for example.
Whoa, right.
Now, that seems kind of counterintuitive. Wouldn't you want to get fluids into a burn victim as quickly as possible?
You'd think so, but actually burn tissue doesn't absorb fluids as well as healthy tissue. And there's a higher risk of infection as well.
Oh.
So it's kind of like trying to water a plant with damaged roots.
Right.
It's just not going to be as effective, and you might even do more harm than good.
That's a great analogy, yeah.
Yeah.
So let's say you found a good vein. What happens then? What's the actual process of, putting that IV in?
Well, sterile technique is really, really important.
Sure.
So gloves, prepping the skin, everything has to be absolutely clean. And then they choose the right size catheter for the vein, use a tourniquet to make the vein a little bit more prominent, easier to see, and then they look for something called a flashback.
A flashback.
Yeah, a flashback.
Sounds kind of scary. Like a bad dream or something?
Well, no, not exactly. It's
Right.
actually just a tiny bit of blood that appears in the catheter when they've successfully hit the vein.
Oh,
It's
wow.
kind of like a bullseye.
Okay, so that's how they know they're in the right spot.
Exactly.
Okay, so then what? Boom, you've got an IV access point.
Pretty much.
Okay.
So they advance the needle a bit further, take off the tourniquet, and then they secure the catheter with the dressing. And there you go. You're hooked up.
Wow. So you're officially plugged into the healthcare highway.
You got it.
All right, so we've got the IV set up. What about the medications that actually go through that line?
Yeah.
The document talks about things like preloads, ampoules, vials. What's all that about?
Well, they're basically just different ways of packaging the medication. Some are ready-to-go syringes. Others are little glass containers that you have to snap open. But what's really crucial is what happens after the medication is prepped.
Okay, so tell me, what does happen after the medication is prepped?
Yeah.
How do they get it from, like, the container into your bloodstream?
Well, again, sterile technique is absolutely crucial.
Of course.
The medication is drawn up into a special needle, and this is really important, the dosage is confirmed.
Okay.
ideally with a second healthcare professional.
Oh, wow. So it's like a double-check system to
Exactly.
prevent mistakes.
Exactly. It's a really important safety net, especially for like critical medications.
Wow, that's fascinating. So 2 sets of eyes on every single dose?
Yeah, you want to be absolutely sure you're giving the right amount. Imagine giving someone like 10 times the dose of a powerful drug.
Yeah.
That could be disastrous.
Absolutely. Okay, so dosage is confirmed. Then what? Does it just go straight into the IV line?
Sometimes, yeah.
Okay.
But in some cases, it's given in smaller, more controlled doses.
Okay.
These are called aliquots.
Aliquots.
Aliquots, yeah.
Where are those?
So imagine you're getting pain medication. They might give you a little bit, see how you respond, and then give you more if needed.
Oh, so it's about finding that balance between relieving the pain but not, knocking you out completely.
Exactly. And sometimes they might even dilute the medication with saline.
Dilute.
Mm-hmm.
So like watering it down.
Yeah, kind of. It gives them even finer control over the dosage.
That's interesting.
It's all about precision.
Makes sense. Well, this talk of needles and dosages is making me a little lightheaded. Maybe we should move on to something a bit more electrifying.
Electrifying. You mean like manual defibrillation?
Okay, yeah, defibrillation. That's the one. It's like the ultimate medical drama scene, right?
Yeah.
Clear.
You see it in all the movies.
Yeah, exactly.
Yeah.
But seriously, is it really as dramatic in real life?
It can be.
Oh, wow.
It's a life or death procedure used when someone's heart rhythm goes out of whack, like ventricular fibrillation, for example. That's where the heart's just quivering instead of pumping properly. And that's when you need the defibrillator.
So it's like a jolt that resets the heart.
Exactly.
Okay.
But before they even think about shocking, they have to be absolutely 100% certain that the person's in cardiac arrest.
Okay.
So checking for a pulse, listening for heart sounds, making sure they're not breathing.
So it's not just a free-for-all with the paddles then?
Absolutely not.
Okay, good to know.
And while they're doing all that, someone else starts CPR right away to keep the blood flowing to the brain.
Wow. So every second counts.
You bet.
Okay.
Every second counts.
So we've got CPR going, confirmed cardiac arrest. I'm assuming the defibrillator pads are getting prepped at this point.
You're on the right track. And here's something you might not expect. They might actually dry or even shave the person's chest before applying the pads.
Shave. Why would they do that?
Well, moisture, like sweat, can act as a conductor, and that can divert the electrical current away from the heart.
Huh?
And chest hair can create resistance, which makes the shock less effective.
I see. So those little details can actually make a big difference.
Huge difference.
Wow. Okay, so pads are on, the defibrillator's charged.
Right.
What happens next? Do they just push the button and hope for the best?
Not exactly. They have to analyze the heart rhythm first.
Okay.
There are actually shockable and non-shockable rhythms. Shockable rhythms are like that chaotic electrical storm we talked about. But some rhythms, like a systole that's a flat line, don't respond to defibrillation at all.
So it's like using the right tool for the right job. You wouldn't use a fire extinguisher on a grease fire.
Exactly.
Okay.
And if the rhythm is shockable, everyone stands back, they shout clear, and then they deliver the shock.
Okay.
And then it's back to CPR and monitoring to see if the heart rhythm has returned to normal.
Wow, what an intense procedure. Talk about high stakes.
Yeah, it's definitely not for the faint of heart.
Well said. So we've covered needles going into veins.
Yeah.
But what about other ways to get medication into the body without, puncturing anything?
Oh, absolutely. There are plenty of other options. Subcutaneous injections, intramuscular injections, intranasal, buccal, even sublingual, which is under the tongue.
Wow, it's like a whole menu of medication delivery options.
It really is.
So let's take a quick tour of some of these other routes.
Okay.
What are some of the things we should keep in mind for each one?
Well, for subcutaneous injections, which are just under the skin,
Right.
they're often used for medications that need to be absorbed slowly.
Okay.
Like insulin, for example. It's like a slow drip of medication over time.
Okay, so subcutaneous is more of a gradual thing.
Exactly.
What about intramuscular injections? Those are the ones that go right into the muscle, right?
That's right. They're often used when you need faster absorption or for larger volumes of medication.
Oh, so it's all about location and speed.
Pretty much.
Okay, and then we have those non-needle methods, right? Intranasal, that's just a fancy way of saying nasal spray, right?
Yeah, exactly.
It's a great way to deliver some medications because the nasal passages absorb things really quickly. I mean, think about how fast you feel the effects of a decongestant spray.
It's practically instant.
It really is.
Yeah.
Okay, so we've got injections, nasal sprays. What about these peel and sublingual methods you mentioned? Those sound kind of unusual.
Well, they are a bit more specialized.
Okay.
Vocal administration involves placing the medication between your cheek and gum.
Between the cheek and...
Yeah, okay.
And sublingual means under the tongue.
Under the tongue, okay.
And both of these methods, the medication is absorbed through the lining of the mouth.
So those dissolving tablets that you put under your tongue, that's sublingual, right?
Exactly.
Okay.
It's often used for medications that need to act really quickly, like nitroglycerin for angina.
Right, because it gets absorbed right into the bloodstream.
That's right. It bypasses the whole digestive system.
Wow. So many different ways to get medication where it needs to go. It's like a complex highway system inside the body. It really is.
Well, I'm feeling a bit breathless after all that talk of cheeks and under-the-tongue tablets. Maybe we should explore a method that involves, well, breathing.
You read my mind. Next up, nebulized medication administration. It's a method that delivers medication directly to the lungs.
Okay, sounds like a breath of fresh air. We'll dive into the world of nebulizers after a quick break. Stay tuned.
All right, welcome back to the deep dive, everyone. Hope you enjoyed that break. We left off talking about nebulizers.
Yes, nebulizers. They always make me think of those old movies with those big clunky machines.
Right.
Are they still like that, or, has technology moved on?
Well, technology definitely has moved on. They're not as big and clunky as they used to be.
Okay.
But they're still incredibly helpful, especially for delivering medication directly to the lungs.
Okay.
Like for people with asthma or COPD.
Makes sense. So how do they work? I mean, when would you use a nebulizer instead of, say, an inhaler?
Well, nebulizers create a fine mist of medication, and that can be easier to inhale than the quick burst from an inhaler.
Oh, okay.
Especially for, young kids or folks who have difficulty coordinating their breathing.
Right. So it's all about getting that medicine right where it needs to be.
Exactly. Deep into the lungs.
So walk me through it.
Yeah.
What actually happens during a nebulizer treatment?
Okay, so first things first, the medication is prepared.
Okay.
Sometimes that means drawing it up from a vial. Sometimes it's just opening a pre-filled container called a nebule, and then that's placed into a little chamber in the nebulizer.
Got it. So we've got our medicine chamber loaded up. Then what?
Then the nebulizer is connected to an oxygen source,
Okay.
and the flow rate is very carefully adjusted.
Okay.
That oxygen helps create that fine mist we were talking about.
Okay. Got it.
Once you can see the mist forming, they place a mask over the patient's face,
Okay.
and they're just instructed to breathe normally.
Oh, so they don't have to puff or anything like with an inhaler?
Nope, much more passive.
So it sounds pretty easy.
Yeah, it is. But there are a few things to keep in mind. For example, the patient's position can really make a difference.
Really? So no slouching on the couch with the nebulizer?
Probably not the best idea.
Okay.
Sitting upright is usually ideal because it helps the lungs expand fully.
Oh, okay. So give it lots of room to work. Makes sense.
Exactly. Kind of like giving the medication more space to reach all those tiny air sacs.
Got it. So posture matters. Now, I noticed the document mentioned something interesting. Nebulization is contraindicated in patients with a fever.
Mm-hmm.
Why would that be?
Well, there are a couple of reasons.
Okay.
First, nebulizers can sometimes aerosolize respiratory droplets,
Okay.
and those could potentially spread infections.
Especially if someone has a fever.
Exactly, especially if it's something contagious.
Yeah. So it's about containing those germs.
Precisely. And then secondly, for someone with a fever, a nebulizer treatment could actually raise their temperature even more.
Oh, why is that?
Well, because of that warm, moist air they're inhaling.
Oh, okay. So it's almost like adding fuel to the fire.
Kind of, yeah.
Okay. So minimize infection spread and don't make the fever worse. Makes sense to be cautious. Speaking of being cautious, you mentioned intramuscular injections earlier. Those ones that go right into the muscle.
Right.
Those always kind of make me cringe.
I get it.
Are they as bad as they sound?
Well, any injection can be a little uncomfortable.
Sure.
But healthcare professionals are trained to make it as quick and painless as possible. They've got lots of techniques to minimize the pain.
Okay. That's good to know.
Yeah.
So let's break it down. What happens during an IM injection?
Okay. So, as always, it starts with the basics. Proper PPE, gather the equipment, explain things to the patient, get consent. Then the medication's prepared. They draw it up from the vial or ampoule using a syringe. And of course, double check that dosage.
I think that double check should be a rule for everything in life.
Right.
Not just medical procedures.
Agreed. Okay, so medication's ready to go. Then they choose the injection site. And this depends on a few things. The patient's age, the type of medication, how much they're getting, any specific instructions from the medical directive.
So there's no one-size-fits-all spot for IM injections.
Nope.
Okay.
There are a few commonly used sites, each with their own pros and cons.
Okay.
For little ones under a year old, the outer thigh muscle is usually the go-to.
Okay, that makes sense. Their little arms and, other places probably aren't developed enough.
Exactly. For toddlers, they usually stick with the thigh muscle as well until that deltoid muscle in the upper arm gets a bit bigger.
Okay, so thigh muscles are the MVPs for little kids' injections.
They really are. For adults, though, it usually comes down to either that deltoid muscle in the upper arm or a muscle in the hip area called the ventrogluteal muscle.
Okay, so we've got our target muscle. What happens next? Before they, actually stick that needle in, the document mentions something called the Z-Track method. What is that all about?
Oh, yeah, the Z-Track method.
What's so special about that?
Well, it's a way to prevent the medication from leaking out.
Oh, okay.
Imagine you're giving an injection. Sometimes a little bit of medication can seep back out after you remove the needle.
Oh, like a leaky faucet.
Exactly. The Z-Track method helps to seal it in. They pull the skin to the side before inserting the needle, and then when they release the skin after the injection, it creates a kind of zigzag track that helps to seal the medication within the muscle.
That's pretty clever. So it's like a little secret passageway.
I like that.
So after this zigzag maneuver, the needle goes in at a 90-degree angle.
That's right, straight into the muscle. And they inject the medication slowly and steadily.
Good.
You don't want to rush it.
I bet. I mean, pushing it in too fast would be uncomfortable.
Yeah, and it could damage the muscle.
Exactly. So slow and steady wins the race.
Exactly. After the medication's in, they withdraw the needle and then let go of the skin, letting it slide back into place, sealing that zigzag path.
Okay, so it's like closing the secret passageway once the treasure is delivered.
Exactly. All about minimizing leaks and irritation.
Makes sense. Well, enough about needles for now. What about those methods that don't involve any pokes or prods at all?
You're talking about the classics oral and sublingual medications.
Exactly. Just popping a pill or dissolving a tablet? Seems pretty straightforward.
It does. But even with these simple methods, there are things to keep in mind to make sure everything goes smoothly and the medication works as intended.
Okay, what are some of the things we should keep in mind with oral and sublingual medications?
Well, the basics are always there. Proper PPE, explaining things to the patient, getting your consent if possible.
Right.
Then the medication is prepared. They check the dosage carefully, make sure the packaging is intact. But with oral meds, it's really important to make sure the person can swallow safely.
Oh, yeah, of course. You don't want him choking on a pill.
Exactly. And then, depending on the specific medication, there might be instructions about taking it with or without food, or whether you can crush it or chew it.
So reading those tiny instruction leaflets is actually important.
It can make a big difference in how well the medication works.
Good to know.
Now, with sublingual meds, those dissolving tablets that go under the tongue, the key is to make sure it dissolves completely.
Right.
Don't swallow it, don't chew it.
Right. I've used sublingual meds for headaches before, and they work so much faster than swallowing a pill.
That's because that area under your tongue has a super fast connection to your bloodstream.
Oh, okay.
The medication gets absorbed right away, bypassing the whole digestive system.
Wow, it's like a shortcut to pain relief.
Exactly. So these oral and sublingual routes, even though they seem simple, they're really powerful tools for delivering medication. But, speaking of delivering medication, remember when we talked about nebulizers and how they create that fine mist of medicine for the lungs?
Yeah.
Well, there's another device that does something similar, but it's much more portable.
Okay.
It's called a metered dose inhaler, or MDI.
Oh, yeah, the good old inhaler. I think everybody's seen one of those at some point.
Right.
But is there more to them than just, pressing a button and inhaling?
Absolutely. Let's take a closer look at this essential device and learn how to use it effectively.
Okay, I'm ready to become an inhaler expert.
All right, let's do it.
Welcome back, everyone. We're about to unravel the mysteries of metered dose inhalers, those little lifesavers for folks dealing with asthma and other breathing issues.
You got it. Inhalers are super common, but using them the right way, that's key. We'll break it down step by step and give you some insider tips to make sure you're getting the most out of your inhaler.
Okay, I'm all ears. I've used inhalers before, but I always get a little unsure. Like, am I doing this right? What are the big things to keep in mind?
Well, just like with any procedure, we got to start with the basics. PPE, all our equipment ready, and making sure the patient understands what's going on and they're okay with it. Then we prime the inhaler.
Prime. Like, pump it up.
Haha, well, not quite that dramatic. But yeah, you got to get it ready for action. Usually that means giving it a good shake and a couple of test sprays just into the air. It's like making sure the medication is flowing properly.
So those test sprays, they're important. Gotta admit, I've skipped those before.
It's tempting, but those test sprays make sure you're getting a full dose when you actually use it. Now, there are a couple of ways to use an MDI. One way is using a spacer.
Oh yeah, spacers, those little chamber things, they always seem kind of bulky to me. Are they really necessary?
They can be super helpful, especially for kids or anyone who has trouble timing their breath with the inhaler. Spacers hold the medication so you can breathe it in slower and deeper, meaning more medicine gets to your lungs right where it needs to be.
Ah, so it's like taking a deep breath of medicine instead of trying to catch a tiny puff in midair.
Exactly. It gives the medicine a better chance of reaching those small airways. You just pop the MDI into the spacer, breathe out gently, then put your mouth on the spacer, making a good seal.
Okay, so you've got your inhaler, spacer, mouth all lined up. Then what?
Press down on the inhaler, release a puff into the spacer, then you breathe in slow and deep. Hold your breath for a few seconds to let the medicine settle in.
So there's a definite technique to it.
Yeah.
It's not just a quick puff and done.
Right. How many puffs and how long you wait between them depends on the specific medication and your doctor's orders. Follow those instructions carefully.
Okay, spacers, got it. They're like the MVPs of inhaler use. What about those emergency situations where someone might not be able to use an inhaler on their own?
That's where a bag valve mask, a BVM, comes in. It's a handheld device to deliver oxygen and help someone breathe.
Right, like manually assisting breathing. I've seen those used in, well, everywhere.
They're essential in emergencies, and you can actually connect an MDI to a BVM using a special adapter. So you can give someone a puff of medication right through the BVM and then give them breaths.
So it's like a 2-for-1 medicine and breathing assistance.
Exactly. Gets the medication in there fast when it's really needed. But enough about inhalers. Let's go back to injections for a sec. We talked about intramuscular, but what about those subcutaneous injections, those just under the skin ones? Those are a big deal for folks with diabetes who need insulin.
Yes. SC injections, they seem a bit less, I don't know, intense than those IM injections, but I'm sure there's still a right way to do it. What are the key things to remember with an SC injection?
Okay, so same as always. Proper PPE, supplies gathered, explaining everything to the patient, getting consent. Then the medication's prepped, drawn up with a syringe, and of course, that super important double check of the dosage.
Honestly, we should make double check a national motto. It could save a life.
I'm with you on that. But seriously, it's so important. So medication's ready. Time to pick the spot.
Okay.
For SC, it's usually the abdomen, thighs, or upper arms.
Places where there's that little bit of fat under the skin, right?
Exactly. That's where the injection goes, so it absorbs slowly into the bloodstream.
Like a time release thing.
Perfect analogy. But the exact spot depends on the medication, the person's age and body, and what their doctor says.
Okay, so it's not just one spot fits all.
Nope. Individualized, just like everything else. So before the needle goes in, we clean the area with alcohol, to prevent infection. Sterile technique all the way.
I'm really starting to get that sterile technique is key. It seems like the golden rule for all these procedures.
You got it. It's all about safety. So site's prepped. We hold the syringe, pinch a fold of skin at the injection site, and then the needle goes in at a 45-degree angle.
I'm guessing pinching the skin helps make sure the medicine goes into the fat layer and not the muscle.
You're catching on quick. Simple but effective way to target the right spot.
All right, needle's in, skin's pinched. What's next?
We inject the medication nice and slow. Keep an eye on the patient for any discomfort or reactions.
It's like a balancing act. Speed, precision, observation.
It is. Once all the medication's in, we take out the needle, same angle it went in, and gently massage the area to help the medicine spread and reduce bruising.
A little post-injection care goes a long way.
It does. And finally, a small bandage to cover the spot and stop any bleeding.
Simple, effective. Going through all these procedures, I'm really struck by how much detail and care goes into even the simplest things in healthcare.
I'm glad you noticed that. It's often the little things that matter most. But let's not forget about those needle-free options. We talked about pills and under-the-tongue meds, but there's another way to deliver medicine through the nose. Atomizers.
Atomizers. That sounds kind of sci-fi. What are those?
Think nasal sprays. Atomizers are usually for those intranasal medications, those decongestants and allergy sprays you see everywhere.
Oh, nasal sprays. I'm a pro at those. Anything special I should know about atomizers?
Even though nasal sprays seem simple, there's still a best way to do it. Same starting point. PPC, equipment ready, explaining to the patient, getting consent.
Feels like I could recite those steps in my sleep now, but good reminder that safety's always first.
You got it. So the medication needs to be prepped. This might mean drawing it up from a vial with a syringe and then attaching the atomizer to it.
Oh, so you're not just squirting it straight from the bottle. A syringe is involved.
Yeah, the syringe lets you measure and control the dose precisely, which is really important. And of course, always double check that dose.
Precision and double checks. The unsung heroes of healthcare.
Absolutely. Now, we look at the nostrils, make sure there's nothing blocking them, like mucus or anything.
Like a quick peek to make sure the path is clear.
Exactly. Got to make sure the medicine gets where it's supposed to go. If there's anything in the way, we clear it out first.
Makes sense. Wouldn't want the medicine going astray.
Right. So once the nostrils are clear, we hold the patient's head steady with one hand so they don't move while we do this.
I bet even a tiny head wiggle could throw off the aim.
You bet. We want things nice and controlled. So, holding the head steady, we gently put the atomizer into one nostril, aiming kind of upward and outward, following the natural curve of the nose.
Okay, so there's a specific angle. It's not just straight up the nose.
You got it. That angle gets the medicine to the right place. Now, here's where it gets interesting. We press the plunger on the syringe with a good amount of force.
Force. Why?
Not about being rough, but we want to make sure the medication is atomized, turned into a fine mist that the nasal lining can absorb easily.
So a controlled burst of pressure to make that mist.
Exactly. It's all about that fine mist to coat the nasal passages.
Like a tiny explosion of medicine inside the nose.
Haha, that's one way to put it. We do the same thing for the other nostril, make sure both sides get an equal dose, and of course, clean everything up properly, check on the patient, and document the procedure.
Well, after all that, from IVs to injections, nebulizers, nasal sprays, I feel like I've got an honorary medical degree.
Uh-huh. You've been a fantastic student, but really, I think we've both learned a lot about these procedures and the skill that healthcare professionals use every day.
Absolutely. It's easy to not think about it, but there's so much more going on than we realize.
So true. So as we wrap up this deep dive into medical procedures, I'll leave you all with a question. With technology changing so fast, what new and amazing procedures might we see in the future?
That's a great thing to think about. And as we've learned, even seemingly simple procedures have a lot to them and require a real understanding of both science and caring for people. So stay curious, ask questions, and keep exploring this amazing world of knowledge.
Thanks for joining us on the deep dive.
We'll see you next time for another adventure. Have you ever thought about what paramedics face on a day-to-day basis?
Oh, yeah, for sure.
You talk about intense.
Yeah.
They're dealing with life and death situations all the time, and sometimes every second counts. And that's what we're going to be talking about today. We're diving deep into one of those really critical scenarios.
Okay.
What happens when someone can't breathe?
Oh, wow.
Specifically, we're looking at emergency airway procedures, and we're using the Ontario Ministry of Health's Advanced Life Support Patient Care Standards as our guide.
That's a great resource.
Yeah, it is. So to help us kind of understand exactly what's in this document
Wow.
and to help us really break these procedures down, we have an expert joining us today.
Hello.
Thanks for joining us.
Thanks for having me.
So I guess let's just jump right into it. We often hear about these tubes,
Okay.
endotracheal tubes and tracheostomy tubes.
Right.
Can you just kind of explain for us what those are and why they're so important in these situations?
Yeah, so when we think about our airway, we have our trachea, which is our windpipe. Right, that's the highway to our lungs.
Okay.
And sometimes due to injury, illness, or an obstruction, that highway is blocked.
Okay.
And so in those cases, we need to secure the airway.
So is that what these tubes do?
Yes, these tubes are actually securing the airway.
Okay.
So an endotracheal tube is placed through the mouth into the trachea to bypass the blockage.
So it's like a detour.
Exactly like a detour.
Okay.
And then a tracheostomy tube is actually placed directly into the trachea through the neck.
Okay.
And so those are options that we use when a patient can't breathe on their own.
So those tubes are securing the airway, but what happens if the tube itself gets blocked?
That's a really good question. And that's when things can get a little bit dicey.
Okay.
So we're looking at the endotracheal and tracheostomy suctioning and reinsertion medical directive.
Okay, that's a mouthful.
It's a mouthful, but it's really important
Okay.
because it's going to give paramedics the framework on how to manage those exact situations.
Okay, great. So let's talk suctioning. If a paramedic arrives on the scene, what are the indicators? What are they looking for that says, okay, we need to suction?
Yeah, so there's two main indicators.
Okay.
One is that there's evidence of obstruction in the tube.
Okay.
So there's physically something blocking the airflow.
Okay.
The second is that there's a buildup of secretions in the tube.
Okay, like mucus and stuff like that.
Exactly like mucus that could potentially obstruct the airway.
Okay, so it doesn't necessarily have to do with their vital signs or their age.
Exactly, not just their age or vital signs, but what's actually happening in that airway.
But age does play a role in how they would do the suctioning.
You got it. So the amount of pressure that we use for suctioning varies based on the age of the patient.
Interesting.
So for infants under 1 year, we're going to keep that suction pressure quite low,
Okay.
between 60 and 100 mmHg.
Wow, that's very precise.
It is very precise.
Okay.
Then for children between 1 and 12 years old, 100 to 120 mmHg. And then anyone 12 and older is 100 to 150 mmHg.
So it doesn't really get that much higher for adults.
No, it doesn't. And that's because applying too much pressure can actually cause damage to the tissues in the airway.
That makes sense.
And then regardless of age, we're only going to suction for 10 seconds at a time.
Okay.
So 10 seconds is the maximum for each suction attempt to prevent complications.
Wow. So these paramedics really need to know their stuff.
They do.
So they get there, they assess the situation, they determine if they need to suction.
Right.
What if suctioning just isn't enough? What if, say, the tracheostomy tube has come out?
So that is a high-stakes situation.
Yeah, that sounds terrifying.
So picture this. You arrive on scene and your patient is in respiratory distress. Their tracheostomy tube is dislodged and their airway is compromised.
Oh my gosh.
So you know, as a paramedic, you need to very quickly assess the situation and determine if an emergency tracheostomy reinsertion is required.
Okay, so walk me through that. What goes into that decision?
All right, so first of all, we need to make sure that there is a pre-existing tracheostomy and that the cannula, which is the tube itself, is removed.
Okay.
The second thing that we need to look for is that the patient is in respiratory distress.
Okay.
So they're having difficulty breathing.
Right.
The third thing is that we're unable to ventilate the patient, so we can't get air into their lungs.
Okay.
And then the fourth thing, and this is a really big one, is that we have a spare tracheostomy cannula available.
Ah, so you can't just use any tracheostomy tube.
No, it needs to be specifically for that patient.
Okay, wow. So is there a limit to how many times a paramedic can try to reinsert the tube?
Yes. So we're only going to attempt reinsertion twice.
Okay.
And that's because patient safety is paramount.
Right.
And we need to avoid any complications that might occur from multiple attempts. So if the reinsertion is unsuccessful after 2 attempts, then we're going to move to a different airway management technique.
That makes a lot of sense.
Yeah.
So there's a lot of judgment calls happening in these situations.
Absolutely.
But aside from all of the technical stuff, are there other things that paramedics need to keep in mind?
Yeah, so with both suctioning and tracheostomy reinsertion, pre-oxygenation is essential.
Okay, what does that mean?
So before we even start the procedure, we're going to pre-oxygenate with 100% oxygen.
Okay.
And that's because we want to ensure that the patient has adequate oxygen reserves before we go and manipulate the airway.
Okay, so that makes sense. You're getting them ready.
Yes, you're getting them ready.
What about tracheostomy reinsertion specifically? Are there any things they need to keep in mind?
Yeah, so there's 2 key points that I'd like to highlight. One is that when we're reinserting a tracheostomy tube, we always want to use a new sterile cannula.
Okay.
The second is that sometimes family members or caregivers can be a great help in these situations.
Oh, okay, so they should get them involved.
Well, if they're familiar with the patient's tracheostomy care, they can provide us with really valuable information and even assistance in the procedure.
Okay, that's interesting. It's amazing how much goes into these procedures.
It is.
There's all the technical stuff, all the considerations, and then adapting to each individual situation.
Exactly. And remember, this is just a highlight.
Right.
There's so much more to it than what we've talked about today.
Yeah, it really gives you a new appreciation, I think, for paramedics and what they do.
Yeah, it really does.
I mean, it really makes me think, what other factors do they have to consider in the moment?
Lots.
You know, the environment, the patient's history, maybe even the resources that they have available.
All critically important.
It's a real testament to the skill and the adaptability that they have.
Absolutely.
It's really incredible.
Yeah.
Well, this was a fascinating deep dive into emergency airway procedures.
Thanks for having me.
Thanks so much for joining us.
You're welcome.
And we'll see you next time on The Deep Dive. Okay, so picture this. You're a paramedic racing to a scene, lights flashing, sirens blaring.
Sounds intense.
It is. You arrive and find a patient who needs to be transported. Like right now, every second counts.
Got it. A real emergency situation.
But here's the catcher. The patient's on home dialysis, still hooked up to their machine.
Oh, that definitely complicates things.
Big time. This is where we dive into something called the Home Dialysis Emergency Disconnect Protocol.
Okay, I'm listening.
This protocol lives in a pretty important document. It's the Ontario Ministry of Health's Advanced Life Support Patient Care Standards.
So these are the rules paramedics follow in these really tough situations.
Exactly. Today we're going deep into this specific protocol, figuring out the decisions paramedics have to make when lives are on the line.
You know what's really interesting about this protocol? It kind of throws out the usual playbook.
How so?
Well, usually things like a patient's age, their heart rate, vital signs, all that stuff, it's super important.
Right, makes sense.
But with this protocol, it almost doesn't matter.
That's surprising. Why would that be?
Because in this scenario, time is absolutely everything.
So the focus is just getting them to the hospital, ASAP.
Exactly. The document is very clear on this. Paramedics can only do this emergency disconnect if and only if there is absolutely nobody else around who knows how to disconnect the patient.
So no family, no nurses, nobody.
Nope, it's a true last resort. And speaking of urgency, the protocol also says the patient needs to go to the nearest appropriate facility.
Appropriate facility. What does that even mean in this context?
That's where things get tricky. You have a patient needing specialized care, right? Maybe heart issues, lung problems, who knows?
And not every hospital is equipped for everything.
Exactly. So paramedics have this balancing act. They're weighing how serious the patient's condition is against how long it'll take to get them to a hospital that can actually help.
I see. So distance versus specialized care.
Right. On top of that, you've got different types of dialysis to consider.
Like, what are we talking here?
Well, you've got hemodialysis, where the blood is filtered outside the body. And then there's peritoneal dialysis, which uses a catheter in the abdomen to clean the blood.
Wow. So many factors to juggle in a high-pressure situation.
It's a lot. And that's not even considering what could go wrong if a patient is disconnected the wrong way.
Yeah, this isn't like unplugging a lamp. What are the risks we're talking about here?
Oh, serious stuff. We're talking bleeding risk of infections. And there's even something called an air embolism, where an air bubble gets into the bloodstream.
That sounds terrifying.
It can be. Improper disconnection could turn a critical situation into a fatal one.
Okay, so this brings us to the emergency disconnect kit mentioned in the protocol. I'm imagining like a big red box with flashing lights.
Maybe not flashing lights, but it's definitely crucial. This kit is usually attached to the dialysis machine itself or on a nearby wall, easy to find.
So it's ready to go.
Exactly. It has everything needed for a safe disconnection. And the document is really specific about how this all goes down.
Like, what does it say?
It stresses that paramedics have to clamp both sides of the connection before disconnecting anything. Then they use end caps to prevent leaks or anything getting in.
So every little step is about minimizing risk during transport.
Precisely.
Got it. Okay. Look, walk through this. Say you're the paramedic. You're on scene. Every second counts. You've confirmed you meet the criteria for an emergency disconnect. What's next?
Okay. First, locate that disconnect kit. Remember, every second matters. Then follow the kit's instructions to the letter.
No room for error.
Nope. Clamp, disconnect, secure those end caps. It's almost like solving a puzzle under pressure.
High-stakes puzzle.
Absolutely. And all this is happening while your partner is getting the patient ready for transport, watching their vitals, calling the hospital.
It's a coordinated effort.
Definitely. Then it's into the ambulance, lights and sirens on, and straight to that closest appropriate facility.
Man, what a race against time. This whole protocol makes me think, how important is planning ahead for folks on home dialysis?
Oh, it's huge. It makes you wonder, what would you want to discuss with your family if you were in this situation? Where's that kit? Who knows the procedure?
Themes you don't want to think about but need to.
Exactly. Even knowing where the disconnect kit is or practicing with a family member could make all the difference.
A difference between a safe trip to the hospital and a potential disaster.
You got it.
Wow. Definitely something to consider. Thanks for taking us on this deep dive today.
My pleasure. Always happy to shed some light on these important topics.
Absolutely. Until next time.
See ya. Welcome back for another deep dive. Today, we're tackling medical directives.
Oh, interesting.
Yeah, you know those documents that kind of like guide your healthcare if you can't speak for yourself?
Right. Important stuff.
It's like, imagine you're in an accident and can't communicate. A medical directive basically speaks for you, tells doctors what you want or don't want.
Based on what you decided back when you were healthy. It's all about making sure you stay in control of your own healthcare. Even if something happens.
Exactly. Okay, so let's try to break down a typical medical directive. Think of it like an instruction manual, but for your medical care.
With different sections.
Yeah.
Each one is really important.
Yeah, yeah. So one of the first things you'll usually see is the indications.
Ah, yes, the indications. That's like the foundation of the whole thing. Tells you exactly when the directive applies, what medical situation we're talking about.
So it's like setting the scene.
Yeah, exactly. You got to be super clear about when these instructions actually kick in. Otherwise, it could be misinterpreted, you know?
Makes sense. What comes next?
Conditions.
Conditions.
Yeah, think of it like a checklist. Before the doctors do anything, they have to make sure all those conditions are met.
Oh, so this is where things get really specific, huh?
Exactly. It's all about making sure, like, everything lines up perfectly with what you wanted.
Mm.
Say, for example, you only want pain meds if your pain level is above a certain number. That would be in the conditions.
Oh, okay. Okay, I see. But what if there's like a treatment you don't want, even if most people would normally get it?
Contraindications.
Contraindications.
Yeah, that's the section for stuff that would prevent a treatment,
Yeah.
no matter what, like a safety net.
So sticking with the pain meds, a contraindication might be if you're allergic to a certain type, right?
Exactly. So it's there to protect you.
Gotcha. And then after all that, we finally get to the main part, I guess, the treatment section.
Right. This is where it gets down to the nitty-gritty. Clear instructions for the medical team, all based on those indications, conditions, and contraindications we talked about.
So it's kind of like a recipe. You have the when, the if, the don't, and then the do, all laid out step by step.
Yeah, that's a good way to put it. And sometimes you might even have another section called clinical considerations.
Clinical considerations. What's that?
Think of it like extra guidance or like tips for the medical team, you know?
Okay.
Maybe you have some preferences, personal stuff that could help them take better care of you.
So it's like adding a personal touch, huh? Making sure your care feels right, not just medically, but like for you as a person.
Exactly. Healthcare isn't just about procedures, it's about respecting the whole person.
Right. Now, besides those core sections, you mentioned there are some special types of medical directives. You said auxiliary and special event, I think.
Yeah. Auxiliary medical directives are like, think of it like the optional extras you can get on a car. Heated seats, a sunroof, not essential, but can be nice.
Okay, I'm following.
So maybe you want to, like, authorize a certain procedure to be done by a paramedic in an emergency. You could do that with an auxiliary medical directive.
Interesting. And then the other one, special event directives. I'm guessing that's for big gatherings, places where things could get, a little hectic.
Exactly. Music festivals, marathons, things like that. You want to make sure things run smoothly, medically speaking, even if it's kind of chaotic.
Okay, so it's like having instructions tailored for a specific situation, like knowing it might be a little different from a regular hospital visit. But what about the whole idea of consent? If someone's unconscious or something, how do we know what they'd actually want?
Well, that's where a substitute decision maker comes in. Usually a family member or a close friend who you've chosen to make decisions for you if you can't.
Wow, that's a big responsibility.
It is. Ideally, you'll have talked to them about your wishes beforehand, so they can really advocate for you.
Right. But what if there's something you never talked about specifically? Like, how does the substitute decision maker know what to do then?
Well, that's where things can get a little tricky, ethically speaking. It's not always a black and white situation.
Yeah, I can see that. Sounds like it's super important to, have those conversations ahead of time, even if they're a little uncomfortable.
Absolutely. The more you can clarify things in advance, the better.
So, okay, we've covered the main parts of a directive, some unique situations, and the importance of having a substitute decision maker. But what about the whole concept of consent? Like, what actually makes consent, valid?
There are 5 key elements: capacity, relevance, informed, voluntary, and no misrepresentation.
Whoa, that sounds kind of legally.
I know, but it's actually pretty straightforward. Let's break it down.
Okay, yeah, let's do that. What's capacity?
Basically, it means the person giving consent, they got to be able to understand what they're agreeing to, like the information and the consequences.
So it's more than just saying yes or no.
Right. It's about really grasping what's going on and making a choice based on that understanding.
Got it. So what's relevance then?
Relevance means that the consent has to be specific to the actual treatment being proposed.
So you can't just consent to one thing and have it apply to, everything.
Exactly. It's got to be targeted,
Yeah.
specific to the situation.
Okay, and informed consent. I hear that one all the time, but what does it actually mean?
That's probably the most important one. It means the person giving consent, they have to have all the info they need. The nature of the treatment, the risks, the benefits, any alternatives, the whole picture.
Wow, so it's really about making sure they understand everything before making a decision, not just signing a form.
Exactly. It's about empowering them.
Okay, makes sense.
Yeah.
And what about the last two, voluntary and no misrepresentation?
Voluntary just means that the consent has got to be given freely, no pressure, no coercion.
Got it. And no misrepresentation.
The info that's provided has to be accurate, no trickery.
Okay, so it's about being transparent and honest.
Exactly. All 5 of these elements, they work together to make sure consent is truly meaningful, respecting the person's right to choose.
I see. But what happens if there's no time to get consent, like in a real emergency?
Yes. Then we're talking about emergencies. That's a whole other conversation.
Okay, because then it's all about acting fast, right?
Yeah, sometimes you have to move quickly.
So how do you balance that with, like, respecting the patient's wishes?
Well, first we got to be clear about what an emergency actually is.
Yeah.
Usually it means someone's in serious danger and immediate action is needed.
So, like, life or death situations.
Yeah, exactly. And for those situations, there are specific protocols to guide medical professionals.
Okay, so there's a plan in place, even if things are happening really fast.
Right. They're designed to make sure care is given quickly and effectively, even when there's no time to get, explicit consent.
And are those protocols based on, like, some kind of official standards?
Yes. One of the key ones is the Basic Life Support Patient Care Standards. We call it BLS-PCS for short. It gives clear guidelines for paramedics and other healthcare providers on how to handle different emergencies.
That's good to know. Makes me feel a little better knowing there's a system in place for those high-pressure moments.
Oh, for sure.
Huh.
But, of course, emergencies can still be complicated, ethically speaking. You don't always have all the information you need.
Yeah, I can imagine. So even with those protocols, it still takes careful judgment to, like, make the right call in the heat of the moment.
It does. It's about finding that balance between acting fast and still respecting the patient's autonomy, even amidst all the chaos.
Wow, this conversation has really opened my eyes to, like, how important medical directives are and how important it is to talk about our wishes with our loved ones, even if it's not always easy.
I agree. Open communication is key.
It can definitely prevent a lot of stress and heartache down the line. So while medical directives might not be the most fun topic to think about, they're definitely essential.
They are. It's about having a say in your own care, even when you can't speak for yourself.
It's about taking control of your healthcare journey, not just reacting to things, but shaping it the way you want.
And making sure your values are guiding your care every step of the way.
Well said. And speaking of shaping our healthcare journeys, let's dive into some specific situations where medical directives can be especially valuable. Explore how they can help us navigate different circumstances, make sure our care really aligns with what we want.
One area where medical directives can be super helpful is with chronic illnesses. Like, imagine someone with Parkinson's disease, something that gets worse over time.
Right, because it's not just about emergencies, right? It's about thinking ahead, planning for the long term.
Exactly. As the illness progresses, they might not be able to communicate as well.
Yeah, that makes sense.
So a medical directive can, lay out what they want. Specific treatments, pain management, even end-of-life care.
It can be a huge relief for their family, too, knowing those tough decisions were already made.
Oh, absolutely. Takes a lot of the pressure off.
So it's about being proactive, I guess, not just reacting to things as they come up.
Right. It's about having a plan.
Now, this makes me think about, what about people with, like, strong religious or cultural beliefs? How do medical directives handle that?
Oh, that's so important. You got to respect people's beliefs, right?
Yeah.
A medical directive can actually outline those specifics.
Okay.
So maybe someone has dietary restrictions because of their religion, or they want certain alternative therapies. It's all about making sure their care fits their beliefs.
It's about treating the whole person, not just the illness, huh?
Exactly.
Now, we've been talking a lot about serious stuff, but what about, like, everyday healthcare? Can you use a medical directive for that, too?
That's an interesting question. I mean, traditionally, they've been for serious illness or end-of-life care, but things are changing.
How so?
People are getting more proactive about their health. They want to say in every aspect, not just the big stuff.
So, like, what could you put in a medical directive for everyday health?
Oh, all sorts of things. How often you want checkups, what screenings you're open to, even how you prefer to communicate with your doctor.
So it's like a healthcare mission statement, I guess.
I like that. It's about taking ownership.
This is making me realize we've been talking a lot about the individual, But what about their family? The people close to them.
Oh, they're a huge part of this.
Right. Especially when tough decisions have to be made.
Medical directives can actually help families. If everyone knows the patient's wishes beforehand, it can prevent a lot of arguments.
It takes the pressure off for sure. But what if the family doesn't agree with what's in the directive?
That's tough.
Huh.
But that's where communication comes in. You got to talk things through, try to understand each other's perspectives.
So the directive isn't like the final word.
It's a guide, but it's not set in stone.
Okay, that makes sense. What if things get really complicated, like emotionally?
Sometimes it helps to bring in a third party, a
Right.
doctor, a counselor, someone who can help everyone communicate.
So everyone can make the best decision, even if it's hard.
Right. And hopefully one that honors the patient's wishes.
Okay, let's shift gears a little. We talked before about consent, but what about when someone can't give consent? You mentioned something called a prior capable wish, I think.
Ah, yes. That's when someone made their wishes known before they lost the ability to communicate.
Okay.
So maybe they said they wouldn't want to be resuscitated if their heart stopped. Even if they can't say that now, we should still honor that wish.
It's like capturing their voice, even if they can't speak anymore.
Exactly.
But what if there's no written record of that wish, or they never explicitly said it?
That can be tricky. In those cases, you have to rely on people who knew them well. Family, friends, anyone who can shed light on what they would have wanted.
It's like putting together a puzzle, huh? Trying to figure out what they truly would have chosen.
In a way, yeah. You're trying to honor their values, even if you don't have all the answers.
This is really emphasizing how important those conversations are. Talking to your loved ones about your wishes while you still can.
Couldn't agree more. The more information you can give, the better. It makes things so much easier later on.
Okay, we've been focused on medical directives for, serious situations. But what about mental health? Can you use them for that, too?
Absolutely. Just like physical health, you can outline your preferences for mental health care too.
So someone could say what kind of therapy they want, or medications they want to avoid.
Exactly. And also, what helps them cope when they're feeling stressed?
So if they have a mental health crisis, there's already a plan in place.
Exactly. It can make a huge difference.
This all goes back to that idea of being proactive, right?
Well,
Thinking ahead, planning for different situations,
it's about taking control of your health, both physical and mental.
and making sure your voice is heard.
Exactly.
Okay, so we've covered a lot of ground here, but let's get practical. How does someone actually go about making a medical directive? Is it complicated?
Not really. Most places have standard forms you can just fill out.
You don't need a lawyer or anything.
It can be helpful, but it's not always necessary.
Okay, what about witnesses? Or do you have to get it notarized?
Yeah, the rules vary depending on where you live.
Yeah.
But usually you need a couple of witnesses, people who aren't going to inherit from you or anything.
Makes sense. So you got to check the specific requirements for your state.
Yeah, exactly. And it's good to double check every few years. Laws can change.
Okay, good to know. So once you have it, you're good, right?
Well, not exactly. It's good to review it every now and then. Make sure it still reflects your wishes.
Because things change, right?
Yeah, life happens. You might
Oh.
get married, get divorced, have kids, get a new diagnosis.
So it's not a one-time thing, it's more like an ongoing process.
Exactly.
This makes me think about technology. Are there apps for medical directives?
Oh, yeah. Lots of them. They let you create, store, and share your directive all in one place.
That's cool.
It makes things a lot easier.
It seems like we're getting more and more options for managing our health information, huh?
For sure. And it's only going to get better as technology keeps advancing.
Now, I know some people might feel a little hesitant about medical directives, it's a scary topic.
I get that. But one of the biggest misconceptions is that they're only for older folks.
Yeah, we've talked about that. They're for anyone, really.
Right. No matter your age or health, it's about having a voice in your care.
The other thing I think people worry about is having to think about serious illness or death.
It's not easy, for sure. But honestly, having those conversations can be a real gift to your loved ones.
I see what you mean. It takes the burden off them later on.
Exactly. And remember, you don't have to do it alone. There are people who can help.
Yeah, like a therapist or a counselor, someone to guide you through those tough conversations.
Exactly. So don't be afraid to reach out for support.
Okay, as we wrap up this part of our deep dive, I want to ask you about the future. Where do you see healthcare planning going?
One thing I'm really excited about is personalized medicine.
Personalized medicine.
Yeah, it's about tailoring treatments to each individual, their genes, their lifestyle, their preferences.
So not just a one-size-fits-all approach.
Right. And as we learn more about genetics, it's only going to get more personalized.
This makes me think about like AI and all that.
Yeah,
Could that play a role in healthcare planning?
absolutely. AI can help us analyze huge amounts of data,
Huh.
predict health risks, personalize treatment plans. It's pretty amazing.
It sounds like technology is going to play a big role in the future of healthcare.
Oh, for sure. But we got to be careful, too. Make sure it's used ethically,
Mm-hmm.
always with the patient's best interests in mind.
That's a really good point. It's not just about the technology itself, it's about how we use it.
Exactly. And at the end of the day, it all comes back to medical directives and making sure people have a say in their own care.
It's about respecting their wishes, their values, no matter what challenges they might face.
I like that. It's about giving people control over their health journey, helping them shape their own future.
It's been quite a journey, learning all about medical directives and why they're so important.
Yeah, it's really about, taking control of your own healthcare, making sure your voice is heard.
Right. And realizing that things change, your wishes, your priorities, they might evolve over time.
Exactly.
So as we wrap up this deep dive, I want to leave our listeners with something to think about, something big.
Okay, I'm intrigued.
We've talked a lot about medical directives for like the tough stuff, serious illness, end of life care. But what if we use them for like everything?
Everything.
Yeah, like what if it became a tool for proactive healthcare, not just reacting to illness, but actually promoting wellness?
I like that. So instead of just focusing on what you don't want, you're also saying what you do want in terms of staying healthy.
Exactly. Imagine outlining your preferences for like preventative care, routine checkups, healthy lifestyle choices, all that.
It would be like a roadmap for a healthier life.
Exactly. Your medical directive could be a reflection of your commitment to well-being. You could say, how often you want to see your doctor, what kind of exercise you enjoy, even your thoughts on nutrition.
It's like a personal health manifesto.
It is. It's about taking charge from the beginning, not waiting until something goes wrong, making conscious choices that align with your values.
And empowering people to be active participants in their own healthcare.
Yes. So, dear listener, we encourage you to think beyond those traditional uses of medical directives. Think about how they can help you create a healthcare journey that reflects your values, your goals, your vision for a healthier life.
It's about moving from fear to empowerment, taking control of your health destiny.
Beautifully said. And remember, you don't have to figure this all out on your own. Talk to your loved ones, your doctor, do some research.
There are so many great resources out there. Don't be afraid to ask for help.
This has been such an enlightening deep dive into the world of medical directives. Hopefully, you're feeling inspired to take charge of your own healthcare journey.
It's been a pleasure joining you for this conversation.
And a huge thanks to you, our listener, for joining us on this deep dive. Until next time, stay curious, stay informed, and keep those knowledge gears turning.
Hey everyone, and welcome back for another deep dive. You know how we do things around here. We take something complex, maybe even a little controversial, and we break it all down.
Into manageable pieces.
Yeah, exactly. So today we're looking at newborn resuscitation guidelines. And we're focusing on the ones used specifically by paramedics here in Ontario, Canada.
Oh, this is interesting stuff. Most people just assume it's like, oh, baby's not breathing, you start doing CPR.
Right.
Hmm.
But it's actually so much more complicated than that.
Oh, yeah, way more. There's gestational age to think about and ethical considerations and the whole question of like when to intervene and when to kind of let nature take its course.
Heavy stuff. And to guide us through this, we have an expert in the field. So
Happy to be here.
I'm really curious to hear what you found in these guidelines. What are some of the big takeaways?
Well, right off the bat, what strikes me is how carefully these guidelines lay out exactly when a paramedic can step in and do things like newborn resuscitation.
Right, because paramedics have different scopes of practice than, say, a doctor in a hospital.
Exactly. So there are specific conditions that have to be met before a primary care paramedic in Ontario is even authorized to perform newborn resuscitation. It's all very clearly spelled out.
Yeah, and even the very first step, like the indication for even looking at these protocols, it's pretty basic.
Yeah, it's basically, is there a newborn patient? That's the trigger.
Right, but then it gets super specific.
Oh, absolutely. Like with positive pressure ventilation or PTV, they focus a lot on the newborn's heart rate.
That's what I noticed too. And it's interesting because things like respiratory rate and blood pressure, they're not even part of the picture here.
And that's because with newborns, heart rate is the most reliable indicator in those first few minutes of life.
So if you're a paramedic arriving on scene, you're assessing the situation. You see a newborn in distress, less than 24 hours old, and their heart rate is below 100 beats per minute.
That's when PPV comes into play.
Okay, so you're basically helping the baby breathe using a mask and bag, right?
Exactly. It's all about increasing those oxygen levels.
Makes sense, and I'm assuming this is different from CPR.
You got it. CPR is reserved for even more critical situations.
Because the guidelines say CPR kicks in when the heart rate is below 60 beats per minute.
Yeah, so if you've been doing PPV for 30 seconds using room air and the heart rate hasn't gone up above 60, that's a sign that things are getting pretty serious.
Right, it's like the baby's not responding to the less invasive help.
Exactly, and that's when you move to CPR, which involves chest compressions and rescue breaths, a much more aggressive approach.
And this is where things get even more ethically complex, because the guidelines also mention CPR for newborns who are considered obviously dead, according to basic life support standards.
Right, and this is always tough, you know? Paramedics are often the first on the scene, and they have to make these incredibly difficult judgment calls.
Like, when is resuscitation just not going to be effective?
Yeah, exactly. The guidelines acknowledge that sometimes resuscitation just isn't going to work. Like, there are times when a newborn's condition is so severe that it's considered futile.
Yeah. It's a sensitive topic for sure. And then there's the whole issue of gestational age, which adds another layer of complexity.
Oh, for sure. And the guidelines actually highlight infants born between 20 and 25 weeks gestation.
And why is that?
Well, babies born that prematurely are incredibly fragile. Their organs are still developing, and they're at such high risk for complications.
So if you're dealing with a baby born between 20 and 25 weeks...
The guidelines recommend immediate resuscitation and transport to an ICU, a specialized neonatal intensive care unit where they can get the care they need.
So what happens if you don't know the gestational age for sure? Like, what if it's unclear?
The guidelines are pretty clear on this. They basically say, when in doubt, resuscitate. It's about giving these tiny humans every possible chance.
Makes sense. But then on the flip side, there are cases where the guidelines say no resuscitation.
Yeah, for newborns under 20 weeks gestation, the chances of survival are just so low that resuscitation is generally not recommended.
Wow. So in those cases, what happens?
Well, it shifts to more compassionate care, like keeping the baby warm and making them comfortable.
And it mentions consulting with a BHP.
Right, a base hospital physician. So they can provide guidance and support to the paramedics and the family in these very, very difficult situations.
Yeah. It's got to be tough, But it's good that the guidelines take those ethical considerations into account.
Absolutely. And they also really emphasize involving the parents in the decision-making process, providing support, respecting their wishes.
Because at the end of the day, this is about real people.
Absolutely. Real people facing incredibly tough choices.
So as we've seen, these guidelines are a roadmap for paramedics facing these incredibly difficult and often emotional situations. They really try to balance the need to intervene with the limits of what medicine can do.
And don't forget, there are tons of resources out there for those who want to learn more about the actual techniques like PPV and CPR.
Yeah, if you're interested in the nitty-gritty details, definitely check out the Heart and Stroke Foundation of Canada guidelines.
Those will give you a really good overview.
Well, this has been a really eye-opening look into the world of newborn resuscitation.
Definitely not as straightforward as people might think.
Big thanks to our expert for walking us through all of this.
My pleasure. Always happy to talk about this stuff.
And all our listeners out there, thanks for joining us for another deep dive.
Keep those brains working.
Until next time.
See ya.
All right, so you know how everyone talks about allergies this time of year?
Yeah, the sniffles and the sneezes, the whole 9 yards.
Exactly. Yeah. But today we're going deeper.
Way deeper.
Like way past those seasonal sniffles.
Right into the serious stuff.
Yeah, the kind of allergic reactions that can actually be life-threatening.
Yeah, exactly.
So we're talking anaphylaxis.
That's right. And to help us navigate this topic, we're going to be looking at some guidelines.
Oh, cool. Which guidelines?
These are the guidelines from the Ontario Ministry of Health.
Okay.
And they're specifically the guidelines that are given to paramedics.
Oh, wow. So this is like an inside look.
Yeah.
At how first responders handle these really scary emergencies.
Absolutely. When it's, life or death.
So these paramedics, what are the most important things that they need to know? Yeah.
So the first thing is being able to recognize the severity of the situation. So knowing the difference between a mild allergic reaction, which maybe just causes some hives or, a little bit of itchiness, versus a full-blown anaphylactic reaction where it's a true emergency.
Okay, so there's like a spectrum of of allergic reactions.
Absolutely.
Okay, so how would a paramedic tell the difference?
Yeah, that's a really good question. So there are a few key signs and symptoms that they're trained to look for.
Okay,
And these are things like difficulty breathing,
that makes sense.
swelling, especially in the face, the lips, the tongue, the throat,
Oh, wow.
a sudden drop in blood pressure, so the person might feel faint or dizzy,
Okay.
and then even a change in their mental state. They might become confused, anxious, or even lose consciousness.
Oh, okay. So it's not just like a physical thing. It can really affect the brain.
Yeah, absolutely. It can affect multiple body systems all at once, which is what makes it so dangerous.
So I know epinephrine is like the go-to medication in these situations.
Yeah, it's the first line of defense. But why? Like, what makes it so important?
Well, basically, in anaphylaxis, your body's going into a state of shock.
Okay.
And that means that your airways can close up rapidly, your blood pressure plummets, and your organs start to get deprived of oxygen.
Oh, wow.
And epinephrine, it's like hitting a reset button.
Oh,
It acts almost instantly to open up those airways, constrict the blood vessels so it raises the blood pressure,
okay.
and it just helps stabilize the situation.
So it's really like it buys them time.
It does, yeah. Every second counts in these
I
situations.
bet. So something I noticed in the guidelines was that they mention a very specific concentration and dosage of epinephrine that needs to be used.
Right.
And you might think, oh, it's just an injection. How complicated can it be?
Right.
But clearly, there's more to it than that. So what's the deal with that?
Well, the specific concentration that's recommended is 1 milligram per milliliter.
Okay.
And you'll also see it written as a ratio 1.1 thousand.
That means it's the same thing. And then the dosage, that's calculated based on weight.
Okay.
So it's 0.01 milligrams per kilogram of body weight.
So you got to do a little bit of math there
Yeah, you do.
to make sure you're giving the right amount.
Exactly, because giving too much epinephrine can actually cause problems,
Oh, okay.
like heart problems and other complications.
So it's really important to get it right.
Yeah.
So are there any limits on how much epinephrine can be given at one time?
Yeah, there is. The maximum single dose is 0.5 milligrams for adults.
Okay.
And paramedics have to wait at least 5 minutes between doses.
Okay, so they can give multiple doses.
They can,
Yeah.
but they have to monitor the person very carefully and make sure that they're responding to the medication and they're not having any adverse effects.
Got it. So epinephrine's the first line of defense, but what about some of these other medications?
Mm-hmm.
Like diphenhydramine, Benadryl.
Right.
Where do they fit into all of this?
So diphenhydramine is an antihistamine.
Okay.
And during an allergic reaction, your body releases histamine.
Okay.
And histamine is what causes a lot of those uncomfortable symptoms, like the swelling, the itching, the redness.
The highs and stuff?
Yeah, exactly. So diphenhydramine blocks the effects of histamine, and that helps reduce those symptoms and control the overall allergic response.
So it's not just for mosquito bites then?
No, not at all.
Okay, interesting. But it's not considered like the primary treatment though, is it?
No, you're right. It plays an important supporting role.
Okay.
But epinephrine, like we were talking about before, is really the one that's going to address those immediate life-threatening effects of anaphylaxis.
Okay.
And then diphenhydramine, that's going to come in and help to kind of further manage the allergic reaction and reduce the discomfort.
Okay, so they work together as a team,
They do.
but epinephrine is the captain.
Yeah, exactly.
Okay, and I think I remember in the guidelines they talk about the dosage of diphenhydramine being different based on weight.
Yes, that's right. So for individuals between 25 and 50 kilograms, it's 25 milligrams.
Okay.
And then for those who are 50 kilograms or above, it's 50 milligrams.
So it's pretty straightforward cutoff there.
Yeah, it is.
25 to 50 is one, and then above 50 is the other one.
Mm-hmm.
Okay. So can paramedics just give this intravenously?
That's a good question. So actually, IV administration of diphenhydramine is something that that's reserved for paramedics who have received special training and authorization.
Oh.
So not every paramedic can give it that way.
Right, because giving medication intravenously can be more risky.
Exactly. It's a more advanced skill.
So they need to have that extra training.
Yes.
So we've gone over a lot of information about medications and stuff, but what would you say is like the biggest takeaway that our listeners should get from all this?
I think the most important thing is understanding that a severe allergic reaction is a serious medical emergency.
Right. It's not something to mess around with.
It's not. You need to know the signs of anaphylaxis, you need to act quickly, and you need to use the right medications correctly.
Mhm.
And that can really be the difference between life and death.
Absolutely. It's funny because you think about latex allergies. You always think about, oh, those are healthcare workers.
Right.
Those are the people who have to worry about latex allergies.
Hmm.
But apparently, latex allergies are becoming more common in the general population
Oh, wow.
because latex is in so many everyday items.
That's interesting. I didn't know that.
Yeah, so it goes to show you that allergies can be really unpredictable.
Yeah.
And you never really know when you might come across something that you're allergic to.
Absolutely. So preparedness is key.
So we have a question for our listener out there. Do you know what to do if you or someone around you experiences a severe allergic reaction?
Mm-hmm.
Would you recognize the signs?
Mm-hmm.
And would you know how to respond?
It's a good question to think about.
Absolutely. And while this this deep dive has hopefully given you some valuable insights, it's really important to remember that this information is not a substitute for professional medical advice.
Yes, absolutely.
If you have any concerns about allergies or your health, always talk to your doctor or healthcare provider.
That's right.
Stay informed, be prepared, and stay safe out there.
Exactly. All right, welcome everyone. Today we're diving into something that might sound kind of dry at first, but trust me, it's way more interesting than you think. We're talking about pain management.
Pain management.
Yeah, but specifically for paramedics here in Ontario. Like what do they actually do when someone's hurting? It's not just as simple as like handing out aspirin, right?
Absolutely not.
So to get this right, we're going straight to the source. The Analgesia Medical Directive from the Ontario Ministry of Health.
Yes, their official guidelines.
Exactly, like the rule book for dealing with pain out in the field.
It's essential reading for any paramedic, that's for sure.
Especially those prepping for their exams. But even if you're not, on the ambulance crew, I think it's fascinating to peek behind the curtain a bit, see how these decisions get made.
Definitely. And one of the first things that this directive emphasizes, and it might surprise you, is how subjective pain really is.
Subjective, you mean like what hurts one person might not bother another?
Exactly. There's no universal pain scale. What might be a 10 out of 10 for me might be a 3 for you.
So how on earth does a paramedic figure out what to do then, if there's no pain meter to check?
Well, that's where good communication comes in. They have to rely heavily on the patient telling them about their pain.
Okay, so asking lots of questions. Where does it hurt? What kind of pain is it?
Exactly. Location, intensity, all of that. And then, of course, the paramedic is also checking vital signs, looking for any other clues.
Right. Makes sense. But then, okay, let's say they've got a good handle on the situation. What are their actual options for, pain relief meds?
This directive focuses on 3 main ones. You've probably heard of them. Ibuprofen, acetaminophen, and ketorolac.
Wait, hold on. Ibuprofen, that's just dullest, really.
And acetaminophen is Tylenol.
Yep, and ketorolac is the generic name for Toradol.
Oh, okay. So stuff most people have in their medicine cabinet. But I'm guessing a paramedic can't just, dish them out to anyone who asks.
Definitely not. There are some pretty strict rules in place. Like what? Give me an example.
Well, first off, the patient has to be at least 12 years old.
Mm-hmm.
And they have to have what's called an unaltered level of awareness.
Unaltered. So basically awake and able to talk.
Exactly. They have to be able to understand what's going on and accurately describe their pain. Makes sense, right?
Yeah, totally. But what about beyond that? Are there other conditions for each specific drug?
Oh, tons. And this is where it gets really interesting, I think, from a paramedic's perspective. They have to be like detectives, basically.
Detectives!
Well, because each medication comes with this whole list of contraindications. Basically, reasons why you wouldn't give it to someone.
Don't give this if. Okay, I'm starting to see the detective work.
Right. They have to consider the patient's entire medical history, what other meds they might be on, allergies, everything.
Okay, so give me a for instance. When would ibuprofen be a no-go?
Let's say someone's had a recent head injury, like a concussion.
Concussion, okay.
Giving them ibuprofen could actually increase the risk of bleeding in the brain because it messes with blood clotting, you see.
Whoa, really? I never knew that. So even seemingly harmless painkillers
Can have serious consequences if they're not used carefully.
Exactly. And then it's not just about, like, obvious injuries either. They have to think about drug interactions.
Oh, right, like if someone's already on blood thinners.
Exactly. Giving them ibuprofen on top of that could be really dangerous.
So they have to be like part pharmacist too, keeping track of all those interactions.
Exactly. It's like a mental puzzle, figuring out the safest approach for each individual.
Well, it definitely sounds a lot more complicated than I initially thought. But okay, while we're on this track, what about dosage? Is it always the same as like what's on the bottle at home?
That's a great question, and the answer is sometimes no.
Oh,
This directive actually gives a higher maximum dose for acetaminophen for adults when it's given in the field.
really? How much higher are we talking?
It's 1,000 milligrams for adults versus the usual 650 you see over the counter. That does seem like quite a jump. Are there ever, like, concerns about side effects at that level?
Well, of course, they always weigh the benefits against the risks. But that higher dosage is usually for situations where rapid pain control is really crucial.
I see. So it's not just a blanket rule, it's very much based on the specific situation.
Absolutely. They have to take everything into account, the patient's condition, the pain level, their medical history, to make the best decision.
Okay, now I'm really getting the sense of just how much goes into this. It's way more than just grabbing a bottle of pills and saying, here you go.
Right. It's about using their knowledge and experience to make the safest and most effective choice in a potentially stressful environment.
Exactly. Oh, and before we move on, I have to ask about something I saw in the directive. Renal colic. What even is that?
Think kidney stones.
Oh, ouch.
Yeah, not fun. Renal colic is that intense pain that comes with kidney stones.
Okay, that makes sense why the directive specifically mentions NSAIDs for that, like ibuprofen.
Right, because those NSAIDs are good at targeting inflammation, which is a big part of renal colic pain.
Fascinating. So it's like different kinds of pain might call for different strategies.
Exactly. Paramedics have to be able to tailor their approach to each individual situation.
Okay, so we've covered the basics, the rules, the meds themselves. But I'm curious about different ways of giving the meds. I noticed the directive mentions IV ketorolac.
Ah, yes. So most often, those medications are given orally as pills.
All right, that's what I figured.
But some paramedics have additional training that allows them to administer certain meds intravenously.
Intravenously. Okay, so like directly into the bloodstream.
Exactly. Ketorolac is one of those, and it's typically reserved for cases where you need faster pain relief or when someone can't take anything by mouth.
Wow, so there are even levels of expertise within the field of paramedicine.
Exactly. It just goes to show you there's a whole world of knowledge and experience that goes into being a paramedic. It's incredible.
All right, well, listeners, I don't know about you, but I'm already feeling like I've learned a ton in just this first part of our deep dive. We started with some basic painkillers, and now we're talking about different ways to administer them, special considerations. It's really amazing how much goes into it.
And we've only just scratched the surface. We've laid the groundwork, but now it's time to see how all of this actually plays out in real-world scenarios.
Okay, I'm definitely intrigued. Bring on those scenarios.
All right, so welcome back to our pain management deep dive. Last time we were talking about all those guidelines, all those rules.
Yeah, all that stuff in the Analgesia Medical Directive.
Right, from the Ministry of Health. But now it's time to get practical. Let's see how those guidelines actually play out, in real life.
Okay, yeah, I'm ready to see how it all works on the ground.
Okay, let's picture two different scenarios, two different patients. First up, you're responding to a call, and you've got a patient with a sprained ankle.
Sprained ankle, okay. Like, they fell playing basketball.
Exactly. They're young, healthy, 20 years old, no allergies, no major medical history to speak of. The pain's just in the ankle. Vital signs are all stable. Pretty straightforward.
Okay, yeah, that does seem pretty classic. So what would be the first steps in managing their pain?
Well, you'd start by getting a good history from them, right? Making sure all those details you just mentioned are actually accurate. Asking about any past injuries, previous sensitivities to meds.
Right, got to make sure they're not allergic to ibuprofen or something.
Exactly. And assuming everything checks out, the source of the pain is obvious, no other red flags, you'd probably offer them either ibuprofen or acetaminophen.
So in a case like this, it's almost like the paramedic could give the patient a choice between those two.
Yeah, pretty much. It's about respecting their preferences, as long as it's safe to do so, of course. You empower the patient, you give them some agency.
Makes sense. Okay, so that's scenario one, pretty clear cut. But what about a case where it's not so easy?
All right, picture this. You arrive on scene, and the patient is a 65-year-old, and they're having chest pain.
Oh, wow. Okay. That's a whole different ballgame.
Right. And they have a history of heart problems, and they're already taking a bunch of medications, including blood thinners.
This is where it gets tricky, right? All those contraindications we talked about.
Exactly. This is where that deep knowledge is crucial. Chest pain, huge red flag. Giving certain painkillers could actually make things worse. Or mask symptoms.
So ibuprofen is out of the question, right?
Most likely, yes. Too risky with the potential heart issues and the blood thinners. Plus, this patient needs to get to the hospital, like yesterday. Giving them certain meds could complicate things at the hospital.
I see, yeah. The pain relief is almost secondary at that point, right? You
Mm.
just got to get them stable. But, I mean, they're obviously in distress. What can the paramedic do for the pain while they're getting them to the hospital?
Well, in a situation like that, the focus shifts to other ways of managing pain. Non-medication stuff. Making sure they're positioned comfortably, providing reassurance.
Right, just being calm and supportive.
Exactly. Monitoring their vitals super closely. They might give them oxygen, maybe
Yeah.
consider some other interventions depending on the specifics.
So it's not always about reaching for the meds, right? Sometimes it's about those other skills.
You got it. Paramedics are trained to think holistically, see the big picture, especially when it's a complex case like this. But what if, in this same scenario, you also find out the patient has a history of stomach ulcers?
Uh-oh. Weren't stomach ulcers one of the things we said you shouldn't give ibuprofen for?
You're remembering perfectly. And in a case like this, even acetaminophen might not be the best idea. Could irritate their stomach even more.
Okay, so now both of our usual go-tos are off the table. What happens then? Patient's in pain, but all the meds have potential problems.
Right.
What does the paramedic do?
That's when it gets really, really challenging. They might try to contact a physician for guidance, weigh the risks and benefits super carefully for any possible option.
I imagine there's no perfect answer in a situation like that, right?
Sometimes, yeah. It comes down to picking the least harmful option, even if it's not ideal.
Wow. That's a lot of responsibility, isn't it? Making those judgment calls.
Absolutely.
Yeah.
And that brings us to a really important point, which is all of these individual patient decisions, like we've just been talking about, they actually raise bigger questions about pain management as a whole.
Bigger questions like what?
Like, what are the ethics involved? What are the implications for society? You know, the big picture stuff.
Okay, yeah, now you've really got me thinking. Okay, so we've gone deep, haven't we? Like really deep into the specifics of how paramedics in Ontario deal with pain.
We have all the rules, the medications, those tough decisions they sometimes have to make.
Right. But like you said down at the last part, all those individual cases, they bring up even bigger questions, right?
Mhm.
About how we think about pain as a society.
Exactly. Because pain, let's be honest, it's universal. Everyone experiences it at some point.
Oh, yeah, for sure. It's not like a problem that just paramedics have to worry about.
Right. And the way we manage pain, whether it's a little stub toe or like a chronic condition, it has consequences, like ripple effects on all sorts of things.
Okay, ripple effects, like what? Give me an example.
We'll think about the economic side of things. Chronic pain can lead to people missing work, less productivity.
Mhm.
They might need more healthcare resources.
Right, makes sense. Those costs add up both for the individual and for like the system as a whole.
Exactly. And it's not just about money either, right?
Mhm.
Chronic pain can impact mental health, relationships, just the ability to, enjoy life.
Oh, absolutely. I can see how it would lead to isolation, depression, just feeling hopeless.
Exactly. So effective pain management is not just about treating those physical symptoms. It's about the whole person, their well-being on every level.
Now, I know we've been zeroing in on those Ontario guidelines to deal with like ibuprofen, acetaminophen, that sort of thing.
Right, the common stuff.
Yeah.
Yeah.
But we can't talk about pain without at least mentioning, well, the opioid crisis.
You're right. It has to be part of the conversation. Opioids, they can be effective for severe pain, but they also come with huge risks. Addiction, overdose.
Yeah. Finding that balance between providing relief and preventing harm, it's tough.
It really is. It feels like we're at this turning point, I think, in how we approach pain management.
A turning point.
Yeah, like on the one hand, we have to acknowledge pain. It's a serious issue and it deserves attention, treatment.
But on the other hand,
On the other hand, we have to be really careful about over-relying on medications that can have these devastating side effects.
right, it's like a tightrope walk. So what's the answer then? What's next?
Well, that's why research and innovation are so important. We need to keep exploring new approaches, no meds, even new ways of thinking about pain itself.
So what's out there? What are some of the things people are working on?
One area that's really promising is what we call non-pharmacological approaches. So basically, not just relying on pills.
Like what?
Think physical therapy, mindfulness techniques, acupuncture. Some people are even using virtual reality.
Hold on, virtual reality for pain? What? How does that even work?
It's pretty cool, actually. They use those VR headsets to create these immersive experiences. And it basically distracts patients from their pain.
So it's like tricking their brain into focusing on something else.
Exactly, like a high-tech form of distraction.
Wow. It sounds like pain management is becoming much more like personalized, multifaceted.
Exactly. No more one-size-fits-all solutions.
Well, listeners, I think we've covered a lot of ground today, haven't we? We started with those very specific rules for paramedics in Ontario.
And now we're talking about the future of pain management.
Right. What a journey. But as we wrap up, I think you had one final thought you wanted to leave our listeners with.
They did. We've talked about how pain affects everyone, but there are some groups that face extra challenges. Like imagine being a child who can't really articulate what they're feeling, or an elderly patient with a whole bunch of other health issues.
That's such an important point. Like, there's so much more to explore here, even beyond what we've talked about today.
Exactly.
Yeah.
It's up to all of us to keep learning, keep asking questions, and keep pushing for better pain management for everyone.
Well said. Well, on that note, I think we'll let our listeners continue their own deep dives into this fascinating, complex topic.
Thanks for joining us, everyone.
We'll see you next time for another deep dive into something that matters.
Ever wonder what really happens in the back of an ambulance? Like, what do paramedics actually do?
Yeah, it's pretty amazing.
Today, we're going deep
It is.
into the world of paramedics in Ontario.
Uh-huh.
Specifically, all the procedures they're trained to perform
Yeah.
in those like really intense situations when every second counts.
Yeah. You might be surprised at the sheer range of skills that these first responders possess.
Okay, so walk me through this.
We're going to break down an
Mhm.
official document
Hmm.
called
It's called the 2023
the 230201
dash 02
-01
underscore V5.1
underscore V5.1
companion document.
companion document.
apdnex.pdf.
Get pdnext.pdf. But
We're not going to go through the whole thing.
no.
We're focusing on Appendix A,
Right.
the part that reads like a real-life medical thriller.
It is fascinating stuff.
Oh, really?
One thing that struck me is how this document highlights the importance of standardized procedures
Okay.
for paramedics across Ontario. So that means no matter where you are, you can expect a consistent level of care.
That makes a lot of sense.
Right.
It's reassuring to know that there's a system in place.
Yeah.
Especially, when you're dealing with an emergency.
Absolutely.
Okay, so what kind of procedures are we talking about?
Imagine
Yeah.
a paramedic kneeling on the ambulance floor,
Okay.
helping deliver a baby.
Uh-huh.
That's coming out feet first.
Oh, wow.
That's called a breech birth.
Oh, my goodness. Okay, that's definitely got the drama factor.
Right.
I wouldn't even know where to begin.
So paramedics are trained to use a technique called the Mariso-Smellie-Veit maneuver,
Okay.
or MSV,
MSV.
to guide the baby's head out safely.
Oh, okay, got it. But what's really striking is they only have 4 minutes
Yeah,
to deliver the head once the umbilical cord is visible.
that's right.
Like, that is intense.
Time is critical in these situations.
Yeah.
And it's not just breech births.
Okay.
Think about a shoulder dystocia,
I've heard of that.
where the baby's shoulder gets stuck during delivery.
Oh, wow. I
Yeah.
can only imagine the panic in that situation.
Paramedics follow a specific set of maneuvers known as ALARM
Oh, wow.
to quickly and safely address the problem.
Okay, so break that down for me.
So the ALARM acronym actually walks them through each step.
Interesting.
So it's A, ask for help.
Okay.
L, legs abduction.
Legs abduction. Okay.
A, adduct shoulder.
Okay.
R, rollover.
Gotcha.
And M, manually release posterior arm.
Wow. Okay, so they've got that acronym to just walk them through it step by step.
Exactly.
So how much time do they have?
They have about 8 minutes
8 minutes.
from the time the head is delivered to resolve the situation.
Oh my goodness, that's incredible.
It
It
is.
seems like paramedics are trained to handle complications that most people would only associate with a hospital setting.
Absolutely.
Like, I wouldn't think that you would ever encounter that outside of a hospital.
Right. Wild. And speaking of situations that might seem more at home in a hospital drama, let's talk about cricothyrotomy.
Okay, that one sounds intense.
It is.
Cricothyrotomy.
So is that what they do when someone's airway is completely blocked?
Yeah, that's my understanding.
Exactly.
Okay.
A cricothyrotomy is a surgical airway procedure where they create an opening in the trachea
Okay.
or windpipe to allow the patient to breathe.
Wow.
It's truly a last resort in a life or death situation.
And they can do that in the back of a moving ambulance.
Mm-hmm.
It's mind-blowing the level of skill and knowledge they possess.
It really is.
I mean, I'm just constantly learning about all this stuff.
So and remember, we're just scratching the surface
Oh, really?
of what Ontario paramedics are trained to do.
So if you're ever wondering who to call,
Right.
when you're facing a real-life medical thriller,
You know who to call?
you know who to call paramedics.
911.
But before you do that, let's dive deeper into some more of these fascinating procedures.
It's amazing to think about, right, all the tools and techniques paramedics have at their disposal
It really is.
right there in the ambulance, I mean.
Right. We were talking about cricothyrotomy before the break.
Mm-hmm.
What other procedures can they perform
Well,
that would normally require a hospital?
one that comes to mind is transcutaneous pacing.
Transcutaneous pace.
It's essentially like a temporary external pacemaker.
Hold on. Are you telling me they can regulate a heartbeat outside of a hospital?
Yeah.
How does that even work?
It's pretty ingenious, actually.
Uh-huh.
They use electrodes placed on the patient's chest to deliver electrical impulses that help the heartbeat at a regular rhythm.
Wow.
It can be a real lifesaver until the patient can get to a hospital for more comprehensive care.
So it's like they're carrying a mini hospital with them wherever they go.
I know, it's amazing.
It's almost hard to believe.
I know, right?
Yeah.
But it's a testament to how much responsibility paramedics carry
Yeah.
and how critical their role is in our healthcare system.
Absolutely. And it's not just, those dramatic high-stakes procedures.
Right.
We talked about defibrillation earlier, which most people have heard of.
Right.
But even with something seemingly straightforward like that,
Yeah.
there are important nuances, right?
You're right. The document actually emphasizes the importance of minimizing hands-off chest time during CPR.
Oh, interesting.
Every second counts when someone's heart has stopped,
Right.
and it's all about coordinating efforts to give the patient the best possible chance of survival.
Okay, so it's about teamwork
Yeah.
and efficiency, making sure that everybody is working together seamlessly to get that done.
And speaking of teamwork, let's not forget about medication administration.
Okay.
It's not just about giving someone a pill.
Right.
Paramedics need to master different routes and techniques depending on the situation and the medication.
Well, this document we're looking at mentions everything from IVs and injections to delivering medication through the nose or even under the tongue.
Wow.
It's a lot to keep track of.
It is. And for each route of administration, they need to know the proper technique, the correct dosage, and potential complications.
Well-
It's like having a pharmacy on wheels,
Yeah.
with a whole other layer of knowledge and skill required on top of everything else they do.
Right. And even something that might sound simple, like suctioning tubes to clear airways,
Yeah.
has a level of complexity that I never would have imagined.
That's a great point. The document we're looking at outlines the specific steps for suctioning endotracheal and tracheostomy tubes,
Okay.
highlighting the importance of using the correct pressure and technique.
Wow. It's fascinating how even seemingly routine procedures require such a nuanced understanding of anatomy and physiology.
Yeah.
It really makes you realize just how much training and expertise goes into being a paramedic.
It's an ongoing process of learning and refinement.
Yeah.
And this document is just a glimpse into that world.
I'm curious what stood out to you most when you were going through this document. Is there a particular procedure or insight that really surprised you? It's amazing to think about the breadth of skills paramedics need to have, right? From managing airways and heart rhythms to assisting with childbirth. But I'm curious what happens after the baby is born.
That's a great question.
Yeah, like what? I wouldn't even know where to start.
Well, one procedure they might perform is an external uterine massage.
External uterine massage.
Mhm.
What's that all about?
It's a technique used to help the uterus contract back to its normal size after the placenta is delivered.
Okay.
This helps reduce bleeding,
Okay.
which can be a serious issue after childbirth.
So they're basically massaging the mother's abdomen.
Exactly. The document describes how the paramedic would place one hand on the lower abdomen to support the uterus and the other hand on the top of the uterus, gently massaging it in a circular motion.
Okay, so it sounds like a delicate balance
Yeah.
between applying enough pressure to be effective, but not causing any discomfort.
You're right. It requires a skilled touch and a good understanding of anatomy.
Right.
And speaking of anatomy, there's another procedure called external bimanual compression,
Uh-huh.
which is used in more serious situations when external uterine massage isn't enough to control bleeding.
Okay, that sounds a bit more intense. What's the difference?
With external bimanual compression, the paramedic uses both hands to compress the uterus between them, one hand on the lower abdomen and the other on the top of the uterus.
Wow, that sounds like a lot of pressure. But I guess in a life-threatening situation,
Yeah,
you have to do what you have to do.
absolutely. These procedures highlight the fact that paramedics aren't just responding to injuries and illnesses,
Yeah,
they're also providing critical care for mothers in the moments after childbirth,
of course.
which is a really important part of their job.
It's incredible how much they're trained to handle.
Yeah.
Going through this document has really opened my eyes to the complexity of paramedicine and the vital role that these first responders play in our healthcare system.
I completely agree. It's easy to take their expertise for granted,
Mm-hmm.
but when you really delve into the procedures they're trained to perform, it's truly impressive.
So after this deep dive, what's the key takeaway for our listeners? What do we want them to remember about the world of paramedics in Ontario?
I think the biggest takeaway is that paramedics are so much more than just ambulance drivers. They're highly skilled medical professionals who are constantly learning and adapting to meet the needs of their patients.
Yeah.
They're making life-saving decisions every day, often in extremely challenging circumstances.
Right, and it's not just about memorizing procedures from a document like this.
Right.
It's about critical thinking, problem solving, and having the compassion and resilience to deal with whatever comes their way.
Exactly, and it's something we should all be grateful for.
Absolutely. So the next time you see an ambulance go by, remember the incredible individuals inside, ready to respond to any emergency, no matter how complex.
And remember, we've only scratched the surface. There's a whole world of medical knowledge and innovation out there, and paramedics are at the forefront of it all.
That's a great point. It's a field that's constantly evolving, which makes it even more fascinating to explore. So to all our listeners out there, stay curious, keep learning, and never underestimate the power of a deep dive. All right, let's jump right in. Today, we're diving deep into how hypoglycemia is actually treated out in the field.
Yeah, because it's one thing to read about it, but another to, put that knowledge into action, especially under pressure.
Totally. And we're using a very specific source for this deep dive, the Hypoglycemia Medical Directive, used by paramedics in Ontario, Canada.
Real world stuff, right, from the Ministry of Health.
Exactly. So something that really surprised me was paramedics don't always need a confirmed blood sugar reading to start treatment.
Right, so it's all about suspected hypoglycemia.
Yeah.
The consequences of not treating low blood sugar,
Mm.
they're serious.
Like, how serious are we talking?
We're talking brain damage, even death. So paramedics are trained to act fast, even if they just suspect it's hypoglycemia.
So better safe than sorry.
Exactly. Better to be safe, right?
Yeah.
Way better than the risks of not treating it.
Makes sense. It's about recognizing how urgent it is. So what do paramedics actually DO? What tools do they have for suspected hypoglycemia?
Well, they've got two main treatments. Dextrose, which is a type of sugar, and then there's glucagon, which is a hormone, and that helps raise blood sugar.
Gotcha. So the goal is to get that blood sugar back up and fast. But I imagine it's not just like a one-size-fits-all dose.
Nope, not at all. This directive gets very specific about the concentration of dextrose they use.
Concentration?
Yeah, like whether it's a 5% solution, 10%, even 50%, basically how much sugar's in it.
Oh, okay.
Then there's how they give it. With dextrose, it's always intravenous through an IV, and then of course the actual dosage. That depends on the patient's weight, and there are maximum limits too.
So many things to consider, even in those first couple of minutes.
Absolutely. And then there's this idea of titration.
Titration?
Basically, it's about finding the right dosage to safely bring the patient's blood sugar back to normal.
I bet that takes a lot of skill and careful observation.
For sure. It's like adjusting a dimmer switch, You want to get the lighting just right. Paramedics are always assessing how the patient's responding, and then they adjust the treatment as needed. Always aiming for that sweet spot where blood sugar's stable and the patient starts regaining consciousness.
Sounds like a delicate balancing act.
Yeah.
So after that initial treatment, does everyone automatically go to the hospital?
Not necessarily. That's where the treat and discharge section comes in. It outlines exactly when a patient can be treated right there and then and safely discharged versus needing to go to the hospital.
Okay, I'm really curious about that. Like, how do they decide? What are those criteria?
Age is a big one. The patient needs to be between 18 and 65 to even be considered for discharge. And they need a confirmed diabetes diagnosis and a history of, recent insulin use.
So if someone's never been diagnosed with diabetes and suddenly has low blood sugar, they're probably going to the hospital, right?
Right. Got to make sure it's actually related to diabetes and not something else entirely. Beyond that, they have to have responded well to the treatment. Their blood sugar needs to be stable. They got to be mentally alert. It's the whole picture, not just the number on a glucometer.
That makes sense. So anything else?
Well, they also have to rule out things like a drug overdose or if the patient's pregnant. No seizures either. And a big one is there has to be a responsible adult to stay with them in case symptoms come back.
Wow. That's quite a checklist. So paramedics have a lot of responsibility in these situations.
Oh, yeah, definitely. But they're not completely on their own. If they're unsure about whether someone meets the criteria for discharge, they can actually contact a base hospital physician remotely.
Really? So even out in the field, they can get a second opinion.
Exactly, right then and there. Helps ensure the best possible outcome for the patient.
That's reassuring. It's clear that this is about more than just checking boxes and following a rigid set of rules.
Right. Absolutely. The directive's important, yeah, it gives those guidelines. But there's also a huge emphasis on the paramedic's own judgment, on the nuances of each case.
What do you mean? Can you give me an example?
Sure. Imagine someone's experiencing low blood sugar for the very first time. They might be terrified, confused, even combative because it affects the brain, So the paramedic's role goes way beyond just giving meds.
What else do they need to do?
They need to be calm, compassionate, get as much info as possible, assess the whole situation, and then make informed decisions, sometimes even going beyond the strict protocol. It's all about adapting to each individual person, each unique situation.
So recognizing that every patient is different and every situation has its own complexities.
Exactly. And sometimes the most powerful things you can do are actually the simplest, like just being reassuring, explaining what's happening, treating the patient with respect. That can make a world of difference.
It's about that balance between following those established protocols and using your best judgment. Really fascinating stuff.
It really is.
Yeah.
And it highlights just how skilled these paramedics are, making these life or death decisions often under a lot of pressure.
Absolutely. Okay, so we've covered a lot. Suspected hypoglycemia, those different treatment options, how they decide whether to discharge someone.
And we've touched on how important that human element is. Paramedics aren't just robots following a script. They're making these critical judgments, adapting to each patient.
This has been a really eye-opening look at pre-hospital care. For you, what's the most important takeaway from this part of our deep dive?
For me, it's how complex something as seemingly straightforward as hypoglycemia can be. There's the science behind it, but also the art of how you interact with and communicate with the patient. And paramedics are right there on the front lines, navigating all of that with incredible skill and compassion.
Totally agree. It shows just how dedicated they are, how much training they have, and this ability to think on their feet in those really tough situations. And, while we've been focusing on Ontario's protocols, these principles, careful assessment, knowing when to intervene, and that compassionate care, those are universal.
Absolutely. Whether you're a medical professional or just someone who wants to better understand this, the lessons here apply pretty broadly.
We've been exploring how paramedics in Ontario handle hypoglycemia, and it's fascinating how much goes into those decisions out in the field.
It's way more than just giving sugar, that's for sure.
Right. We've seen those protocols, how patient safety comes first, and how they use their judgment to handle each situation.
Adaptability is key.
Totally.
Yeah.
But we've mainly focused on that initial response to suspected hypoglycemia. What happens after those first few minutes?
Good question. This hypoglycemia medical directive, it actually covers some important clinical considerations, stuff that goes beyond that initial intervention.
Like what? Give me an example.
Okay, so one interesting thing is they might give oral glucose or even simple carbs after that first treatment with dextrose or glucagon.
So it's not just about that quick fix, but also about making sure the blood sugar stays at a safe level.
Yeah, exactly. The body needs a steady source of energy to really recover, right?
Right.
Sometimes, if the hypoglycemia is mild, oral glucose or simple carbs might even be the main treatment. No 4V or injection needed.
Oh, interesting. So again, it's about tailoring the response to the specific situation.
Absolutely. Another key thing the directive talks about is documentation, especially important if a patient refuses to go to the hospital.
Wait, so even if someone doesn't want further care, paramedics still have to document everything.
Oh, yeah. It's super important. They have to try and get those final vital signs, including blood glucose, and record it all.
I can see why that documentation would be important for a few reasons.
Exactly. First, it helps ensure that care continues smoothly. If the patient does end up needing medical attention later, that record is crucial.
Like, it gives the next healthcare provider a better understanding of what's been going on.
Yep. Plus, it protects both the patient and the paramedic. Creates a clear record of everything that happened, all the decisions made, the care given.
Makes sense. Accountability and transparency. Now, we've been deep in these medical directives, which are obviously for professionals. But you mentioned earlier that understanding the basics of hypoglycemia can help anyone. Can you expand on that?
Definitely. Those protocols are great, but even just knowing the basics about hypoglycemia, its causes, symptoms, some simple first aid stuff, that's valuable for everyone, especially people with diabetes or the families.
What are some of the key things people should look out for?
Recognizing those classic symptoms like confusion, dizziness, sweating, shakiness, weakness, all signs of low blood sugar. And in severe cases, you can even have seizures.
So if you see someone with those symptoms, especially if they have diabetes, that's a big red flag.
Huge red flag. And in those moments, time matters. While you're waiting for help to arrive, a sugary drink or snack can make a big difference.
Taking action, even if it seems small.
Exactly. Of course, always get professional medical advice for anything serious. But knowing about hypoglycemia can really help people respond in an emergency.
Being prepared, knowing what to do when every second counts. So we've got those specific protocols, ongoing care, documentation, and how even basic knowledge can empower people.
And it all points to this idea that managing hypoglycemia takes a multifaceted approach. Medical intervention is part of it, but so is education, awareness, taking responsibility for your own health.
Recognizing that we all have a role to play. Sometimes a little bit of knowledge can go a long way. Anything else that stands out to you from what we've covered so far?
You know what I find really striking? How these protocols show this balance between individual patient care and managing healthcare resources as a whole.
What do you mean by that?
Well, think about those treat and discharge criteria. It's not just about whether a patient's okay to go home. It's also about making sure hospitals aren't overwhelmed unnecessarily.
So those criteria are meant to make sure only people who really need hospital-level care are transported.
Exactly. It's a good reminder that paramedics aren't just making decisions for one person, they're working within this larger system.
Another layer of complexity to those decisions. It's not just medicine, it's also resource allocation, the big picture of healthcare.
Exactly. And it highlights how multifaceted paramedicine is. They need medical knowledge, of course, but also critical thinking skills and an understanding of the entire healthcare system.
We've certainly gained a much deeper understanding of all the intricacies of hypoglycemia treatment and just how skilled these first responders are. This deep dive has been really insightful. Now, before we move on, remember that we've been focusing on Ontario's protocols.
Right. While they're really useful to look at, those specific guidelines can vary depending on where you are and the individual situation.
Absolutely. Stay tuned for the final part of our deep dive, where we'll wrap things up with some final thoughts on treating hypoglycemia and talk about how important it is to stay informed about your own health needs. And we're back for the final part of our deep dive into treating hypoglycemia. We've been following the journey of those paramedics in Ontario, from recognizing it to those crucial decisions about treatment and transport.
Yeah, we've covered a lot of ground, haven't we? All those protocols, the decision-making out in the field, and even how important it is for people to be aware and take action themselves.
Exactly. But before we wrap up, I'm wondering, what's missing from these directives? Like, what are some of those things that aren't explicitly written down, but are still really important for understanding how to manage hypoglycemia?
That's a good question. I think one thing that comes to mind right away is patient education, especially for people who actually have diabetes.
So it's not just about responding to those acute episodes. It's about giving people the tools to, like, manage their condition proactively, to prevent those episodes in the first place.
Exactly. It's like paramedics are there to catch you when you fall. But wouldn't it be better to know how to avoid those falls altogether?
I like that analogy.
Yeah.
So what kind of knowledge can help people with diabetes do that? Stay ahead of those potential hypoglycemic episodes.
Well, knowing those common triggers is huge. Things like missing meals, exercising too hard, or even getting the insulin dosage wrong. Those can all cause blood sugar to drop way too fast.
So it's about being aware of those daily habits and how they affect blood sugar.
Exactly. And it's not just about avoiding things, it's also about recognizing those early warning signs. We've talked about those before: dizziness, confusion, sweating. Those are like your body telling you something's not right.
It's about paying attention to your body and knowing when to take action.
For sure. And speaking of action, another crucial thing is having that ongoing relationship with your doctor. Don't just wait till things get bad and call 911, right? Regular checkups, monitoring your blood sugar, adjusting medications, even making lifestyle changes. All that helps manage diabetes effectively over time.
Taking charge of your health, not just reacting to emergencies.
Exactly. And that brings us back to that human element we've been talking about. That open communication, the trust between you and your healthcare provider.
Recognizing that it's not just about following protocols, but about building relationships, working together to be as healthy as possible.
Couldn't have said it better myself. So we've focused on those specific protocols, but I think the big takeaway for everyone is understanding hypoglycemia gives you power. It lets you take control of your own health or help someone else.
Absolutely. Knowing the causes, the symptoms, even some basic first aid, that can make a real difference, whether it's for you or someone you care about.
And remember, this is just the start. There's a ton of information out there about hypoglycemia, diabetes, staying healthy.
Keep learning, find resources that are right for you, and talk to your doctor.
Knowledge is power, especially when it comes to your health. Never stop learning.
Well said. That's a wrap on our deep dive. It's been amazing to explore all this, to see how complex treating hypoglycemia is, and to appreciate the skill and dedication of those paramedics.
It's been great sharing this journey with you.
Thanks for joining us, everyone. Until next time, stay curious and keep learning. Okay, folks, welcome back. Today, we're going to be taking a deep dive into some pretty intense stuff. We're talking IV therapy and fluid administration.
Really important stuff, especially in those emergency situations where, every second counts.
Right. And we're looking specifically at how these procedures are handled by our primary care paramedics here in Ontario. PCPs, as they're often called, the ones who are often first on the scene.
Exactly.
So to guide us through this complex world, we're turning to the guidelines set up by the Ontario Ministry of Health. Specifically, we're cracking open the Advanced Life Support Patient Care Standards, version 5.3 to be precise.
That's the one. That's the PCP's go-to manual. Everything you need to know about providing advanced life support in the field.
And that's a lot of responsibility, right? I mean, they're making decisions that can have, huge consequences.
Absolutely. These guidelines are designed to give PCPs a clear framework for providing safe and effective care. And a big part of that is understanding their scope of practice, what they're authorized to do and when.
Okay, so let's dive right in. I see here in the guidelines something called PCP Auxiliary Medical Directives. What exactly does that mean?
So those directives are essentially like pre-approved permissions. They allow PCPs to perform certain procedures and administer medications without having to contact a physician for every single case.
So it's like having standing orders, in a way.
Oh, yeah, you could think of it like that. It helps streamline care and allows PCPs to act quickly in those time-sensitive situations.
Makes sense. Now, I also see that there's a distinction between PCP Autonomous IV and PCP Assist 4.
Right, that's a key difference in terms of what a PCP is authorized to do. A PCP with autonomous IV clearance, they can independently start an IV and administer fluids or medications.
So they're fully authorized to handle the entire process themselves.
Yes, within the boundaries of the guidelines, of course. Now, PCP Assist 3, that's a bit different. They can cannulate, which means putting in the IV line, but they can't actually administer anything through it. They need an advanced care paramedic to supervise that part.
Interesting. So one PCP can get the access set up, but another with the higher level of training has to be there to actually administer anything.
Precisely.
Okay. So that really highlights how important it is for every PCP to know their specific authorizations, right? Like what they can and cannot do on their own.
Absolutely. It's about ensuring patient safety and practicing within the bounds of their training and expertise.
Makes sense. Now, let's move on to those situations where an IV is actually needed. And looking at these guidelines, the criteria seem pretty broad. It says it's for the actual or potential need for intravenous medication or fluid therapy.
Yeah, that's kind of the nature of emergency medicine. Things can change quickly, and you need to be prepared for a variety of possibilities.
So it really comes down to the PCP's judgment in the moment.
Exactly. The PCP has to assess the situation, considering the patient's condition, vital signs, and potential complications. They need to determine if getting that IV access established is truly necessary, based on what's happening and what might be needed later.
Wow, they really have to think ahead and anticipate what might happen. That's a lot of pressure.
It is. They're trained to do it, though. Now, assuming the PCP has determined an IV is needed, the guidelines primarily discuss one specific fluid, 0.9% ACL.
Oh yeah, normal saline. It's what we often hear about in, like, medical dramas and stuff. Seems like it's the go-to fluid for emergencies. But why is that?
It's actually really interesting. Normal saline is what we call an isotonic solution. So it has a similar salt concentration to your blood.
Oh, okay, so it's not going to shock the system when it gets pumped in.
Right. It's gentle, it doesn't disrupt the body's natural balance. That's what makes it a safe bet in most emergency situations, where you got to get fluids into someone quickly and safely. You don't want to add more problems.
Yeah, I can see how that would be really important. Now, speaking of getting those fluids in, I see the guidelines distinguish between giving fluids for maintenance and giving a fluid bolus.
Ah, that's an important distinction. It's about the rate and the volume of the fluids we're giving.
So maintenance is like a slow and steady drip to keep things going.
Yeah, think of it like regularly watering a plant to keep the soil moist. It's about maintaining hydration over time. A bolus, on the other hand, that's like giving the plant a big gulp of water all at once because, it's wilting and needs a quick boost.
A little resuscitation.
Exactly. We use boluses when we need to rapidly replace fluids, like you see in severe dehydration or when someone's blood pressure is dangerously low.
Okay, so that makes sense. And looking further into those bolus procedures, it's interesting that the guidelines have different instructions based on the age of the patient. 2 years to under 12 and then 12 and older. I guess that highlights that, kids aren't just small adults, right? Their bodies handle things differently.
Absolutely. Kids have different needs, and their bodies react to fluids in a way that we have to be extra careful about.
So for those younger kids, ages 2 to under 12, the bolus is 20 milliliters per kilogram of body weight, even in increments of 100 milliliters. And after each of those increments, the PCP reassesses the patient. So smaller, more frequent checks for the little ones.
Exactly. And then for those 12 and older, still 20 milliliters per kilogram, but the reassessment happens every 250 milliliters.
Okay, so bigger boluses, less frequently for the older patients. I guess their bodies can handle those bigger fluid shifts.
You got it. Now, even with these differences, in how we administer the fluids, it's super important to remember that a fluid bolus is a powerful tool.
Right, not something to be taken lightly.
Especially with those little ones. They're way more sensitive to, sudden changes in fluid levels. That's why those smaller, more frequent assessments are absolutely crucial. It's like you're constantly monitoring to make sure you're giving enough to help, but not so much that it backfires.
Yeah, you're looking for that sweet spot. Now, there's also a specific mention of fluid bolus in the guidelines for patients suspected of having diabetic ketoacidosis, DKA.
Right. That's right, DKA. And yeah, that's a serious complication of diabetes. Basically what happens is the body's not using sugar for energy properly, so it starts breaking down fat instead, and this, creates a buildup of acids in the blood.
Ketones, yeah.
And that can be really dangerous, life-threatening even. So in these situations, fluid bolus is vital because it helps rehydrate the patient, dilute those ketones, and get the blood flowing right again.
So it's really about getting things back into balance.
Exactly. Now, for younger patients with suspected DKA, the guidelines bring up this thing called a mandatory provincial patch point.
Mandatory provincial patch point. Sounds pretty official. What's that all about?
Well, it's basically an extra layer of safety. It means before the PCP can administer that fluid bolus, they got to contact a base hospital physician, get authorization.
So even though the PCP has the authority to act, there's still that check in place, right? Make sure an expert is in the loop and gives the okay, especially in like a high-stakes situation like DKA. Okay, so we've covered different patient ages and conditions. Now, is there a general limit on how much normal saline a PCP can give?
Yes, there is. Regardless of the situation, the guidelines set a maximum of 2,000 milliliters of 0.9% ACL.
2,000 milliliters. But why even have a limit? I mean, if someone needs fluids, wouldn't more be better?
Well, not necessarily. It might seem counterintuitive, but giving too much fluid too quickly, it can actually be harmful. Overloading the system.
Like overfilling a balloon.
Exactly. Eventually, it's going to burst. In the body, too much fluid can strain the heart and the lungs, even lead to swelling in the brain, which is a very bad situation.
Definitely don't want that. Now, I do see there's an exception to that 2,000 milliliter rule. For patients in cardiogenic shock or those who've regained a pulse after cardiac arrest, the maximum is lower for them. Why is that?
Because their hearts are already compromised. You don't want to overwhelm them with a huge volume of fluid. It could make things worse, put too much stress on the heart.
So in those cases, it's about finding that balance, right? Enough fluid to help, but not so much that it harms.
Exactly. Now, there's one more thing I want to touch on about fluid administration, especially for those younger patients. The guidelines recommend using microdrips or volume control sets for kids under 12.
What's the reason for that?
Well, think about it. Kids have much smaller veins than adults, right? So we need to be super careful about how much fluid we're giving and how fast it's going in. Those special sets, they let us control the flow rate really precisely.
So like a tiny eyedropper instead of a big watering can.
Yeah,
Makes sense. You need that extra level of control.
exactly.
Okay, so lots to consider when it comes to fluid administration. Is there anything else that really stands out in the guidelines?
Yeah, one thing they emphasize is that even though fluid bolus can be, a real game changer in an emergency, it should never delay transport to the hospital.
Right, got to get them to that definitive care.
Exactly. And it shouldn't take priority over managing, other immediately life-threatening conditions.
So it's all about prioritizing and making those split-second decisions in the field. Wow, it's amazing how much responsibility those PCPs have.
They do, and these guidelines, along with their training and assessment skills, are what help them provide the best possible care out there. It's all about making the right call, in those critical moments and keeping the patient safe.
So just to summarize, PCPs in Ontario have very specific rules about when and how they can give IV fluids and medications. And those rules, well, they change depending on the age of the patient and what's going on with their health.
Absolutely. It's not just a one-size-fits-all approach. Every situation is unique.
All right. So as we wrap up this deep dive, here's something for everyone to think about. We've talked a lot about normal saline today, but what other IV fluids or medications might a paramedic use? And how do they decide which one is the right one for the job?
That's a great question. The choices are actually much broader than just normal saline. There's a whole range of fluids and medications out there, each designed for specific situations. It's like a whole other level of expertise that paramedics have to master. Really impressive when you think about it.
Absolutely. It's amazing what they do. And if you want to delve deeper into that world of pre-hospital care, you can always check out the full Advanced Life Support Patient Care Standards document from the Ontario Ministry of Health. It's a fascinating read.
It is.
Until next time, keep those brains buzzing, and as always, stay curious.
Stay safe out there.
Okay, so ready to jump in the ambulance.
Let's do it.
Today, we're going behind the scenes with paramedics, specifically in Ontario, Canada.
All right.
We're looking at how they handle something we've all experienced, nausea and vomiting.
Yeah, absolutely.
And we're using their Advanced Life Support Patient Care Standards as our guide. You'd think, right, treating an upset stomach gets pretty basic, but trust me, it gets way more interesting.
Oh, yeah. There's a lot to it.
And we're focusing specifically on what primary care paramedics, the PCPs, the folks you see first in an emergency, can do.
Right.
They have a limited set of tools and medications, so it's fascinating how they make those decisions in the field.
Exactly, yeah. They have to work within those constraints, and this document really lays out how they think it through.
So it's like their playbook for nausea and vomiting.
Pretty much, yeah. It tells them when it's okay to give a medication, how much, and even how to give it.
Okay, I'm intrigued. So walk me through this. What are the go-to meds for paramedics dealing with an upset tummy?
Well, the two stars of the show here are ondansetron and dimenhydrinate.
Ondansetron, dimenhydrinate. Those are some serious medical terms.
I know, right? But you've probably heard of them by their brand names, Zofran and Gravol.
Oh, Zofran and Grivol.
Uh,
Okay, now we're talking. So those are the weapons in their arsenal.
Yep. And the way they choose between them, or even how they decide to give them, well, it's not as simple as you might think.
Okay, give me an example. What makes it complicated?
Well, let's talk about the ways they can actually administer the meds.
Okay.
They've got a few options. Orally, which is just PO, like swallowing a pill.
Right, the classic.
Then they can do IV, which means injecting it into a vein.
Okay, that's getting more serious.
And then there's IM, which is injecting it into a muscle.
So different routes of administration depending on the situation.
I see. Now, I remember reading in the document that PCPs actually need special authorization to do IVs. Yes, you caught that. It's because giving medication intravenously, it's a whole different level of skill and training. And risk, frankly. You're putting it directly into the bloodstream.
Right, it's like a fast track straight to the system. So it's reserved for more serious situations, I guess.
Exactly. Sometimes you need to hit the brakes quickly, and IV is the fastest way to do that.
I guess it also matters what they're diluting it with, saline or dextrose.
Yeah, that's another layer of complexity. Sometimes they need to dilute the medication before giving it IV.
So less of a jolt to the system.
Precisely, make it a little gentler on the body. But they don't dilute it for IM injections, which is interesting.
Huh. Why is that?
I guess because the muscle can absorb the medication more gradually, so it doesn't need to be diluted.
Fascinating. So IV, IM, PO, choosing between those is all part of their decision-making process. But what else are they considering when they're faced with a nauseous patient?
Well, one of the biggest things, and this is true for almost any medication, is weight.
Right. A bigger person might need a bigger dose.
Exactly. And the document actually lays out very specific weight categories and corresponding dosages for both ondansetron and dimenhydrinate.
So they're pulling out their calculators, doing some math in the field.
You got it. Got to get that dosage right.
Wow. I never thought about that. And is it just the total amount that's important, or are there limits too?
Oh, yeah, definitely. Dimenhydrinate has a maximum single dose, and that varies based on the patient's weight.
Makes sense. But what about ondansetron?
It's a little different. It has a single maximum dose regardless of weight.
Interesting. So each medication has its own quirks. But I guess weight is just one piece of the puzzle, right? What other factors are they taking into account?
Well, the big one, the one that always comes up, is allergies.
Right. You don't want to give someone something they're allergic to. That could be bad.
Exactly. And for dimenhydrinate, that's especially important because it's an antihistamine.
Oh, so if you're allergic to Benadryl or something like that.
You probably shouldn't be getting dimenhydrinate.
Good to know. What about other medications the patient might be taking? Does that matter?
Absolutely. Dimenhydrinate can interact with a whole slew of other drugs.
Uh-oh. What kind of drugs?
Things like anticholinergics, which affect your nervous system. Tricyclic antidepressants, too.
Wow, so they really have to be detectives, figuring out what else is going on with the patient.
Yeah, it's like piecing together a puzzle, making sure all the pieces fit before they give anything, and it's not just dimenhydrinate.
Right. I bet ondansetron has its own list of no-nos.
You bet it does. People with a heart condition called prolonged QT syndrome can't take it.
I've heard of that. That's a pretty serious condition.
Yeah, it is. And another interesting one, they can't give ondansetron if the patient has recently used apomorphine.
Apomorphine, huh? Now, what's that used for?
It's a drug for Parkinson's disease. You wouldn't think it would be related to nausea, but there you go.
So it's like this web of interactions.
Yeah.
Crazy.
Yeah, it really highlights how interconnected everything is in the body. And that paramedics need to have this incredibly broad knowledge base to make safe decisions.
Totally. Okay, now here's something I found really interesting in the document. It mentioned that they might actually consider using both medications, ondansetron and dimenhydrinate, for the same patient.
Yeah, sometimes one just isn't enough.
So why would they do that?
Well, imagine they give a patient ondansetron and 30 minutes later, they're still nauseous.
Poor thing.
Yeah, so in that case, they might add dimenhydrinate to the mix or vice versa. See if that does the trick.
So it's like a double whammy, two different approaches at the same time.
Exactly.
Yeah.
They're really pulling out all the stops to try and get that patient some relief. But they have to be careful, of course. It's a delicate balance.
I can imagine. Now, there was one more thing that caught my eye. It seems like dimenhydrinate is the preferred choice for patients under 65, generally speaking.
Yep, that's right.
Any reason for that?
Well, we just have a longer history with dimenhydrinate. More data on its safety and effectiveness in that age group.
So tried and true.
Pretty much. But look, if ondansetron is the only option available, they can use it for older patients, too.
Gotcha. Okay, so to sum it all up, it seems like treating nausea and vomiting isn't just about grabbing a bottle of Gravol. It's about knowing the medications, understanding the patient, their history, their allergies, their other meds, and then making a judgment call based on all of that, all in the back of an ambulance.
Exactly. It really is a testament to the skill and knowledge of these paramedics. They're making these critical decisions, sometimes in very stressful situations. It's amazing, really.
It really makes you think. I mean, next time I see a paramedic, I'm going to have a whole new level of respect for what they do.
I think it's a good reminder for all of us, too, to be as open and honest as possible with first responders about our medical history and what medications we're taking.
You never know what little detail might help them make the best decision for you.
Absolutely. That information could really make a difference.
All right, well, there you have it. A peek behind the curtain of paramedic practice, all thanks to the Advanced Life Support Patient Care Standards. Now, makes you wonder, doesn't it? What other factors do paramedics consider when they're treating different medical conditions.
Lots. And we'll keep diving deeper into these protocols to find out.
Stay tuned, folks.
We'll be back.
See you next time.
Bye for now. All right, so get ready, everyone, for today's deep dive.
Yeah.
Because we're going deep into the world of emergency medicine, specifically...
right to the heart of it.
Yeah, right to the heart of it. We're talking trauma cardiac arrest
Okay.
and the guidelines
Yeah.
that paramedics use.
The rope,
with
though.
those
Tough decisions out in the field.
incredibly tough calls in the field
Yeah.
when somebody's life's on the line.
Yeah.
Um,
And these are...
these are the trauma cardiac arrest medical directives from the Ontario Ministry of Health.
Okay, so these directives, right?
Yeah.
They're kind of like that essential guide.
The roadmap
Roadmap.
for paramedics when they're dealing with trauma cardiac arrest,
Yeah.
especially those first responders, giving them the knowledge and authority
Yeah.
to deliver the best care that they can.
And we're going deep into this roadmap today
Yeah,
with excerpts from the Advanced Life Support Patient Care Standards.
exactly.
But we're really focusing on the core medical directives for primary care paramedics.
Yeah, the core medical directives
Kind
for
of.
primary care paramedics.
Empowering those.
Yeah.
First
yeah.
responders.
Let's imagine a scenario, right?
Okay.
A paramedic shows up at the scene of a serious accident.
Right.
It's a car crash. Somebody's fallen from a height.
Could be a number of things, yeah.
And there's a patient who has gone into cardiac arrest
Right.
because of that severe trauma.
Exactly.
That's when these directives kick in, right?
This is when it kicks in. This
Yeah.
is when these are so important.
Okay,
Right.
so one of the first things a
Yeah.
paramedic has to determine is if that patient meets the criteria for
For the treatments that are outlined in the directive.
certain treatments outlined
Yeah.
in the directive. So,
Right.
for example,
Uh-huh.
manual defibrillation.
Mm-hmm.
Now, defibrillation, we all know about the electric shock, right?
That's the one we see in the movies.
Yes,
They-
big paddles,
Yeah.
clear.
But it's not just a case of shocking everyone who's in cardiac arrest.
Right.
You have to meet very specific conditions.
Yeah, so you can't just like, oh, they're in cardiac arrest.
No.
Zap them.
No, you have to meet certain criteria.
Yeah, so what are some of those conditions?
Well, first of all, they have to be at least 24 hours old.
Okay.
I mean, it's kind of a given.
Obviously, yeah.
But they also have to be exhibiting what we call an altered level of awareness.
Okay, so they're not.
Basically not responding normally.
Yeah, if they're sitting there chatting.
Yeah, they're conscious and chatting away. It's probably not.
Yeah, you don't need to defibrillate them.
Not a cardiac arrest.
Yeah.
Right.
Okay.
And the directive also specifies
Mhm.
the type of heart rhythm the patient has to have before defibrillation can even be used.
Okay, so they're...
So there's two main shockable rhythms, ventricular fibrillation, or VF,
Okay.
and pulseless ventricular tachycardia,
Okay, now those sound...
VT for short.
They sound pretty complex. Can you break those down for us a little bit?
Yeah, sure. Think of your heart as an electrical system.
Okay.
In VF, the electrical activity in the ventricles,
Okay.
the lower chambers of the heart,
Okay.
becomes completely chaotic.
Okay.
It's like massive short circuit.
It's like a...
Instead of a coordinated beat, you get this quivering
Yeah.
that is totally ineffective at pumping blood.
So it's not beating too fast?
Nope.
It's not beating too slow?
Nope.
It's just all over the place?
It's completely out of whack.
Yeah.
Now, with pulseless VT,
Okay.
the electrical signals are rapid and regular,
Okay.
but they're still not making the heart pump effectively.
Okay.
It's like a car engine,
Okay.
revving super high,
Yeah.
but the wheels aren't turning.
Okay.
Lots of activity, but no forward motion.
I got it. Okay.
Yeah.
So in both of these cases,
Yes.
defibrillation is used.
Is used to try to reset the heart's rhythm,
Okay.
to deliver a controlled electrical shock,
It-
and hopefully get it back into a normal rhythm.
Okay. Now,
A life-sustaining rhythm.
the directive also mentions CPR,
Hmm.
right?
Yes.
Cardiopulmonary resuscitation, which most people have heard of.
Right.
What kind of guidance
Okay.
does it give paramedics?
Well, it gets very specific, actually.
Yeah.
It outlines how CPR should be performed, how often,
Right.
and for how long in each cycle.
Okay.
Every second counts in these situations.
Yeah.
So having this standardized approach
Yeah.
really helps ensure that paramedics are delivering that consistent, high-quality care.
Yeah. So it's like a
Yeah.
finely tuned dance.
That's a great way to put it.
Right.
Where every movement,
Or every...
every second has a specific purpose.
Yeah. Okay, now.
But, there's another aspect of this directive that is particularly challenging.
Okay, what's that?
And that's something called trauma TO.
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 Okay.
It stands for termination of resuscitation.
Oh, wow. That sounds heavy.
It is heavy.
Yeah.
It's the incredibly difficult decision to stop resuscitation efforts.
Right.
And the directive outlines very specific criteria that need to be met before that decision can even be considered.
So it's not a decision made lightly at all.
Not a decision made lightly.
Yeah. What kind of factors go into that?
Well, for example, the patient has to be at least 16 years old,
Okay.
showing no signs of life whatsoever.
Okay.
No pulse, no breathing, no response to any kind of stimuli.
Wow.
And critically,
Yeah.
there needs to be no sign of life from the moment they were completely removed from that traumatic situation.
Oh, so if there's even like a
Right.
flicker of a heartbeat during extrication.
Absolutely. That would indicate there's still some potential for recovery.
Oh, wow.
Yeah.
That's incredible.
Another scenario where trauma TOR might be considered is if there are signs of life,
Okay.
but the estimated transport time to the nearest emergency department is 30 minutes or more.
Oh, wow. So why is that 30-minute mark
Right.
so critical?
Because studies have shown that the chances of survival decrease drastically after that time.
Okay.
The longer it takes to get that trauma patient to definitive care, the less likely they are to make it.
Okay, so it's this like heartbreaking balance
It is a heartbreaking balance.
between holding on to hope,
Right.
but also the reality.
Acknowledging the reality.
Yeah, the situation.
Yeah, exactly.
Okay.
And then there's another rhythm we need to talk about that plays a role in this decision-making process.
Okay. What is it?
It's called PEA, or pulseless electrical activity.
PEA.
You arrive at the scene.
Yeah.
The monitor shows electrical activity in the heart,
Okay.
but the patient has no pulse.
So it's like the engine is running,
Perfect analogy.
but the car's not moving.
Yeah, the heart's electrical system's working,
Yeah.
but it's not translating into that effective pumping of blood.
Okay, and like we were talking about with the 30-minute.
Right. A transport rule if they're in PEA.
Yeah.
And that golden window of opportunity is closing.
Yeah.
Trauma TOR might be considered.
Wow, so that's a lot for paramedics to process
It is.
in the heat of the moment, right?
It is a huge responsibility.
They're assessing the patient's age, their heart rhythm,
Absolutely.
the transport time,
Yeah.
whether there are any signs of life
It's never taken lightly.
at all.
But, there's one crucial element we haven't even mentioned yet that plays a huge role in all of this.
Okay, I'm all ears.
Communication
Okay.
between the paramedic on scene
Yeah.
and a physician at the base hospital.
Okay, so it's not just the paramedics out there
Not at all.
making these life or death calls on their own.
There's this thing called a provincial patch point, where the paramedic connects with a base hospital physician, or BHP, to get guidance and authorization.
Okay, that sounds like a really critical safety net.
It is.
Can you tell me more about that?
Sure. So the paramedic is the eyes and ears on the ground, providing real-time information about the patient's condition.
Oh.
The BHP, on the other hand, has a broader perspective, using their expertise to interpret that information within the context of the directive and the specific circumstances of that case.
Yeah. So it's like a real team effort, right? The
That's exactly right.
paramedic and the BHP.
Working together to make the best.
Yeah, working together to make the best possible decision for the patient.
For the patient, absolutely.
Yeah.
And that brings us to another interesting part of this directive.
Okay.
The section on contraindications.
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 Now, those are the situations where
Right.
certain treatments shouldn't be administered.
That's right. It's like a built-in safety mechanism
Yeah.
to prevent harm.
Okay.
For instance, manual defibrillation
Yeah.
should never be used if the patient's heart rhythm isn't VF
Right.
or pulseless VT.
Okay, so because shocking a heart,
Right.
that's not,
That's not one of those rhythms.
and one of those rhythms could actually make things worse.
Yeah. Precisely. It's about using the right tool for the right job.
Yeah.
Right.
Okay.
And then there are contraindications related to the trauma TOR itself.
Okay. Such as?
Well, one of the most important ones is age.
Okay.
Trauma TOR cannot be applied if the patient is under 16 years old.
Okay, that makes sense because younger patients might have
Right.
a better chance of bouncing back even after prolonged cardiac arrest.
Exactly. They might have a greater physiological reserve.
Right.
Right.
Yeah. Okay. Oh.
And another contraindication for trauma TOR
Yeah.
is if defibrillation has already been attempted.
Okay.
The directive recognizes that once that step has been taken,
Yeah.
it's essential to continue resuscitation efforts and get that patient to definitive care as quickly as possible.
Okay, so it's like crossing a threshold.
That's a good way to think about it.
Once you've started down a certain path, you just
We got to see it through.
gotta see it through.
Right.
Yeah.
And then there's a situation where a patient might have a non-shockable rhythm, like a systole or PEA,
Okay.
but is showing some signs of life.
So maybe their pupils are reacting to light,
Exactly.
or they're making some effort to breathe.
In those cases, the directive says trauma TOR is not an option.
Right.
Even the slightest flicker of life
Yeah.
means there's still potential for recovery,
Okay.
and every effort should be made to support that.
Wow, this directive really is like a
It is
complex algorithm
Very
with all these different factors
very complex.
feeding into the decision-making process.
All these factors, yeah.
Yeah, it must be.
It's incredibly challenging.
Incredibly challenging for paramedics to apply this knowledge
Right.
in these high-pressure situations.
High pressure situations.
Yeah.
That's why the directive includes a section on clinical considerations.
Okay.
It's like a layer of nuanced guidance that helps paramedics navigate those gray areas.
Okay, can you give me an example of what that section covers?
Well, one interesting point is that it reminds paramedics to consider the possibility of a medical cardiac arrest, even if there's no obvious signs of trauma.
Okay, so somebody could just collapse in the street,
Exactly.
and there might not be any immediate indication
Yeah.
of what caused it.
Right.
Yeah.
And in those cases, the directive really emphasizes the importance of a thorough assessment, looking for any clues that might suggest an underlying medical condition.
So it's like being a detective gathering all the evidence.
I like that analogy.
Yeah. Right.
Before forming a theory.
Before you jump to any conclusions.
Right. And speaking of evidence,
Okay.
the directive goes into detail about what constitutes signs of life,
Right.
which, as we've seen, play a crucial role in this decision-making process.
Yeah, and it's not just about
It's not just about checking for a pulse anymore.
checking for a pulse anymore.
No.
So what else are paramedics looking for?
So the directive lists 4 specific signs. Any spontaneous movement,
Okay.
any effort to breathe, organized electrical activity on the ECG,
Right.
that's the heart monitor,
Yeah.
and pupils that react to light.
Okay, so even if a patient doesn't have a palpable pulse,
Right,
they're exhibiting some of these other signs,
right.
that could change the course of action.
Absolutely. It's all about painting a complete picture of the patient's physiological state
Okay.
and using that information to guide the most appropriate response.
Okay.
And here's where it gets even more interesting.
Okay.
The presence or absence of certain signs of life can actually be combined to create a kind of score
Okay.
that helps paramedics assess the severity of the situation.
Wow, so it's almost like a point system.
It is like a point system.
Yeah, tell me more about that.
So let's say a patient has no spontaneous movement, isn't making any effort to breathe, but their pupils are reacting to light,
Okay.
and there's organized electrical activity on the ECG.
Okay.
That would indicate a more favorable prognosis compared to a patient who's completely unresponsive, even though neither patient has a palpable pulse.
So the combination of signs matters just as much as the
Yeah.
presence or absence of any single sign.
Precisely. It's a more nuanced way of looking at the situation.
Yeah.
And it really highlights the critical thinking skills
Yeah.
that paramedics bring to their work every day.
Now, there's one last aspect of this directive that I'm curious about.
Okay.
The use of intravenous fluids.
Okay.
It seems like giving fluids would be a top priority
Right.
in a trauma situation.
It would seem that way.
But I know that that's not always the case.
You're right. It's not always as straightforward as it might seem.
Okay.
So while the directive acknowledges that an IV fluid bolus may be considered in a trauma cardiac arrest,
Mm-hmm.
it emphasizes that fluid administration should never delay transport to the hospital.
Okay, so getting the patient
Right.
to definitive care
Absolutely.
trumps everything else.
Think about it this way.
Yeah.
In the field, a paramedic's resources are limited. They can perform CPR, they can defibrillate, they can administer certain medications,
Yeah.
they can establish an IV line,
Yeah.
but they can't perform surgery.
Right.
They can't do blood transfusions.
Right.
And they can't provide the level of monitoring and life support that's available in a hospital setting.
So it's a matter of prioritizing interventions.
It's all about prioritizing intervention.
Yeah, focusing on what can be done effectively in the field
Right.
versus what needs to happen
In a more controlled environment.
in a more controlled environment.
Exactly. And when it comes to trauma,
Yeah.
cardiac arrest time is of the essence.
Yeah.
Every minute that ticks by decreases the patient's chances of survival.
Right.
So the directive emphasizes that rapid transport to a facility
Mm-hmm.
equipped to handle those complex trauma cases
Yeah.
is paramount.
Wow, this deep dive has really opened my eyes
Yeah,
to the complexities
it is
for
complex.
pre-hospital care.
It's a fascinating world for sure.
It's like a whole other world of knowledge and expertise
And it's constantly evolving
Yeah.
as new research emerges
that most people never get a glimpse of.
and technology advances.
Yeah, speaking of evolution,
Right.
I'm curious to get your perspective on how these protocols might change in the future,
Okay.
given the rapid advancements that we're seeing
Right.
in medicine and technology.
Mhm.
What do you envision?
That's a great question, and it's one that experts in the field are constantly grappling with.
Yeah.
What's fascinating is that we're already seeing a shift towards more data-driven decision-making in pre-hospital care.
Data-driven decision-making.
Yeah.
That sounds
It's intriguing.
intriguing. Yeah. Can you give me an example of what that might look like?
Sure. So imagine a future
Yeah.
where paramedics have access to real-time data
Okay.
from the patient's medical history,
Okay.
their vital signs, maybe even genetic information,
Wow.
all right, at their fingertips.
Yeah.
This could lead to
Yeah.
even more precise,
Oh.
personalized treatment protocols.
That would be incredible.
Like-
It's like having a whole team of specialists
Yeah.
virtually present at the scene.
Exactly.
Yeah.
And with the rise of artificial intelligence and machine learning,
Mm-hmm.
we could see the development of algorithms
Okay.
that assist paramedics
Mm-hmm.
in making those really difficult decisions,
Yeah.
especially when time is of the essence.
So instead of just relying on like
Right.
the directives
Mm.
and their own judgment,
Right.
they'd have this,
They'd have this AI support system helping them analyze the data,
yeah,
recommend the best course of action,
like a high-tech partner,
precisely like a high-tech partner.
crunching the numbers,
Crunching numbers,
providing evidence-based insights.
providing evidence-based insights to guide their decision-making.
Yeah.
Of course, there are ethical considerations with any AI integration,
Yeah.
but the potential benefits
Sure.
are undeniable.
Yeah, so it's all about finding that balance
Right.
between human expertise
Yeah,
and
and these
technological advancements.
technological advancements.
Yeah.
hmm
Sounds like the future of pre-hospital emergency care is,
It's going to be incredibly dynamic and innovative.
yeah, really exciting.
It is.
Mhm.
And one thing that will always remain constant
Yeah.
is the dedication and expertise of the paramedics themselves.
Yeah, they are the ones out there.
They are the ones on the front lines.
Yeah.
Applying these evolving protocols,
Yeah.
making these critical decisions
Mm.
that save lives.
This deep dive has been fascinating.
Yeah.
Really a journey into
Yeah.
the world
It's been a pleasure
of trauma, cardiac arrest,
sharing these insights with you.
and the protocols that guide pre-hospital care.
Absolutely.
Really given me a new appreciation
Yeah.
for the complexities
It is complex.
and challenges that these first responders face
It is.
every single day.
Every day.
And as we wrap up,
Yeah.
one thought that keeps coming back to me.
Okay.
We've talked about the specific criteria for things like defibrillation,
Right.
trauma, TOR,
Hmm.
but what really stands out is that emphasis
Yes.
on those signs of life,
Those signs of life are so important.
like that beacon of hope.
It's like a beacon of hope,
Right.
guiding paramedics to keep fighting for their patients.
Yeah.
As long as there's even a slight chance of recovery.
Yeah.
That's a beautiful way to put it.
Those signs of life,
Yeah.
however faint
Yeah.
they may be.
They represent that resilience of the human spirit,
Yeah.
the will to keep going.
That will to keep going.
And for paramedics, they serve as a powerful reminder of why they do what they do,
yeah.
to preserve that spark of life
Mm-hmm.
and give their patients a fighting chance.
Well, on that inspiring note, I want to thank you for joining us on this deep dive.
It's been a pleasure.
It's been an incredible journey into the world of emergency medicine.
It has been.
And for all of our listeners,
Yes.
thank you for being here.
Thank you.
We hope you found this deep dive informative and thought-provoking. Until next time, stay curious and keep exploring the world around you. All right, get ready because today we're going deep into Ontario's paramedic guidelines for cardiac arrest.
Oh, yeah.
We're talking the Advanced Life Support Patient Care Standards version 5.3, and it is a dense read.
Yeah.
This document, it's basically a roadmap for life and death decisions.
It is.
And what we're going to uncover is how these protocols actually play out in those really intense, crucial moments.
It's wild, isn't it? Like we see those dramatic rescues on TV.
Yeah.
But there's this whole system, this really in-depth system
Yeah.
that's working behind the scenes to guide paramedics.
Right.
when they're in those crazy high-pressure situations.
Exactly. And I think for anyone who has ever wondered, like, what is actually happening in those ambulances, this is going to be eye-opening.
Oh, for sure.
So to get started, let's unpack what a medical directive actually is in this context.
So think of it this way. In a cardiac arrest,
Yeah,
every second counts.
right.
Paramedics need to move fast. A medical directive basically gives them the okay to do certain treatments
Okay,
without waiting for a doctor's orders.
right.
It's like having pre-approved actions that they can just take immediately,
Yeah.
which could totally mean life or death.
That makes a lot of sense, especially when you consider just how chaotic those emergency situations are.
Oh, yeah.
So let's focus on the medical cardiac arrest medical directive.
All right.
What are we talking about when we say non-traumatic cardiac arrest?
So we're talking about when the heart stops suddenly,
Mm-hmm.
but it's not because of like a physical injury.
Right.
This could be from a bunch of different medical conditions.
Right.
But the main thing is it needs action right away.
Okay.
And the guidelines lay out a very specific approach.
And that approach seems to be built around this idea of primary clinical considerations.
Yeah.
I was really surprised by some of the things listed there where early transport is the priority,
Okay.
even before the patient might be totally stable.
Yeah,
It seems kind of backwards at first.
it does, doesn't it?
Yeah.
But it makes more sense when you look closer.
Yeah.
You see, it's about finding a balance between doing treatment right there on the scene
Mm-hmm.
and getting to a hospital, with more advanced equipment as fast as possible.
So, like, walk me through it. Why would something like pregnancy over 20 weeks
Yeah.
automatically mean they need to get to the hospital fast?
Because now you've got two lives to think about.
Right.
The baby depends on the mom's blood flow.
Yeah.
So any delay in getting to a hospital that can care for both of them,
Mm-hmm.
it could be really bad.
Okay, that makes sense.
Yeah.
What about some of the other examples?
Okay.
Like hypothermia, airway obstruction, or drug overdose?
Right.
Each of those seem like they need a different plan.
Totally.
Yeah.
Hypothermia, for example,
Mm-hmm.
that needs really specific warming techniques.
Okay.
You might not have that in an ambulance.
Right.
You need a controlled space to slowly warm them up.
Yeah.
That's something a hospital is way better at.
So it's not just about like stabilizing their heart rate and stuff. It's
Mhm.
also about knowing what kind of care they're going to need at the hospital.
Totally.
Okay.
And airway obstruction is another one.
Mm-hmm.
Paramedics can handle some airway problems, the basic ones,
Right.
but sometimes you need intubation.
Yeah.
That's where they put a tube into the windpipe to help them breathe.
Right.
That usually needs a doctor at the hospital.
So the guidelines are looking ahead. They're not just dealing with the crisis right now. They're
Right.
already figuring out what the patient might need down the line.
Exactly. You got to anticipate.
And what about a drug overdose?
Okay.
Why would that mean getting them to the hospital fast?
Well, sometimes the drug they took needs a special antidote.
Mm-hmm.
You can only get that at a hospital.
Okay.
Or sometimes the overdose makes other health problems worse.
Right.
That means they need more complex care, more than what we can do in the ambulance.
It's almost like a chess game.
Kind of, yeah.
You're thinking many moves ahead,
Yeah.
trying to predict what the patient needs and making sure they get to the right place as fast as possible.
Yeah, exactly.
It puts a lot of pressure on the paramedics.
Oh, for sure.
Now, there's another term I saw in this section, refractory VF or pulseless VT.
Mhm.
Have you heard of that before?
Oh, yeah. You hear that on those medical shows all the time.
Yeah.
It refers to these really dangerous heart rhythm problems.
Right.
Ventricular fibrillation, that's VF,
Oh,
and then pulseless ventricular tachycardia, VT.
okay.
And refractory basically means it's not responding to defibrillation,
Yeah.
which is what we usually do in these cases.
Right.
The directive actually says they should start transporting the patient after 3 shocks,
Okay.
even if they haven't got a pulse back.
So even though there's no pulse, they're saying, all right, get them to a hospital because time's running out.
Yeah, it's like accepting that sometimes the best chance is at a hospital,
Right.
somewhere with more advanced equipment.
Okay, so let's move on to the conditions and contraindications section. This is where it gets really specific about when they can and can't do things. There's a whole table listing treatments. Some of them are pretty intense.
Oh, yeah.
For instance, manual defibrillation.
Yeah.
It says they can do that for anyone 24 hours or older,
Right.
but only if they have VF or pulseless VT.
Right.
Why just those rhythms? Is it because defibrillation wouldn't work for other types of arrhythmias?
Exactly.
Oh.
VF and pulseless VT, we call those shockable rhythms.
Okay.
Because defibrillation can reset the heart's electrical activity,
Okay.
and hopefully get it back to a normal rhythm.
Like hitting a reset button.
Exactly.
Other rhythms just don't respond to defibrillation the same way.
Right, so it wouldn't be the right thing to do.
It's all about using the right tool for the job.
Exactly.
Now, here's one that really stood out to me.
Okay.
The reason they might not do CPR,
Okay.
it says, obviously dead as per BLS PCS.
Yeah,
That's a big call.
it is.
How do paramedics even decide that?
You're right, it's a tough decision, and it's not something they take lightly.
Yeah.
BLS PCS, that stands for Basic Life Support Patient Care Standards.
Right.
It's another set of guidelines paramedics use.
Okay.
It basically lists specific things they can see that tell them a patient can't be brought back.
Like what kind of things?
This could be no breathing, no pulse, and certain things they check with the nervous system.
Okay, so it's not just a gut feeling. There are specific things they look for.
Yeah, it's a careful judgment based on those criteria.
Right.
It's important to remember that sometimes doing more CPR just isn't the best thing for the patient.
Yeah.
It's a tough part of the job, but sometimes it's necessary.
That makes sense. So we talked about defibrillation and CPR. What about medical termination of resuscitation, or TOR?
Yeah.
That sounds serious.
Yeah, it is.
Yeah.
TR is when they decide to stop all efforts to resuscitate the patient.
Right.
This directive says there are certain conditions that have to be met
Yeah.
before a paramedic can even think about TOR. Like, there are age restrictions. The patient has to be at least 16 years old,
Okay.
and there has to be no return of spontaneous circulation.
What does that mean?
That's ROSC.
Okay.
It means they haven't gotten a pulse back after 20 minutes of trying.
So it's not a decision made lightly, and there are very clear rules in place.
Right.
But are there ever other things that might factor into that decision? Is it ever a judgment call?
It can be, yeah. The directive also says that the paramedic can't have seen the arrest happen.
Right.
And that no defibrillation shocks were given.
Interesting.
These factors help make sure they have as much information as possible.
Mm-hmm.
But yeah, there's always room for judgment based on the specific situation.
Why are those specific things, a witnessed arrest and defibrillation, so important?
Well, if someone saw the arrest happen and started CPR right away,
Right.
the chances of survival could be much higher.
Yeah.
And if they got a shock and still no pulse,
Mm.
it might mean there's something more serious going on
Okay.
that wouldn't respond to more CPR.
Yeah.
So in both those cases, it might make more sense to keep trying.
Okay.
They have to weigh that against, potentially making the patient suffer longer if they're not likely to recover.
So it's really about giving the patient the best chance,
Exactly.
while also being mindful of whether it's ethical to keep them alive if they might not recover.
Right.
These are tough decisions.
They are.
And it's amazing how these guidelines try to navigate that gray area.
It's a delicate balance.
Now, we also see epinephrine on this list, but it says they only use it for anaphylaxis in this case.
Right.
That seems odd.
Yeah.
I thought it was used for other cardiac arrest situations, too.
You're right. It is.
Yeah.
Epinephrine is strong medication.
Right.
It can get the heart pumping again and tighten up blood vessels.
Okay.
But in this directive, it's only for when they think the arrest was caused by anaphylaxis.
Right. So a severe allergic reaction.
Yeah, exactly.
So it's about targeted treatment.
Yes.
We're not just using epinephrine for any cardiac arrest.
No.
It has to be the right situation.
Right.
This really shows how much thought and detail goes into these directives.
It does. It's really impressive.
Okay, let's move on to the treatment and details section.
All right.
This is where we get into the nitty-gritty of doses and procedures.
Yeah, this is where the rubber meets the road.
One thing I noticed was the different energy levels they use for manual defibrillation,
Okay.
depending on how old the patient is.
Right.
What's the reason for that?
It's all about how the heart works.
Mm-hmm.
A child's heart is way smaller and more sensitive than an adult's.
Right.
So if we use a lower energy level, we lower the risk of damaging their heart muscle.
So it's kind of like adjusting the dose of medicine based on a patient's weight and age.
Exactly.
Like you wouldn't give a kid the same amount of medicine as an adult.
Exactly.
It's the same idea with defibrillation.
It is. You want to give enough energy to restart the heart,
Right.
but not so much that you hurt them.
Okay, next up we have AED or SAE defibrillation. I've heard of AEDs. Those are the portable ones you see in public places.
Yeah.
What's a pediatric attenuator cable, though?
Oh, that's a good question.
Mm.
It's basically an extra safety feature for kids.
Okay.
It lowers the energy output of an AED when they use it on a child.
Okay.
That way, the shock isn't too strong for their smaller body.
It's like a built-in safeguard.
Correct.
It's pretty clever. It makes you realize how much thought goes into these devices and all the protocols, especially when we're talking about vulnerable patients like children.
It really does. It's a testament to how much we focus on patient safety these days.
Now, let's look at the details for epinephrine.
Okay.
It gives us specifics about the concentration, the dose, and the maximum single dose. Why all these limits?
Remember, epinephrine's a powerful drug.
Right.
And like any drug, it can have side effects if you use it wrong.
Yeah.
The concentration and dosage are carefully worked out to make sure they deliver just the right amount to get the heart going again without causing harm. And that maximum single dose, that's just a safety net.
Right.
To prevent accidental overdoses.
Okay.
Which could be really dangerous.
So it's about finding the right balance.
Exactly.
Where it works but isn't dangerous.
Right. And that balance can change depending on the person, their age, their weight, their overall health.
Right.
That's why paramedics need to really understand these meds and how to use them safely.
Okay, last but not least, we've got this mandatory provincial patch point.
Yeah.
What in the world does that mean?
Patching, in this case, means contacting the doctor at the base hospital, the BHP.
Okay.
They need to talk to them for further instructions.
Okay.
It's like getting advice from a medical expert who can help them based on what's happening with the patient.
So it's like a lifeline to a specialist.
Yeah, exactly.
Who can give a second opinion or maybe offer some advice when things are really tough.
Right.
And why do they do this, especially when they're thinking about 2R?
Because, like we said, the decision to stop trying to resuscitate someone is huge.
Yeah.
The directive says they have to talk to the BHP before doing that.
Right.
The BHP can check on the patient, think about things that might not be in the directive, and then ultimately decide if it's okay to stop resuscitation or not.
So it's like a final check.
It is.
A second opinion from an expert before making that big call.
Exactly. It's a really important safety measure.
Right.
It makes sure these decisions are made with as much info and expertise as possible.
It's amazing how these guidelines give paramedics the power to act quickly,
right,
but also make sure they can get expert advice when they need it.
It's a really cool example of how protocols and human judgment work together in emergency medicine.
Yeah.
And we're just scratching the surface.
I know.
There's a whole other section on clinical considerations that goes even deeper into how paramedics make decisions.
We've covered a lot in this first part of our deep dive.
Yeah, we have.
But there's still so much more to explore.
Definitely. Okay, so let's get into these clinical considerations.
Right.
This is where we really see things get complex.
Right, like we're going from the rule book to the actual game.
Exactly. It's not always so black and white.
Right.
Like, take the point about the base hospital's airway strategy.
Okay.
That might seem like a small detail.
Yeah.
But it can really change how they care for the patient.
Okay, break that down for me.
Sure.
What does that even mean?
Well, sometimes doing the basic stuff to help them breathe.
Okay.
Like using an oral airway or a nasal airway.
Yeah.
Along with a bag valve mask.
Right.
Sometimes that's just not enough.
Okay.
Some patients need more.
Okay.
They need something like intubation.
Right, where they put a tube down the throat.
Exactly.
To help them breathe.
Right.
And that's something a doctor has to do at the hospital.
Usually, yeah.
So the paramedics have to think ahead, consider which hospital they're going to.
Right.
And whether that hospital prefers a certain way of managing the airway.
Exactly.
That could change their decisions right there on scene.
Yeah.
And it makes sure things go smoothly when they get to the hospital.
It's all about planning ahead.
So it's not just about getting to a hospital. It's about getting to the right hospital.
Exactly.
The one that can do what the patient needs.
And making sure you're ready for that transfer.
That kind of forward thinking seems to be everywhere in these guidelines.
It really is. It's impressive.
Another example that stood out was the part about naloxone.
Oh, yeah.
It says it's no clear role in a confirmed cardiac arrest.
Right?
Now, that's interesting to me.
Okay.
I know naloxone is used to reverse opioid overdoses.
It is.
So why wouldn't it be helpful if someone's heart stopped?
Yeah.
Especially if they think it might be an overdose.
That's a good question.
Yeah.
It seems kind of strange at first.
Right.
But here's the thing. In a confirmed cardiac arrest, the heart's not beating right.
Okay.
It stopped working properly.
Right.
Naloxone's main job is to help people breathe again.
Yeah.
It reverses the effect opioids have on breathing.
Okay.
So while an overdose could lead to a cardiac arrest,
right.
Once the heart has actually stopped, naloxone isn't going to fix that.
I see. So it's like trying to fix a flat tire by filling up the gas tank.
Exactly. You're focusing on the wrong thing.
Right. You're not solving the real problem.
When the heart is stopped, the priority is getting it beating again.
Okay.
That means CPR and defibrillation.
So naloxone, while it's a lifesaver in other situations,
Totally.
it's just not the right tool for this job.
Right. It wouldn't be the right intervention in that scenario.
It's amazing how complicated it gets.
Yeah.
Even something like giving a drug,
Mm-hmm.
you have to really understand what's happening in the body.
It's not just about knowing what the drug does.
Right.
You have to know when to use it and why.
Now, this next part of the clinical considerations is really interesting.
Okay.
It talks about how the base hospital doctor might not approve TOR,
Yeah.
even if the patient meets all the criteria. What kinds of things might make them decide that?
Well, this is where human judgment comes in.
Okay.
The doctor might consider things that aren't written down in the directive.
Like what?
Things like how old the patient is,
Okay.
whether anyone saw the arrest happen and started CPR right away,
Right.
how long it will take to get to the hospital,
Okay.
or even what they think caused the arrest.
So even though there's a checklist,
Yeah.
it's not just about following it blindly.
No, it's not just ticking boxes.
There's still room for professional judgment
Exactly.
and for looking at the whole situation.
It's about seeing the big picture.
And it can go the other way too, right?
Yeah.
The doctor could approve TOR even if the patient doesn't meet all the criteria.
Exactly.
That seems strange.
Yeah.
Why would that happen?
Imagine there are a lot of logistical challenges.
Like what?
Like maybe the terrain is really rough,
Right.
makes it almost impossible to transport the patient.
Yeah.
Or maybe there's a mass casualty incident and resources are stretched thin.
So in those extreme cases,
Yeah.
the doctor might make the tough call to stop resuscitation,
It's a difficult decision.
even if they could technically keep going.
Right.
Wow, that really shows how complicated these decisions are.
Yeah, it's not easy.
It's not just about following the rules.
Yeah.
It's about weighing everything. The medical stuff, the logistics, even the ethical stuff.
You have the best judgment call you can
Right.
in a really tough situation.
Speaking of the base hospital doctor,
Okay.
it seems like their role goes beyond just approving TOR.
Yeah.
There's a whole section about talking to them about defibrillation Joule settings.
Right.
Now, I'll admit that sounds pretty technical.
It is a bit.
Can you explain it for us?
Sure. Joules are just the units we use to measure the energy from a defibrillator.
Okay.
You can think of it like how strong the shock is.
Okay.
Higher joules mean a more powerful shock.
Right.
The directive gives general guidelines.
Yeah.
But the doctor at the hospital actually decides the exact joule setting.
So another example of the guidelines being flexible,
Yeah.
letting the experts on the ground make decisions.
Right.
But why leave that up to the doctor?
Good question.
Couldn't the directive just say what Joule setting to use in different situations?
It's not that simple.
Okay.
Lots of things can affect the right joule setting.
Like what?
The patient's age, their size, any other health problems they have,
Yep.
even the type of defibrillator they're using.
So there's no one-size-fits-all approach.
Exactly.
It's like tailoring a suit.
Kinda, yeah.
You have to measure, make adjustments, make sure it fits that specific person.
In this case, the doctor is like the tailor.
Right.
They decide what fits best for the patient when it comes to the defibrillation energy.
That's a great analogy.
Thanks.
But why is it so important to get that fit right?
Well, if the setting is too low,
Yeah.
the shock might not be strong enough to restart the heart,
Okay.
but if it's too high,
You could damage the heart muscle.
so it's a delicate balance.
Yeah, it is.
You need enough power to be effective,
Right.
but not so much that you cause harm.
You got it.
It just shows how complex these decisions are.
It's not easy stuff.
This is all so fascinating.
I know, right?
It's like peeling back the layers of an onion.
Yeah.
Every detail reveals something even more complex.
And we're not even done yet.
I know, right?
There's still more to discuss.
Years of research, experience, just this commitment to making sure people get the best possible care.
Especially in those situations where it's like, life or death.
Exactly, when it matters most.
So as we wrap things up,
All right.
let's think about what this all means for our listener.
Okay.
Why should they care about these really specific details
Yeah.
of pre-hospital cardiac arrest care?
Well, first of all, the more you know,
Yeah.
the more you can advocate for yourself
Right.
or for your family, if there's ever an emergency.
It's like getting a sneak peek behind the scenes.
Exactly. You see how things work,
Yeah.
what they think about, what decisions they make.
And those decisions are being made for you, ultimately.
Yeah, and while we're not saying you should try to be a doctor or anything,
Right.
knowing a little about these protocols can help you ask better questions.
Yeah.
You know, talk to the healthcare providers more effectively.
So you can make sure you're heard.
Exactly, especially in those crazy situations.
Right, where things are happening so fast.
Yeah, where every word matters.
That clear communication can be so important.
Totally, it can make all the difference.
But I think understanding these guidelines is important for more than just individuals.
Okay, I'm curious.
What do you mean by that?
Think about it. These directives, they show how emergency medicine is always changing.
Right.
It's based on the latest science, the best practices,
Mm-hmm.
but they're always reviewing them, updating them as we learn more.
So it's not like it's set in stone.
Nope, it's always evolving.
And by understanding that process,
Yeah.
we can really appreciate how much work goes into this.
Oh, for sure.
You know, how dedicated they are to making sure people get the best care possible.
Absolutely. It's really inspiring.
It makes you realize that these paramedics
Yeah.
and those doctors at the base hospital,
Mm-hmm.
they're not just robots following a script.
No, not at all.
They're making these really complex decisions
Yeah.
in real time.
With so many things to consider.
It's impressive.
It is.
It's like they're walking a tightrope. They have to follow the rules,
Mm-hmm.
but also use their own judgment.
Right, based on what's happening in that moment.
And the stakes are so high.
It's incredible, really.
It is. It's something we should all be grateful for.
Definitely.
So as we wrap up this deep dive,
Okay.
I want to encourage our listeners to keep learning,
Yes.
to keep exploring this world of emergency medicine.
There's so much out there.
There is, like the Ontario Ministry of Health website.
Yeah.
You can find the full guidelines there
You can really dig in.
and learn even more about what these paramedics and doctors do every day.
I bet this deep dive will inspire some people.
I hope so.
You know, maybe they'll want to get involved in this field themselves.
That would be amazing.
They would, maybe as a paramedic,
Yeah.
a doctor, a researcher, or just someone who's more informed.
Just a more engaged citizen. You know,
Exactly. Because the more people who understand this,
Mm-hmm.
the better we can support the people who are out there saving lives.
Well said. I think that's a perfect way to end our discussion.
I agree.
Thanks for joining us.
It was my pleasure.
For this deep dive into Ontario's medical cardiac arrest directives.
That was fun.
Until next time, stay curious, stay informed, and stay well. You know, it's crazy to think about all the decisions paramedics have to make like every second, right? Especially when it comes to something as intense as opioid toxicity and withdrawal.
Oh, absolutely. It's definitely a high-stakes environment. They're walking a tightrope, trying to save a life, but also, like, managing this really complex medical situation.
And that's exactly what we're diving into today.
Oh,
We're
my.
using these guidelines. They're called the Advanced Life Support Patient Care Standards, and they're from the Ontario Ministry of Health in Canada.
Yeah.
And they basically lay out like exactly how paramedics in Ontario are supposed to handle these situations, you know, when they're out there on the ground.
Exactly. I mean, these are the guidelines that paramedics rely on, especially when they suspect an opioid overdose, right?
Yeah.
And they outline, like, two main treatment options, naloxone and buprenorphine naloxone.
Okay, so let's break that down. Let's start with that first one, naloxone. The guidelines actually mention a bunch of different ways this medication can be given.
Right, yeah, there are several ways to administer it. Intravenously, that's IV. Intramuscularly, that's IM. Intranasally, IN. And subcutaneously, or SC. And the guidelines, you know, they get super specific about the dosage for each one. Like, for example, if you're going IV, the maximum single dose is 0.4 milligrams.
Yeah.
And paramedics can give, like, up to 3 doses.
Oh, wow. So is there like a preferred way to give it, or does it just depend on what's happening?
Yeah, it totally depends on the situation.
Yeah.
You know, like how bad the overdose is, the patient's overall condition.
Yeah.
But there's something that might surprise you. When paramedics give naloxone, especially through an IV, the goal isn't always to, like, wake the patient up right away.
Oh, really? Why not?
Well, imagine someone's in a deep opioid haze and then, bam, they're suddenly jolted awake. It can be really intense. They can go into withdrawal, like really bad. They could get confused, agitated, even aggressive.
So it's more about getting them breathing again
Yeah.
safely and less about like snapping them out of it completely.
Exactly. It's about restoring, like, those vital functions.
Yeah.
But you want to do it in a controlled way, right? In fact, the guidelines even say that only paramedics with special authorization can give naloxone intravenously. It's a pretty delicate balance.
That makes sense. So there are like different levels of expertise even within the paramedic world,
Yeah,
like for this one skill.
absolutely.
Yeah.
Different situations need different levels of training and authorization. But, you know, even though naloxone is often the first thing they try, the guidelines also really emphasize other steps, like Airway management, making sure the patient can breathe. That's always the top priority.
Yeah.
And they even say to check the patient's blood sugar if naloxone isn't working.
Oh, wow. It's like they have this whole checklist, like detectives or something, making sure they're thinking of everything, even in these like high pressure situations.
Yeah, exactly. They have to rule out other things that could be going on and like address any immediate threats to the patient.
Yeah.
Make sure they're stable.
Okay, so we talked about managing the overdose, but what about when someone's already in withdrawal?
Right. So that's where the second part of the guidelines comes in, managing acute opioid withdrawal. And for that, they use this tool. It's called the Clinical Opiate Withdrawal Scale, or COWS.
Oh, yeah, I've heard of that, the CIWS scale. It basically gives you a score, right? Based on how bad the withdrawal symptoms are.
Got it. It looks at things like sweating, anxiety, tremors, even goosebumps. They ask the patient questions, and then based on the answers, they get a score. And that score helps the paramedics figure out what to do next.
So a higher COWS score means the withdrawal is more severe.
Yeah, exactly. And if the score is 8 or higher, then the guidelines say paramedics can consider using buprenorphine naloxone.
And that's the second treatment option we talked about.
Right. Buprenorphine naloxone is actually kind of interesting. It's a mix of two drugs. The buprenorphine part, it binds to the same receptors in the brain as other opioids, like heroin or fentanyl. But it has a much milder effect, so it can help with cravings and withdrawal symptoms. And then the naloxone, well, it's an opioid antagonist. It's mainly there to prevent people from misusing the medication.
So it's like kind of hitting the brakes on withdrawal, but also putting up a guardrail so it's not misused.
Yeah, that's a great way to put it. And the way it's given is also kind of different. It's sublingual, meaning it goes under the tongue. And the starting dose, according to the guidelines, is 16 milligram.
And are there more doses after that, or is it just the one time?
The guidelines do lay out how to give more doses, if they're needed. Paramedics can give 8 milligrams every 10 minutes, up to a total of 24 milligrams. But just like with the IV naloxone, paramedics need special permission to give buprenorphine naloxone. It's not a decision they make lightly.
So it sounds like there's a lot of emphasis on like training and authorization for all of this.
Yeah, absolutely.
Which makes sense given how complex this all is.
It really shows how much responsibility paramedics have.
Yeah.
You know, they're not just giving meds. They're making decisions that could really impact someone's life.
And they're doing all this under pressure out in the field. It's kind of remarkable when you think about it.
Yeah, it really is. These guidelines, they give us a peek into what paramedics deal with every day. It's incredibly challenging, you know, trying to revive someone from an overdose while also managing the withdrawal, trying to find that balance.
And that balance, that fine line you mentioned, it makes you think about the bigger picture. Like, what's the overall goal here? Is it always about immediate revival, like waking someone up as fast as possible? Or is there a reason to be more cautious, especially with those potential withdrawal symptoms we talked about?
That's a great question, and it leads to some really important considerations about the opioid crisis and the whole idea of harm reduction.
Yeah, I'm really curious to hear more about that. It sounds like we're about to get into something pretty deep.
It is interesting, isn't it, that balance, that like fine line. It really gets at the heart of harm reduction, you know, when we think about how to deal with the opioid crisis.
I've heard people talk about harm reduction, but I'm not sure I totally get what it means, like in this situation.
So harm reduction, it's basically recognizing that people use drugs and they do it for all sorts of reasons. And sometimes like quitting completely right away. It's just not realistic. Or maybe it's not even the main thing you're going for. So instead, you focus on reducing the bad stuff, the negative consequences that come with drug use.
So it's not about like judging people
Yeah.
or trying to make them fit into some like perfect mold. It's more about, you know, meeting them where they're at, offering support.
Exactly. It's about seeing people who use drugs as, well, people. They deserve care and respect, regardless of their choices, right?
Yeah.
And when we talk about the opioid crisis, there are a lot of harm reduction strategies.
Like what? What kinds of things?
Well, a big one is making sure people have access to clean needles, clean syringes. It might seem, I don't know, counterintuitive.
Yeah.
But it actually helps stop the spread of diseases like HIV, Hep C, things like that.
Oh, right. Yeah. That makes sense. It's about reducing the potential for harm, even if they're still using drugs.
Exactly. Another big piece is naloxone. We talk about how paramedics use it, but it's really important for other people to have it too. Friends, family, even just people in the community. Having those naloxone kits around can literally save lives.
So it's about giving people the power to step in and maybe save a life.
Yeah. And then there's connecting people to treatment, like actual treatment programs, medication-assisted treatment,
Yeah.
counseling, support groups. The key is to have different options so people can find what works for them. Different situations, different needs.
It sounds like harm reduction is about a lot of different things then. It's not just one thing, it's about looking at the whole problem from all sides and not just focusing on getting people to stop using drugs entirely.
That's a really good way to put it. It's complex, right? Addiction is complex. There's no one answer. And those guidelines we talked about, the
Yeah.
ones paramedics use, they actually showed this whole harm reduction philosophy.
Oh, really?
Think about how they give the naloxone. We said the goal isn't always to immediately wake the person up. It's more about getting those vital functions back safely and making sure the person doesn't get too agitated, right? Too uncomfortable. That's harm reduction right there.
It's like a more gentle approach, recognizing that the person's going through something really tough, physically, emotionally.
Exactly. You're treating them with respect, with dignity, even when they're in the middle of this crisis. And, these same ideas apply to how they manage withdrawal. Remember that COWS scale and the buprenorphine naloxone.
Yeah, they use it when the withdrawal is really bad.
Right. And the fact that they have these guidelines, this protocol for managing it, using meds to make the person more comfortable, to help with the cravings, that's harm reduction too.
It's like they're trying to make the whole experience less awful, less traumatic, They get that it's really hard and that people need support to get through it.
That's a great point. It's all about seeing addiction as a health issue, not some kind of moral failing. People deserve good treatment, compassionate treatment.
This is really eye-opening. I never thought about it this way. The connection between the guidelines and the whole philosophy of harm reduction. It's pretty amazing, actually.
It really shows how important it is to remember the human side of things. It's easy to get caught up in the stats, the technical stuff. But at the end of the day, this is about people's lives.
And paramedics are the ones on the front lines, right? Dealing with all this day after day.
Exactly. It's a really tough job. They need medical skills, but they also need to understand addiction. They need compassion and a real commitment to harm reduction. It's a lot to ask, really.
It makes you wonder how we can help them more, support them. They're not just dealing with physical problems. They're dealing with people at their most vulnerable.
That's such an important question. I think we need to talk about it more. We talk a lot about the opioid crisis from a public health perspective, but we forget about the people actually doing the work, the human cost,
So where do we go from here? How do we turn all this talk into something real, something that will help? Wow.
So we've covered a lot of ground today, haven't we?
We really have. It's been a pretty in-depth look, wouldn't you say, from those specific guidelines, the ones paramedics in Ontario actually use when they're responding to potential opioid overdoses or people in withdrawal.
Yeah. We talked about all the ways they can give naloxone and how it's not always about, waking someone up right away and how that whole approach is kind of tied to this idea of minimizing harm, right?
Exactly. And then we talked about that COWS scale, how it helps paramedics figure out how serious the withdrawal symptoms are and then what to do next.
And we talked about buprenorphine naloxone, how it can help manage the withdrawal, make the whole thing a little less rough.
Right. It helps with the discomfort, the cravings. And the fact that they have these specific protocols for it, that's a big part of harm reduction, too.
Harm reduction, that's been the biggest takeaway for me today, I think. It's really changed how I think about this whole issue. Me too. It's not about, forcing people to change overnight. It's about meeting them where they're at, helping them, supporting them.
And remembering that they're people, with their own stories, their own struggles.
Exactly. And it's so important to remember that, especially with all the stigma around addiction. And speaking of which, it brings us back to the paramedics. They're often the first ones there, right? When someone's overdosing or going through withdrawal.
Yeah. They're dealing with some really intense stuff, making decisions that could, make the difference between life and death. And they have to think about all these different things, medical factors, social factors. It's a lot.
It really is. And it takes a lot. They need the medical knowledge, of course, but they also need to understand addiction. They need to be compassionate. And they have to believe in this whole harm reduction approach. It's a really demanding job.
So, as we finish up here, it makes me think, how can we do more as a society to support these first responders, the paramedics? They're doing so much.
That's a big question, a really important one. I think it starts with, acknowledging how tough their jobs are, the pressure they're under, and then giving them what they need, resources, training, support, so they can actually do their jobs safely, effectively.
And we have to deal with the bigger problems, too, the things that are causing this opioid crisis in the first place. Poverty, trauma, the lack of mental health care, all of that.
Right. It's a complicated problem, a lot of different pieces. But I think this deep dive has helped us see one really important part of it all, the paramedics, and how important that whole harm reduction approach is.
Yeah, it's given me a lot to think about, and hopefully it's done the same for you, our listener. Thanks for joining us for this deep dive.
Thanks for listening, everyone. It's a tough topic, but it's a conversation we need to be having. The opioid crisis, it affects all of us in one way or another. So let's keep talking. Let's challenge how we think about it. And let's work together to find solutions that are both, effective and compassionate. All right, let's jump into another deep dive. Today, we're taking a look at, well, paramedics, actually.
Oh, interesting.
Yeah, you guys sent over some guidelines that they use here in Ontario.
Okay.
And I got to say, they're a lot more interesting than I thought they'd be.
Really?
Yeah. I mean, these are the folks who show up when, things go really wrong. So, their decisions really matter.
Oh, absolutely. The decisions they make can have a huge impact on a patient's outcome.
For sure. And I think for most of us, we just see the tip of the iceberg, right?
Mm.
The sirens, the rush into the hospital.
Right.
But there's a whole lot going on behind the scenes.
Yeah, there's a whole lot that we don't see.
Yeah. So, for example, the guidelines talk about this thing called patching.
Mm-hmm.
Can you kind of explain what that is?
Oh, yeah. Patching is essentially like having a direct line to expert advice.
Okay.
So imagine you're a paramedic, right? And you're out in the field and you encounter a really tricky situation. Maybe it's an unusual injury or a patient with a really complex medical history. Patching allows them to connect directly with a base hospital physician, a BHP,
Oh, wow.
for real-time guidance. So it's like having a doctor on call, which can be absolutely crucial when you're making those split-second decisions that could really impact someone's life.
Wow. That makes a lot of sense, especially when you think about them being on the move and every second counting.
Exactly.
So when exactly do they have to patch in?
Right.
Is it like a judgment call, or are there specific situations where it's mandatory?
Yeah, so the guidelines actually lay out three main scenarios. Okay, so first, you have situations that always require BHP's input. Things like, cardiac arrests,
Oh, okay.
severe allergic reactions. These are like the must-call moments.
Yeah.
Where the stakes are really high.
Right.
And a doctor's guidance is just absolutely critical.
Okay, so those are the non-negotiables.
Yeah.
What about those gray areas where
Yeah.
a paramedic might not be sure?
Right. That's where that second scenario comes in.
Okay.
So these are situations that fall within a paramedic's scope of practice. Like, they have the training to handle it,
Right.
but maybe they need a second opinion, or the case is a bit more complex than usual.
Uh-huh.
So in those cases, patching with a BHP can be really valuable just to, get that reassurance and
Yeah.
make sure that the patient's receiving the most appropriate care.
So it's almost like a safety net, even if they technically could handle it on their own.
Exactly.
Yeah, I'm starting to see just how much responsibility they have, constantly having to assess and make decisions.
Yeah, they have a lot of autonomy out there.
Wow.
And then there's the third scenario. This is more about seeking advice for, unusual situations or particularly difficult ones.
Okay.
So a paramedic might patch in just to consult with the BHP and get their expert opinion on how to proceed.
Oh, so it's almost like a, hey, I've never seen this before, what do I do kind of thing.
Exactly, yeah.
Oh, wow. Okay, that's interesting. So patching really seems like a lifeline for these paramedics, connecting them to that higher level of medical expertise when they need it most.
Right, it's an invaluable resource for them.
But what happens if they can't get through?
Hmm.
What if they're in a really remote area with terrible reception, or the BHP's unavailable for some reason?
Yeah.
That's got to be stressful.
Yeah, that's a crucial point, and the guidelines do address that.
Okay.
So there's this thing called the life-saving intervention clause.
Okay.
Essentially, if a paramedic has tried to patch but they can't reach a BHP, and the patient needs immediate action that falls within their scope of practice, they're allowed to act without that online authorization.
Wow. That must be a tough call to make, knowing that you're acting without that direct medical oversight.
It is. It's a huge responsibility.
There's no room for hesitation in those situations.
Absolutely not.
Wow. Okay, so the guidelines are really clear about the importance of documenting these, patch failures.
Yeah, patch failures.
And reporting them appropriately afterwards.
Exactly, yeah. It's all about accountability.
So there's a lot of accountability built into the system.
Right.
They can act independently when necessary, but it's not a decision that they take lightly.
Right. That's a big deal.
Speaking of tough decisions, what happens if a BHP actually instructs a paramedic to do something that's outside of their training?
Oh, yeah.
That must put them in a really difficult position.
You've hit on another incredibly important aspect of paramedic practice.
Okay.
The guidelines are very clear that a paramedic's primary responsibility is to their patient.
Got it.
So if a BHP's instruction exceeds their scope of practice, or they believe that it would put the patient at risk,
Yeah.
they are expected to push back.
I can imagine it takes a lot of courage to, question a doctor, especially in a high-pressure situation like that.
It does. It takes a lot of confidence and a strong sense of, professional ethics.
Yeah.
They need to be able to clearly communicate their concerns, explain their limitations, and really advocate for the safest course of action for their patient.
Yeah.
This highlights, the need for paramedics to have a strong ethical compass and the ability to make sound judgments under pressure.
Yeah. I'm starting to see a pattern here.
Yeah.
It seems like a lot of what paramedics do hinges on, critical thinking and adapting to each unique situation.
Absolutely. That's a huge part of their job.
So far, we've talked about, individual decision-making.
Right.
But what about when there are multiple paramedics on scene? How do they work together and make sure everyone's on the same page?
Well, imagine you have a team of paramedics arriving at, an accident scene, right?
Yeah.
You might have paramedics with different levels of training and experience.
Right.
To ensure the patient receives the best possible care, the guidelines establish a clear hierarchy of responsibility.
Okay, so it's not just a free-for-all where everyone jumps in.
Not at all.
Okay.
The paramedic with the highest level of certification assumes overall responsibility,
Got it.
especially for actions that might be outside the scope of practice of the other paramedics.
Oh, okay.
This ensures a smooth flow of expertise and prevents any confusion about who's leading the care.
Okay, so there's a clear chain of command.
Right.
But what happens if they disagree on the best course of action?
Oh, yeah.
Do they ever have, conflicts?
Well, that's where communication becomes absolutely essential.
Right.
They need to be able to, respectfully voice their opinions, listen to each other's perspectives, and ultimately come to a decision that prioritizes the patient's well-being.
Yeah.
And remember, they always have that option to patch in with a BHP for guidance if they need it.
So it's a combination of clear protocols and good old-fashioned teamwork.
Exactly.
Yeah.
That's what it comes down to.
Awesome. Okay. So it sounds like communication is, key, especially in those, really high-pressure moments.
It is.
We've talked about how paramedics, make decisions and work together.
Right.
But what about the actual procedures they follow?
Right.
Are there, set protocols for different medical situations?
You're right. Communication is really the backbone of effective emergency care.
Yeah.
And to answer your question, yes, there are.
Okay.
These guidelines outline specific patient care models for a variety of situations.
Okay.
Things like stroke, heart attack, or even traumatic injuries.
Yeah.
Think of these as predefined playbooks
Okay.
that help paramedics provide, consistent and standardized care.
Okay. So instead of having to, reinvent the wheel every time,
Exactly.
they have a roadmap to follow.
That's a great way to put it, yeah.
Okay.
These models, they lay out the criteria for identifying a particular condition,
Right?
along with step-by-step instructions for assessment, treatment, and transport. So this ensures that no matter which paramedic team shows up, the patient receives a certain standard of care.
That makes a lot of sense.
Yeah.
But what happens if a patient, doesn't fit neatly into one of these models?
Right.
What if their symptoms are unusual or it's not clear what's going on?
That's when a paramedic's training and judgment really come into play.
Oh.
They have to rely on their foundational knowledge, the advanced life support,
Yeah.
and basic life support patient care standards
Right.
to assess the situation, rule out potential problems, and make decisions based on the individual patient's needs.
Okay.
It's a delicate balance
Yeah.
of following protocols and adapting to the unique circumstances of each call.
So even with all these guidelines and models, there's still a lot of room for individual assessment
Oh, absolutely.
and critical thinking.
Yeah, they have to think on their feet.
It's definitely not just about blindly following a checklist.
No, not at all.
Okay, that's good to know.
Paramedics are constantly having to make judgment calls based on their observations, the patient's condition, and the resources available to them.
Makes sense.
Yeah.
I'm also curious about the handover process.
Right.
When a paramedic brings a patient to the hospital,
Uh-huh.
How do they ensure that the doctors and nurses
Yeah.
have all the information they need to continue providing the best possible care?
That's another critical step in the patient's journey.
Yeah.
Imagine like the symphony of information that needs
Yeah.
to be passed on vital signs,
Yeah.
initial assessment, treatments administered,
Right.
the patient's response to those treatments.
Yeah.
It's like a carefully choreographed dance
Wow.
to ensure a seamless transition of care.
It must be a challenge to convey all of that accurately and efficiently,
It is.
especially when you're dealing with a critical patient.
It can be very challenging, yeah.
Yeah.
Clear communication is paramount.
Yep.
Paramedics use a standardized system for classifying the urgency of a patient's condition.
Okay.
It's called the Canadian Triage and Acuity Scale,
Okay.
or CTS.
Got it.
This helps hospitals prioritize incoming patients
Right.
and ensures they receive the appropriate level of care as quickly as possible.
So it's not just about getting them to the hospital.
Huh?
It's about making sure they're seamlessly integrated into the hospital system.
Exactly, yeah.
I'm really starting to appreciate all the behind the scenes processes
Yeah.
that most of us never even think about.
It's a whole other world,
Yeah.
and it doesn't stop there.
Okay.
The guidelines also touch on the importance of documentation.
Cool.
Everything a paramedic does, from the initial assessment
Right.
to the final handover,
Uh-huh.
needs to be carefully recorded.
That makes sense.
Yeah,
I guess accurate documentation is crucial for a lot of reasons.
it is.
Legal protection,
Yeah.
quality control,
Uh-huh.
and even for training purposes.
Right.
It's like a written record of their decision-making process.
Exactly, yeah.
Yeah.
It ensures accountability, helps identify areas for improvement,
Right.
and contributes to the overall advancement of paramedic practice.
Okay, so it's not just about the immediate situation.
Right.
It's
Yeah.
about learning and improving for the future.
Exactly.
Okay.
Speaking of advancement, there's one more aspect of the guidelines I want to highlight.
Okay.
The role of research.
Oh, yeah.
Yeah.
I remember seeing something about that.
Uh-huh.
It mentioned how research sometimes leads to changes in how paramedics operate.
That's right.
Yeah.
These guidelines aren't static.
Right.
They're constantly evolving
Yeah.
based on new findings and advancements in medical knowledge.
Okay.
Paramedics are encouraged to stay up to date on the latest research
Uh-huh.
and incorporate evidence-based practices into their work.
It's reassuring to know that they're not just stuck in their ways.
Right.
But are constantly learning and improving.
Absolutely. It's a constantly evolving field.
Yeah.
Yeah.
It also makes you wonder what the future holds for paramedicine
Right.
with all the advancements in technology and medicine.
Yeah.
Who knows what amazing things they'll be able to do in the years to come.
It's exciting to think about the possibilities.
Yeah.
Maybe we'll see new diagnostic tools
Oh, okay.
that allow paramedics to assess patients even more accurately in the field,
Right.
or perhaps advancements in telemedicine
Uh-huh.
that connect them with specialists in real time
Okay.
for even more complex cases.
It's like we're just scratching the surface of what paramedics are capable of.
Yeah, I think you're right.
Now that we have a solid understanding of how paramedics navigate this complex world of protocols and procedures,
Right.
I think it's time we dive into one of the most fascinating aspects of their work. Medication administration.
Okay, that's good.
We've all seen those medical dramas where they're injecting people with all sorts of things.
Right, right.
But I'm guessing there's a lot more to it than meets the eye.
You're absolutely right. Yeah. Administering medication in the field is a complex skill
Okay.
that requires precision, knowledge, and a deep understanding of pharmacology.
Okay.
The guidelines provide a very clear framework
Okay.
for how paramedics make decisions about which medications to use,
Yeah.
how much to administer,
Right.
and even the best way to deliver them to the patient.
So it's not just about grabbing a syringe and hoping for the best.
Not at all.
Okay.
There's a lot of thought and calculation that goes into every decision.
Right.
For example, the guidelines specify that unless stated otherwise,
Uh-huh.
the recommended number of doses can be given,
Okay.
regardless of how many the patient has already received.
So in some cases, they might need to administer multiple doses of the same medication.
Exactly.
Yeah.
Of course, this is always done within the boundaries of safe practice
Right.
and in consultation with a BHP if necessary.
Yeah.
But it highlights the fact that paramedics need to be adaptable
Okay.
and able to adjust their approach based on the evolving needs of the patient.
It sounds like there's a lot of nuance
There is.
to medication administration in the field.
Yeah, it's not a one-size-fits-all approach.
I'm also curious about the different ways they can actually give the medication.
Okay.
I mean, there's the classic injection,
Right.
but I'm sure there are other methods as well.
You're right. The choice of administration route
Okay.
depends on a number of factors,
Right.
including the type of medication, the patient's condition, and the urgency of the situation.
Right.
The guidelines outline several options,
Okay.
and interestingly, the order in which they're listed
Yeah.
actually indicates the preferred route.
So it's not just a random list.
No.
There's like a hierarchy based on what's considered most effective
Mhm.
or appropriate.
Exactly. They
Yeah.
start with the most preferred method
Right.
and work their way down the list
Uh-huh.
based on what's feasible in each specific situation.
Makes sense.
For example, intravenous administration,
Okay.
where the medication is injected directly into a vein,
Right.
is often the most preferred route
Okay.
because it allows the drug to enter the bloodstream quickly.
Right.
But sometimes, due to the nature of the medication
Yeah.
or the patient's condition, other methods might be necessary.
Okay.
Intramuscular injection,
Yeah.
where the medication is delivered into a muscle,
Right.
is another common route.
Okay.
And then there's the oral route,
Yeah.
where the medication is given by mouth.
Okay, so they have a whole toolbox of options at their disposal.
They do.
It's fascinating how they have to like consider all these factors
Yeah.
and make these like split-second decisions
Yeah.
in the midst of what's likely a very chaotic situation.
Absolutely.
Yeah.
And it gets even more complex when
Oh.
you're dealing with pediatric patients' children
Right.
because their bodies are still developing.
Right.
They often require different dosages
Mhm.
and sometimes even different formulations of medications compared to adults.
That makes sense. I
Yeah.
imagine dosing children accurately
Yeah.
must be a real challenge.
It definitely requires extra care and attention to detail.
Right.
Sometimes paramedics might use a specialized tool
Okay.
called the Broslow tape
Okay.
to help determine the correct dosage for a child.
Okay.
It's essentially a color-coded tape
Okay.
that uses the child's length
Right.
to estimate their weight and calculate the appropriate drug dose.
So it like takes the guesswork out of it
It does, yeah.
and ensures they're giving the like the safest
Yeah.
and most effective amount of medication.
Precisely.
Okay, that's interesting.
And then there's this interesting detail about rounding doses.
Okay.
Because sometimes
Yeah.
the calculated dose might be a fraction
Right.
that can't be measured accurately with the tools they have on hand.
Okay.
In those cases, they round it to the nearest measurable dose to ensure accuracy. It just goes to show the level of precision involved in every aspect of their work.
I'm really starting to see how much like knowledge and skill
Yeah.
goes into being a paramedic.
It's a very demanding job.
It's so much more than just like driving an ambulance and taking people to the hospital.
Absolutely.
Yeah.
They're highly trained medical professionals
Right.
who make critical decisions every day,
Yeah.
often in life or death situations.
Right.
Their ability to assess, adapt, and act decisively is truly remarkable.
Well, this deep dive has certainly opened my eyes to the complexities of paramedicine.
It's a fascinating field.
I'm starting to see those flashing lights and sirens in a whole new light.
Me too.
It's amazing how much we've uncovered just by looking at these guidelines.
It really is, isn't it?
Who knew there was so much depth to the world of paramedics?
Oh, it's fascinating. And you know what's really interesting to me?
What's that?
While these guidelines are, filled with all these technical details and procedures,
Mm.
they also reveal a lot about the human side of emergency care.
Yeah, that's a good point.
We often think of medical interventions as being very black and white,
Uh-huh.
but it seems like paramedics are constantly making judgment calls
Right.
and adapting to these unique situations. It's not just, oh, here's the protocol, follow it to the letter.
Right, exactly. They're not just following a rigid set of rules.
Exactly. They're using their knowledge,
Yeah.
their experience,
Uh-huh.
and their critical thinking skills to make the best possible decisions
Yeah.
for each individual patient. And they're doing all of this under immense pressure,
Mm.
often in these chaotic and unpredictable environments.
It's true. That's what really struck me as we went through these guidelines.
Yeah.
Just the level of responsibility.
It's huge.
Okay.
Dealing with life or death situations,
Yeah.
having to assess patients quickly, make critical decisions, provide life-saving interventions,
Right.
it takes a remarkable blend of technical expertise, compassion, and mental fortitude.
I think it really makes you think differently the next time you see an ambulance speeding down the street.
Right.
There's so much more to it than just lights and sirens.
Absolutely. And speaking of the future,
Yeah.
there's one thing that really stuck with me from the guidelines.
Okay.
I think it speaks volumes about where paramedicine is heading.
Okay, I'm intrigued.
Remember how they emphasize the importance of research?
Yes.
Staying up to date on the latest medical findings?
Yeah, it was interesting to see how these guidelines are like living documents,
Right.
constantly evolving
Right.
based on new evidence and advancements in medical knowledge.
That's what I find so fascinating. It means that what we consider best practice today might be completely different tomorrow.
It's true.
And it makes me wonder, what kind of groundbreaking research is happening right now that could radically change the way paramedics operate in the future?
That is a great question. It's exciting to think about the possibilities. Maybe we'll see advancements in like portable diagnostic tools
Oh, yeah.
that allow paramedics to like gather even more information about a patient's condition in the field.
Absolutely.
Like right then and there.
Right on the spot.
Yeah.
Or perhaps we'll see wider adoption of like telemedicine technologies
Oh, yeah.
that allow paramedics to consult with specialists in real time,
Yeah.
even in remote locations.
Imagine a world where paramedics can perform like even more advanced procedures on scene,
Right.
potentially saving even more lives.
It's incredible to think about the potential impact.
Yeah.
And it really highlights the fact that we've only just scratched the surface.
It's true.
Yeah.
Well, this has been an eye-opening deep dive.
I agree.
I definitely have a newfound appreciation for like the skill, the dedication, and the critical thinking
Yeah.
that goes into being a paramedic.
Absolutely.
Well, I think we've just given our listeners a lot to think about.
I think so too.
Who knows? Maybe this will even inspire someone to pursue a career in emergency medical services.
That would be wonderful.
Yeah.
It's a challenging but incredibly rewarding field,
Definitely.
and one that's constantly evolving,
Yeah.
pushing the boundaries of what's possible in healthcare.
Well, on that note, we'll wrap up this deep dive. I hope you found it as informative and thought-provoking as we did.
Me too.
And remember, there's always more to learn and discover, so keep those curious minds engaged.
Until next time.
Ever feel like medical guidelines are written in some secret code? We're cracking that code today.
Yeah, sometimes those guidelines can be a little dense.
You're telling me. We're taking a deep dive into how paramedics decide whether someone who's had a seizure can head home or needs a trip to the hospital.
Right on.
We're looking at the treat and discharge protocol from the Ontario Ministry of Health.
Mm-hmm.
It's all about that balance between safety and, not sending everyone to the ER.
Yeah, makes sense.
Okay, so first things first.
Uh-huh.
These guidelines specifically apply to adults between 18 and 65. Why that age range? What's the magic there?
Well, you got to think about the different risks at different ages.
Okay, yeah.
Like with kids, seizures could be caused by something totally different than in adults.
Right.
They might need a pediatrician to figure things out.
That's-
And then with older adults, there might be other health issues going on that could complicate things, make things riskier.
Makes sense. So age is a factor. And it's not just any seizure, right? They have to have a history of epilepsy.
Absolutely. Yeah. This protocol is only for folks who have a diagnosed history of epilepsy and are taking their anticonvulsant meds regularly.
So controlled epilepsy, not a first-time seizure.
Exactly. If it's their first seizure ever, straight to the hospital.
Right, got to figure out what's going on.
Exactly.
Okay, so they have epilepsy, they're on meds. What else?
Well, another big one. It's got to be just one seizure episode within the last 24 hours.
So if they've had multiple seizures, that's a red flag.
Yeah, that's a different story. Could mean their meds need adjusting or there's something else going on.
Okay, single seizure, known epilepsy, taking their meds. What about the type of seizure? Does that matter?
It does. The seizure has to be similar to their usual seizures.
Like in terms of how long it lasts and what it looks like?
Yep, exactly. If their typical seizure is a short absence seizure, but this one was a tonic-clonic, the whole body shaking,
Yeah,
that's a sign that something's different.
could be something more serious. Right.
So the seizure has to fit their usual pattern, and they have to be mentally back to normal.
100%. The patient has to have returned to their normal level of consciousness.
If they're still confused or out of it, that's a no-go for sending them home.
Yeah, that could be a sign of a brain injury or some ongoing neurological issue.
Got to be safe. The guidelines also talk about vital signs, and they specifically mention temperature. Why is that so important?
Well, fever can sometimes trigger seizures,
Oh, interesting.
especially in kids.
Makes sense.
So if someone has a fever and a seizure, that definitely needs more investigation.
Okay, so we've got age, seizure history, single seizure, typical pattern, back to normal mentally, no fever. What about things like alcohol or drugs? What if the seizure might be related to that?
Good question. Those situations are actually excluded from this protocol.
Oh, so if someone's had too much to drink or is using drugs, it's automatic transport.
Yeah, it's a totally different situation.
Got it. Makes sense. Substance use or even withdrawal can cause seizures, and they need a different approach.
Right, right. What about if they've already been given midazolam? Does that change things?
Yes, that's another exclusion. If the patient's already received midazolam from the paramedics,
Which is a medication for seizures, right?
yep, it's often used to stop prolonged seizures,
Okay.
but it can kind of mask what's going on neurologically, so we can't be sure it's safe to discharge them.
Ah, makes sense. Gotta have a clear picture.
Exactly.
Okay, so no alcohol or drugs, no midazolam. What about injuries?
Yeah, that's a big one. They can't have any injuries related to the seizure.
Even something like biting their tongue.
Even that. It might seem minor, but it could be a sign that the seizure was more severe than usual.
Oh, okay.
Or there could be other injuries we don't see right away.
Like internal injuries.
Could be. I remember this one time a patient had dislocated their shoulder during a seizure.
Wow.
Seemed like a simple fall, but turned out to be more serious.
So you got to be extra careful.
Absolutely.
All right, so no injuries. Let me see. We've covered age, history, type of seizure, mental status, vital signs, no alcohol or drugs, no midazolam, anything else.
A few more things. The patient can't have had any recent fever, illness, or new medications.
Because that could make it harder to figure out what's going on.
Exactly. We need to know they're stable.
Makes sense.
Yeah.
And of course, these guidelines don't apply if the patient is pregnant.
Right. Pregnancy is a whole other ballgame, higher stakes. Seizures during pregnancy need extra careful management because they could affect both the mom and the baby.
Of course, yeah. So let's say everything checks out so far. What about after they're discharged?
That's a really important part. The patient needs a responsible adult to stay with them for at least 4 hours.
Just to keep an eye on things.
Exactly. And they need to understand what to do if symptoms come back.
Like when to call 911.
Exactly. They should also have a plan to follow up with their doctor.
Make sure everything's still okay.
Right. It's all about making sure they're safe and supported even after they leave the scene.
I like that. It's a whole care plan, not just treating the seizure and saying goodbye.
Exactly.
And of course, none of this happens without the patient's consent, right?
Absolutely. Informed consent is crucial. Even in an emergency, the patient or someone who can make decisions for them needs to agree to the plan.
It's their call, ultimately.
Right.
I really like that paramedics can call a base hospital physician if they're not sure about something.
Oh, yeah, that's a great safety net.
Just double check with an expert.
Exactly.
So it seems like it all boils down to this, figuring out when it's safe to let someone recover at home and when they need more care at the hospital.
Yeah, it's about finding that balance. It makes you wonder, though.
What's that?
With all the technology we have now, what if we could monitor patients remotely after they're discharged?
Oh, interesting.
Like imagine getting real-time data on their heart rate, brain activity, all that.
Could change the game.
It could. Who knows what the future holds for these guidelines?
Lots to think about. Well, thanks for diving into this with me.
My pleasure.
Until next time. All right, welcome to another deep dive. Today, I want you to imagine, just for a second, that you're shadowing paramedics, right? Seeing how they handle these, critical moments of care.
Yeah, it's a pretty intense world.
It is. We're
Yeah.
diving into those guidelines they use to make those tough decisions.
Mhm.
Like when can they actually discharge someone right there on the scene?
Right.
Or what happens if someone's like, nope, I don't want treatment. And we're also going to look at how they handle IVs and, all the new tech and meds out there that are kind of changing the game for paramedics.
It's definitely a constantly evolving field, lots to keep up with.
Yeah. So let's jump right into it, okay? First scenario, picture this, right? Someone dials 911, paramedics show up, but maybe, just maybe, a trip to the hospital, isn't actually necessary. Is that even a thing? Can they just say, you're good to go?
It is. There's a term for it, actually. It's called pre-hospital discharge from care. But it's not a decision they make lightly, that's for sure. The paramedic needs to have very specific certification to do that. And the patient, they have to meet strict, criteria, and it's all laid out in what are called medical directives.
Medical directives. Okay, now that sounds pretty official, What exactly are we talking about here?
You can think of it as like the rule book, right? It's all about patient safety, making sure everything's done by the book.
Oh,
So even if a paramedic does decide to discharge someone on the spot, they have a whole checklist they have to go through. It's like 4 main points.
4 points, huh? All right, break it down for me. What needs to happen?
Well, first and foremost, they have to be absolutely sure that the patient is even, eligible for this kind of discharge in the first place.
Right.
So those medical directives we were talking about, those are super important here. Then it's all about clear communication.
Yeah.
You got to explain the diagnosis to the patient in a way that they can understand.
So not just treating them, but making sure they actually get what's going on.
Ye-
Okay, that makes sense. What's next?
Well, then they need to come up with a solid treatment plan, right? And they go over that in detail with the patient. That includes, any potential red flags, like how do you know if things are getting worse and when do you call 911 again. But there's even more to it than that.
More. Yeah, you got me hooked.
Yeah.
What else will we talk about?
So the paramedic also has to consider, does this patient have support? Think about, like, do they have access to food? Transportation. Is there, a safe place for them to stay? Even just like, is there a responsible adult around to kind of keep an eye on things?
Oh, wow, I hadn't even considered those practical aspects.
Yeah.
So it's not just about patching them up and sending them on their way. It's really taking the whole picture into account.
Right. It's taking a holistic view, I guess you could say. Because medical care, it's not just about treating the immediate thing. It's about all those other factors that play into a patient's overall health and well-being.
Okay, I'm impressed. Seriously.
Hmm.
So we've talked about when a paramedic can say, you're good,
Hmm?
but what about the opposite? Right?
Yeah.
Those times when a patient is like, nope, I don't need any help. Those big dramatic scenes you see on TV, like, I don't need a doctor. How does that actually play out in the real world?
Yeah, yeah. Well, it's actually more common than you might think. And you know what? Patients have the right to refuse treatment, even if, it seems like they really need it.
Really? Wow. That must be a tough spot for a paramedic to be in, though. Do the guidelines address that at all?
They do. They specifically mention something called the BLS PCS.
ELS, PCS. Okay, I need a translator here. What does that stand for?
Basic Life Support Patient Care Standards.
Okay.
It's basically a comprehensive guide, like what do you do when a patient says no? It helps ensure that everything's documented, everything's handled the right way, respecting that patient's choice while also, protecting everyone involved from any potential legal issues down the road.
So it's not just about honoring their right to say no, but also like making sure everyone's covered.
Got it.
Okay, let's switch gears a bit. We got to talk about IVs, right? We always see those in medical shows, but how crucial are they in the real world of paramedics?
Oh, they're absolutely essential, especially when you're dealing with emergencies. But it's not just about sticking a needle in, there's a whole system to it. There are actually 2 levels of authorization for paramedics when it comes to IV access.
2 levels. Okay, I'm all ears.
Yeah. So you have PCP Assist 3, and then there's PCP Autonomous 3. PCP just stands for Primary Care Paramedic, by the way.
Gotcha. Okay, so assist versus autonomous. Wait, break that down for me. What's the difference in practice?
Okay, so with PCP Assist, the paramedic can put in the IV, but only if they're specifically directed to do so. And they have to be supervised directly by an advanced care paramedic. We call them ACPs for short.
Okay.
And they can't actually give any fluids or meds through that IV. The ACP handles that part.
So it's more about helping with the procedure itself, right?
Mhm.
What about autonomous?
PCP Autonomous IV means they can not only start the IV independently, but they can also administer the fluids and meds, of course, all according to those medical directives we were talking about earlier.
Right.
It's a big responsibility, and it takes a lot of skill and training.
I can see that. So why even have 2 levels then? What's the point?
Well, it kind of reflects how paramedicine has evolved over time. The assist authorization, they're actually phasing that out.
Really?
It's about recognizing that paramedics are doing more these days, and they have the knowledge and the skills to provide higher levels of care on their own.
That's really interesting. Especially, when you think about how medicine is advancing so much.
Yeah.
People are managing really complex conditions at home now. So what does that mean for paramedics who end up at those homes?
That's a really great question. It's almost like, a whole new area for them. The guidelines specifically talk about home medical technology and novel medications as factors paramedics need to be aware of.
Okay, so I'm picturing like all kinds of fancy futuristic medical devices in someone's living room. So what exactly counts as home medical technology?
It could be anything, really. Ventilators, feeding tubes, implanted devices like pacemakers or insulin pumps.
Mm-hmm.
Basically, any medical equipment the patient's using on a regular basis at home.
I bet there's some stuff even I wouldn't recognize. And what about those novel medications? What are we talking about there?
Those are the newer meds, the ones that are used for those rarer conditions or the more complex chronic conditions. Sometimes the patient will take them themselves. Sometimes a caregiver gives it to them. And it's not always as simple as just popping a pill either.
Right, right. Okay, so that sounds like a lot to keep up with. What did the guidelines say about how to handle all these new gadgets and drugs?
Well, they basically acknowledge that paramedics can't be expected to know everything about everything. They can't be trained on how to operate every single piece of equipment or administer every medication out there, especially not in someone's home. So a lot of it comes down to relying on the patient or the caregiver because they're the experts in their own care.
Right. So trust the people on the scene.
Yeah.
Gotcha. But what if there's a problem, like a device malfunctions? Can a paramedic step in and try to fix it?
Well, that's where it gets a little tricky. They're limited to what they're actually authorized to do. So, no, they can't just start messing with some device they've never seen before or give a medication they're not trained on. It's
Right.
about knowing your limitations and working within them.
So assess the situation, stabilize the patient, and basically rely on whoever knows the device best. That makes sense. But man, clear communication has got to be key in those moments, right? Things could get pretty confusing fast.
Absolutely. Try explaining how your complicated medical device works to someone while you're having a medical emergency.
Exactly. That's a lot. Yeah.
Yeah.
So how do paramedics prepare for all this? Especially with home healthcare tech getting, more and more advanced all the time.
Well, that's where we come back to those local training modules I mentioned earlier.
Right.
The more familiar they are with common home medical technologies, the different medications out there, the better they'll be at handling these situations.
So it's not just about the injury or the illness, it's the whole context of someone's healthcare.
Yeah, it's about understanding the bigger picture.
This is fascinating. It really is like a whole new world for paramedics.
It is. It's demanding, too, both mentally and physically. And as medicine keeps changing, it's only going to get more complex.
You're not kidding. All right, before we move on, though, I want to circle back to continuing education for paramedics. What kind of training do they need to stay ahead of the curve, especially with all these advancements in home healthcare?
Well, they definitely need to keep up to date on all the latest, in terms of medical advancements.
Yeah.
And that means being aware of those home healthcare technologies and all those new medications coming out all the time. Think of it like, refreshing their knowledge on equipment, treatments, all that stuff.
So it's not just for doctors, this continuing education thing.
No, not at all. But it's more than just the technical stuff too, right?
Mhm.
They need to be trained on how to communicate with patients, with caregivers, like, folks who are dealing with these complex conditions every day.
Right.
It's about listening, understanding their perspective, addressing their concerns. It's all about working together.
That makes sense. It's a whole different way to think about interacting with patients, isn't it?
I think so. And, I think simulation training could be so valuable here. Imagine scenarios where a paramedic has to figure out how to assess a patient who's, on a ventilator, or how to provide care while navigating all these complex devices in a home setting.
It's almost like a real-life test run.
Right. But in a safe environment where they can make mistakes and learn. And it's not just about the technical skills either. It helps develop that critical thinking, the quick decision-making that they need out in the field.
So this all ties into this evolution of the paramedic role, right? It's
Yeah.
not just about rushing people to the hospital anymore. They're becoming a much bigger part of the whole healthcare journey.
Exactly. And it's really cool to see.
I think so too. And you know what? As someone who might need their help someday, it's pretty reassuring to know that they're constantly pushing to improve and adapt.
Definitely. It's a testament to, how dedicated they are, how professional they are. They're truly on the front lines, and they deserve so much respect for the work that they do. Now, I know we've covered a lot, but there's another side to pre-hospital care that I think is really important to talk about.
Okay, what's that?
The ethical stuff. All those dilemmas that paramedics face.
Oh, yeah, good point. It's not always so black and white out there.
Not at all. They're making judgment calls that can have, really serious consequences. We talked about patient refusal, but what about cases where a patient might not even be able to make an informed decision?
Right.
Maybe because of their condition or because they're intoxicated or just super stressed out. How do paramedics handle that that gray area.
That's a big one.
Mm.
What do those medical directives say about that kind of situation?
They emphasize that it's really important to assess if a patient truly has the capacity to make an informed decision.
Okay.
So they have to look at their level of consciousness, their mental state. Can they understand the risks, the benefits of treatment? It's not just yes or no to treatment. It's this whole complex evaluation.
Wow. So there's a lot on their shoulders. It's not just about the medical stuff. It's about advocating for their patients, too.
Absolutely.
Making sure their rights are respected,
Yeah.
even in the tough situations.
Right. And sometimes that advocacy goes beyond just the patient, you know?
What do you mean?
They have to advocate for themselves, too. Make sure they're working within their scope of practice, not putting themselves or the patient at risk.
It's about finding that balance, right?
Right.
Compassionate, but also, maintaining those professional boundaries.
It is. It's a delicate balance, for sure, and something every paramedic has to think about every day.
Their work is really remarkable. And the more we get into these ethical questions, the more I realize that being a paramedic is more than just a job. It's like a calling.
It is. It is. They deal with life and death, making split-second decisions that can change everything. They navigate super complex medical scenarios. It's not for the faint of heart. It takes a special kind of person.
I agree. And it's been incredibly thought-provoking, honestly. I have a whole new level of respect for what they do, the challenges they face every day.
It's a world full of surprises. It's always changing, and it demands so much, intellectually and emotionally. But it's also incredibly rewarding, knowing that you're making a real difference in people's lives.
That's got to be powerful.
Yeah.
Before we wrap up this first part of our deep dive, I want to touch on one more thing that's been on my mind.
Okay.
This whole idea of the emotional toll this work takes on paramedics.
Yeah.
I mean, it can't be easy.
It's not, and you're right, it's often overlooked, but it's so important to acknowledge it. Paramedics are exposed to trauma, suffering, loss
Right.
regularly, and that has to have an impact.
Right. It's like they carry that weight
Right.
even when they're off duty.
It is, and it's hard to just, switch it off. Those experiences build up, and having healthy ways to cope, having good support, that's critical.
So what can be done? Is there like a culture of dealing with this stuff in the field?
There's definitely a growing awareness of how important mental health is for first responders.
Okay.
A lot of organizations are offering peer support programs now, and there's better access to counseling, more emphasis on just talking about it.
That's great to hear. Because it's important, right? Their well-being is crucial to them being able to care for others.
It is. It's like, a cycle of care. They take care of themselves so they can take care of others. It's a cycle that deserves all our support. It really is amazing how much healthcare is changing. I mean, so much complex stuff is happening outside of hospitals these days.
Yeah, no kidding.
We were talking about how tough this job can be emotionally, and I think it's so important to, emphasize that
Yeah.
it's not weak to admit that.
Right, exactly. Recognizing how these experiences affect you, all that trauma, the stress, that's a sign of strength.
It is. It shows self-awareness.
And it means you can actually take care of your mental and emotional health so you can keep helping patients.
Exactly. Like that saying, put your own oxygen mask on first.
Exactly.
It's so true. Getting support, whether it's through those peer programs or therapy or even just talking to someone you trust, it can make a world of difference.
No doubt. Okay, so speaking of tough stuff, we were discussing patients who refuse treatment.
Right.
But what about those situations where a patient can't actually make a clear decision, maybe because of their medical condition, maybe they're intoxicated or just like completely overwhelmed with stress?
Right. Right. It's a gray area. Happens a lot more than you'd think. And the guidelines, they really emphasize how important it is to assess the patient's capacity to make a decision.
So it's more than just a yes or no to treatment.
Oh, yeah. Definitely. Paramedics have to consider all sorts of things like what's their level of consciousness? Are they thinking clearly?
Right.
Can they actually grasp what's going on, What are the risks and benefits of treatment? It's a lot to figure out, and quickly.
Especially in an emergency. Do they ever have to make these judgment calls, like under extreme pressure?
All the time. Imagine you get to a scene and there's a patient with critical injuries, but there's no family around to give consent. Those are the decisions that can change everything.
That's a lot to handle. And then on top of all that, they're dealing with the emotional side of things.
Oh, yeah.
Seeing those traumatic events, dealing with death, the aftermath of accidents.
It stays with you.
It has to.
And it's not easy to just shut it off, when you're off duty.
Right.
it all builds up.
So having those healthy coping mechanisms
Yeah.
and a good support system, so important.
So important.
Speaking of support, I'm curious, what role does teamwork play in all this?
Oh, huge.
I mean, it's got to be essential in such a high-stress environment.
Teamwork is like the most important thing. Paramedics, they almost never work alone.
Right.
They depend on each other, not just for the practical stuff, but emotionally too.
So it's more than just having individual skills. It's about knowing how to function as a team, especially when things get crazy.
Absolutely. You have to communicate. You have to anticipate what your partner needs. You have to trust each other. I mean, their lives depend on it.
Wow.
And the lives of their patients too, of course. That's what that tight-knit teamwork is all about.
That level of trust, it must be incredible.
It is.
Almost like a family.
You got it. It goes beyond just being colleagues. They really do become like family, supporting each other through all the ups and downs.
It's remarkable, to think about how resilient they are, how dedicated they are. Unsung heroes, for sure.
No doubt about it. They deal with challenges most people can't even imagine, and they do it with courage, compassion, with this deep commitment to saving lives.
It's amazing. And it makes all that stuff we were talking about with home health care that much more impressive. What happens when, say, they encounter a piece of equipment they've never seen before?
Yeah.
Do they just have to say, sorry, I can't help?
Not necessarily.
Okay.
Remember, it's all about communication, collaboration, right? So they can talk to the patient, to the caregiver. Those folks usually know their equipment inside and out.
So tap into that firsthand knowledge. I like it. But what if there's, like, a serious malfunction? Can a paramedic even touch the equipment?
That's where it gets, a little blurry. They can only do what they're authorized to do, right? They can't operate a medical device they don't know or give meds they're not trained on.
So it's about assessing the situation, doing what they can to stabilize the patient, and then relying on the people who know the equipment.
Exactly. It's about knowing your limits and working within those limits.
Makes sense. But man, clear communication's got to be key in those moments. It's got to be stressful.
Oh, for sure. Imagine trying to explain your complicated medical situation and how your equipment works, all while you're having a medical emergency.
Yeah, no kidding. That's a lot.
A lot for everyone involved.
So how do paramedics get better at dealing with this stuff, especially with home healthcare technology getting more and more complex all the time?
Well, that's where those local training modules are so important.
Okay.
The more familiar they are with all the different technologies, the medications, the better prepared they'll be.
It's not just about treating that one issue. It's about understanding that person's whole healthcare situation.
Exactly. It's that shift we were discussing earlier.
Right.
From being purely reactive to being more proactive,
Staying informed about all these changes in healthcare.
Yeah.
This has been such an eye-opening conversation.
It has.
It's like we're getting a glimpse into a world that most people don't really think about.
It's true. And the work they do, it's so demanding, both physically and mentally. Yeah. As medicine advances, their role is just going to keep getting more complex, more challenging.
Absolutely.
Yeah.
Before we wrap up this part of our deep dive, I want to touch on one last thing. The emotional weight of this job. How do they deal with all that trauma, all that stress?
Yeah, you're right. It's something that's often overlooked, but it's crucial to acknowledge it. Paramedics, they see some really difficult things, even horrific things on a regular basis. That takes a toll.
Yeah, it's like carrying that weight even when you're off the clock.
It is. And they don't always have time to process it all. It's one call after another. They're always in that crisis mode.
Right. So what can be done? Is there like a culture of addressing this within the profession?
There is a growing awareness, definitely, of how important mental health is for first responders. Lots of organizations are implementing those peer support programs we talked about, providing counseling, encouraging people to talk about it.
That's good to hear.
Yeah, because it's important to recognize that their well-being, it's crucial. It's essential to being able to care for others.
That's like a cycle of care.
It is. It's taking care of yourself so you can take care of others. And that's a cycle that deserves all the support we can give it.
Welcome back. We've been on quite a journey today exploring the world of paramedics.
It really is fascinating, isn't it?
It is. And, it really shows you just how much goes on behind the scenes in emergency medicine. The demands on these folks, the paramedics, it's incredible. They have to think fast, they have to be empathetic, and they got to have this deep understanding of both the science and the human side of healthcare.
It's a unique combination of skills, that's for sure.
And we were just discussing the emotional weight of the job. And I think it's worth repeating. It's not a weakness to acknowledge how tough it can be.
Not at all. Recognizing the impact of these experiences, the trauma, the stress, that shows strength. It shows self-awareness.
It means they can actually prioritize their own well-being, which ultimately makes them better at taking care of their patients, right?
Absolutely. You have to take care of yourself to be able to take care of others.
So true. Okay, so let's talk about some of the specific ethical dilemmas that come up for paramedics. What kind of stuff are we talking about?
Well, we touched on patient refusal of treatment, but think about those situations where a patient might not be able to make a clear decision for themselves. Maybe because of their medical condition, or maybe they're intoxicated, or just in extreme emotional distress.
Right, right.
Paramedics have to make tough calls about what's best for the patient, and sometimes the guidelines aren't clear-cut. It's a judgment call.
That sounds incredibly difficult. Do they ever have to make those calls, like, under intense pressure?
All the time. Imagine you show up at a scene, the patient's critically injured, but there's no family around to give consent. Those split-second decisions, they can be life-changing.
That's heavy stuff. And then on top of all that, they're witnessing all this trauma.
Yeah.
The injuries, death, the aftermath of accidents, violence. How do they even process all of that?
It's not easy. It really does stay with you, those experiences. And having healthy ways to cope, having that support system, it's essential.
We've talked about support systems, and I'm curious, how important is teamwork in all of this? I mean, it seems like it would be essential in such a high-stress field.
Teamwork is everything. Paramedics almost never work alone. They rely on each other so much, not just for the practical stuff, but also for emotional support.
So it's not just about individual skills.
No.
It's about knowing how to function as a unit, especially when things get crazy.
Exactly. Communication, anticipation, trust. It's all crucial. I mean, literally, lives depend on theirs and their patients'. That's what that tight-knit teamwork is all about.
That level of trust, that camaraderie, that must be pretty powerful.
It really is. It goes way beyond being colleagues. You really do become like family, supporting each other through the toughest times.
It's inspiring,
Yeah.
The resilience, the dedication, unsung heroes, for sure.
Absolutely. They face challenges most of us can't even imagine. And they do it with courage, compassion, this unwavering commitment to saving lives.
Okay, so as we wrap up this deep dive,
Yeah.
what's the one thing you want our listeners to take away from all of this?
I hope they remember that behind those flashing lights and sirens, there are real people making incredibly tough decisions under intense pressure, dealing with, the raw emotions of life and death.
Yeah.
They deserve our respect, our gratitude, and our support.
Well said. And to all you listeners out there, if you ever have the chance to thank a paramedic, do it.
They're the ones who run toward danger when everyone else is running away.
Exactly. And remember, those medical dramas on TV, they don't always show you the whole picture.
Right. It's so much more complex and nuanced than that. It's a deeply human profession that deserves our attention and understanding.
It's been a privilege to explore this world with you today.
It has.
And to everyone listening, until next time, keep learning, keep exploring, and stay curious. Welcome back, everyone. Ready for another deep dive.
Always. What are we looking at today?
Today, we're stepping into the world of paramedics.
Oh, wow.
We've got these guidelines, 2023 EO201V5.1 companion document, AUX.PDF. They're the protocols for primary care paramedic auxiliaries.
Interesting.
Yeah, it dictates how they make these, life or death decisions right there in the field.
I can only imagine. With limited information sometimes.
Oh, absolutely. It gets intense. Like even something as simple as IV and fluid therapy, right?
Right.
You think it's just give fluids to someone losing fluids?
Yeah.
But it's way more complex than that. This document, it really highlights that.
It does. One thing that jumped out at me, no IVs on suspected fractures.
Really?
Yeah, it seems counterintuitive, but
I would think so.
it's all about preventing more damage to the blood vessels. They could already be compromised near the break.
That makes sense.
Yeah.
Then there's this formula for kids. It's to calculate hypotension. SBP equals 70 plus 2 times their age.
Why does age even play a role in blood pressure readings?
Well, a child's cardiovascular system is still developing, you see. So as they get older, the blood vessels become larger and stronger, really. That naturally leads to higher blood pressure as they grow.
Oh, okay.
So that formula, it helps paramedics figure out if a child's blood pressure is too low for their age, which, well, that's a sign that something could be seriously wrong.
So context matters. It's not just about the reading itself.
Exactly.
And then they have this 2 blood pressure rule. You need 2 separate readings showing hypotension before you can start a fluid bolus.
Yes.
What's the reasoning there?
Accuracy is key in these situations. A single low reading could be a fluke. The child's position, anxiety, things like that.
Right, right.
But if you get 2 low readings in a row, that's a red flag. It means something could be seriously wrong.
That makes sense. Now, I have to ask, and forgive me if this is a silly question.
No such thing.
What exactly is a fluid bolus? Oh, sure. It's basically like a rapid injection of fluids, usually saline solution, right into the vein.
Okay.
It's used to quickly increase blood volume, which can be really, really important in cases of severe dehydration or blood loss.
So like a real emergency measure.
Exactly. You want to be absolutely sure before you do something like that, especially with what the document says about cardiogenic shock.
Oh yeah, that's a serious one.
It is. Cardiogenic shock happens when the heart can't pump enough blood for the body. It's critical. And unlike other situations where you might give fluids for low blood pressure, here you have to be really careful.
So giving fluids could actually make things worse.
It could. You see, the heart is like a pump, and in cardiogenic shock, that pump is weak.
Okay.
Adding more fluid to the system is like trying to make that weak pump work even harder.
Oh, I see.
It could overload it and make the problem worse.
So the focus is on supporting the heart itself, not just adding more fluid.
Exactly. Treat the cause, not just the symptom.
That's fascinating. And this document also talked about CPAP, continuous positive airway pressure.
Yes, CPAP, a very versatile tool. Helps patients breathe easier when they're in severe respiratory distress.
Now, here's where I get a little confused.
Okay.
They use CPAP for lung problems like COPD, right?
Mm-hmm.
But also for heart problems like pulmonary edema.
Right.
How can the same tool be used for such different issues?
Well, it all comes down to improving gas exchange in the lungs.
Okay.
Whether the problem is with the lungs themselves or the heart, if your lungs aren't getting enough oxygen into the bloodstream and removing carbon dioxide, the body starts to suffer.
Gotcha.
So CPAP kind of bypasses that problem, regardless of the cause, by forcing air into the lungs and helping that gas exchange happen better.
So it's like a workaround almost.
You could say that. And that versatility is something you see throughout these guidelines, especially when they're dealing with large-scale emergencies, things like public health crises.
You're talking about those protocols for potential COVID-19 patients?
Yes, exactly.
That whole section was really eye-opening.
It is, isn't it?
It's like a window into what it's like to make these crucial decisions when everything is stretched thin.
It is. Imagine you're a paramedic and you're facing a potential COVID patient. Hospitals are overrun, resources are limited, and you have to decide right there if this person needs to go to the hospital or if they can recover at home.
Wow. That's a lot of pressure.
It is. The document outlines a process, assess the patient, but even then, it's not always a clear-cut answer.
Right.
The paramedic has to call a base hospital physician,
Mm-hmm.
and it's not just a quick, hey, what do you think? They have to give a detailed report. The patient's age, COVID screening results, their travel history, symptoms, vital signs, everything.
So even in a pandemic, direct communication with a physician is essential.
It is. Absolutely. And even if the physician says, okay, they can be released, the paramedic's job isn't done.
Really?
They still have to make sure the patient understands what's going on and how to manage their care at home.
It's like they become a temporary home healthcare provider on top of everything else.
Yes, in a way. They need to be sure the patient can self-isolate, that they have someone to help them if they need it, that they know how to monitor their symptoms, and that they know how to get help if things get worse.
It's amazing. Being a paramedic is about so much more than just stabilizing and transporting patients.
It is. It's about educating them, empowering them, making sure they have the tools to manage their own health, even in a crisis.
Wow. And all of that ties right back to that ideal mnemonic we discussed earlier.
It does.
That educate step. It's all about giving the patient the information they need to make good decisions about their own care.
Absolutely. And listen, too. That's so important, especially when you're making a decision to treat and discharge.
It's so simple, but so crucial. Really taking the time to hear the patient's concerns makes a huge difference. It builds trust.
It does. There's one line in the document about this that really stood out to me. It says, a signature is not required to release a patient from care. However, and this is the important part, ensure that thorough documentation includes all discussions had with the patient.
Interesting. What do you think that means?
To me, it means treating and discharging a patient isn't just about checking boxes. It's about having a real conversation, understanding their concerns, and making them feel heard.
Even in an emergency situation, patient-centered care is still at the heart of what paramedics do.
Exactly. And it's important to remember, treat and discharge is different from a patient refusing care.
Oh, right, of course.
Those are two very different situations, ethically, legally, all of that.
So a patient can always refuse care, but they also have a responsibility to understand the risks of doing so.
Right. And the paramedic's job is to give them that information, answer their questions, and ultimately respect their decision, even if they disagree with it.
But in a treat and discharge situation, the paramedic is the one making the judgment call.
They are, based on their assessment, the guidelines, and after talking with a physician.
It's a big responsibility.
It is. That's why documentation is so important. It protects both the patient and the paramedic. There's a clear record of everything that happened.
Like a paper trail.
Exactly. Okay, ready to shift gears a bit?
Sure. What's next?
Let's talk about those special event directives.
Oh, yeah, those seem pretty interesting.
They are. Paramedics have to be even more flexible in those situations. I mean, think about it. They could be dealing with anything from a scraped knee at a marathon to a mass casualty event at a concert.
Yeah, that's a huge range.
It is. And those specific directives, they help guide them through those unique situations.
For example, the directive for minor abrasions. It gives some flexibility with the type of topical antibiotic used.
Right. Why do you think that is?
Well, I guess different antibiotics work better on different types of bacteria.
Exactly. The paramedic might choose a particular antibiotic depending on the wound, where it is, and how likely it is to be infected.
So even seemingly simple cases, there's still that need for critical thinking.
Absolutely. And you see that need for judgment over and over again in these directives. Take the one for minor allergic reactions, for instance.
Oh, yeah. What even counts as minor is pretty subjective.
It is. That's where a paramedic's experience and training really come into play.
They have to assess how bad the reaction is, consider the patient's history, their meds, and then decide if they can handle it right there or if they need to go to the hospital.
Exactly. And then there's the directive for musculoskeletal pain and headaches. They can give acetaminophen,
Right.
but only if the patient hasn't taken any recently. There's a time restriction
Why is that?
to prevent accidental overdose. Acetaminophen is safe when you take it as directed, but too much can be harmful to your liver.
Oh, wow. I didn't know that.
Yeah. So that time restriction makes sure the patient isn't taking more than they should in a day.
Another example of how these guidelines are all about patient safety, even in the smaller things.
They are. It's pretty incredible how much we can learn about what it's really like to be a paramedic just by looking at these guidelines.
It's like peeling back the layers of an onion, you know?
Ah,
There's always more to discover.
I love that analogy. And you know what? We've only just scratched the surface. There's still so much more to uncover in these guidelines.
I know, it's exciting.
But before we dive into all that, I want to ask you, our listeners, a question. Think about everything we've talked about today. The rules, the need for flexibility, the ethics, the communication, all of it. What do you think are some of the biggest challenges paramedics face? Especially when they're trying to balance all those things and still provide the best possible care.
It's a great question, and one I hope our listeners will really consider. Thinking back to those ethical considerations, that section on assessment of patients with possible COVID-19 was really something.
It was, wasn't it? Like a snapshot of decision-making under pressure.
Yeah. When resources are limited, every choice matters.
Right. Imagine you're that paramedic, right?
I can't either.
Facing a potential COVID patient, hospitals overflowing, limited resources, and you got to decide right then and there, transport or not.
That's a tough call.
It is.
The document, it does lay out a clear process. Assess the patient based on those release from care criteria. But even then, it doesn't seem like a simple yes or no.
No. The paramedic, they have to call a base hospital physician. And it's not just a quick check-in.
Oh, really?
It's a whole report. Patient's age, COVID screening, travel history, symptoms, vitals, everything.
Wow. So that communication with a physician is still crucial, even in a pandemic.
Absolutely. And even if the physician clears them for release, the paramedic's work isn't over.
There's more.
Yeah. They have to make sure the patient understands their situation, how to manage their care at home.
So on top of everything else, they become like a temporary home health care provider.
In a way, yes. Confirming self-isolation, caregivers, symptom monitoring, and how to call for help if things take a turn.
It's a whole other level of care that I think most people don't even realize.
You're right. It shows that being a paramedic, it's so much more than just stabilizing and transporting.
Yeah. It's education, empowerment, giving patients the tools to navigate their own health,
Yeah,
even in a crisis.
exactly. And it all circles back to that ideal mnemonic,
Oh, right.
that educate step.
Yeah.
It's all about making sure the patient has the information they need to make good decisions.
And listen is equally important, especially with treat and discharge. Taking the time to hear what the patient is saying can make a world of difference.
It really can. It builds trust. Now, there was one line in the document that really got me thinking about this. It says, a signature is not required for release, but, and this is key, thorough documentation should include all discussions with the patient.
Huh. That's interesting. What do you make of that?
Well, it tells me treat and discharge isn't just checking boxes on a form.
Yeah.
It's about a real conversation, understanding the patient's perspective, making sure they feel heard.
So even in an emergency, even during a pandemic, it's still about patient-centered care.
Exactly. And it's important to remember that's different from a patient refusing care.
Oh, right, right. Two totally different things.
Different situations, ethically, legally, everything. A patient can always refuse care.
But they also have to understand what that might mean, right? The potential consequences.
Absolutely. And the paramedic has to provide that information, answer questions, and in the end, respect the patient's decision, even if they don't agree with it.
But in a treat and discharge situation, the paramedic is the one making that professional judgment.
They are, based on the assessment, the guidelines, and talking with a physician.
It's a big decision.
It is. That's why good documentation is so critical. It protects everyone involved, creates a clear record of what happened.
Okay, so we've talked about those ethical considerations, communication.
Yeah.
Are we ready to move on to something a bit different?
Sure. How about those special event directives?
Yeah. Paramedics have to be extra adaptable in those scenarios, don't they?
They do. I mean, think about the range of situations.
It's pretty wild, right?
A minor abrasion at a marathon, a mass casualty at a concert. It's a whole different ballgame.
And those special directives, they give them guidance for those unique events.
Exactly. Take the directive for minor abrasions, for instance. It actually gives them some flexibility with the topical antibiotic they use.
Interesting. Why do you think that is?
Well, different antibiotics work better against different bacteria, right?
Okay, yeah.
So the choice might depend on the type of wound, the location, the risk of infection, a lot of factors.
So even with something as simple as a scrape, there's still room for critical thinking.
There is. And that need for judgment, it keeps coming up in these directives, like the one for minor allergic reaction.
Yeah, minor. That's pretty subjective.
It is. It really highlights the importance of experience and training for paramedics.
They have to assess how serious the reaction is, the patient's history, their medications, and then decide, can they handle it in the field, or does this person need to go to the hospital?
Exactly. And then you have the directive for musculoskeletal pain and headaches, which allows for acetaminophen. But there's a catch. No acetaminophen if the patient has taken any recently.
Oh, why is that?
It's all about preventing accidental overdose. Acetaminophen is safe if you use it correctly, but too much can damage the liver.
Really? I had no idea.
So that time restriction, it's there to make sure the patient isn't taking more than they should in a day.
Another layer of patient safety. It's impressive.
It is. These guidelines, they really show how much attention to detail is expected of paramedics.
No matter what they're dealing with.
Exactly. It's incredible how much we can learn about the world of pre-hospital care just by dissecting these guidelines.
It really is like peeling back the layers of an onion. There's always something new to discover.
Love that analogy. And we're not done yet. There's still so much more to uncover.
So much more to explore.
But before we dive back in, I want to leave you, our listeners, with something to think about.
Ooh, a cliffhanger. Yeah. I like it.
We've talked about the rules, the need for flexibility, the ethics, communication, everything. So my question to you is, what are some of the biggest challenges you think paramedics face in trying to balance all of that while still providing the best possible care in the field?
It's a great question, and one I hope you'll really think about as we continue this deep dive. It's amazing, isn't it, this constant back and forth between having these set protocols and needing to be flexible.
It is. It's a delicate balance. On the one hand, you have these guidelines, right, to make sure things are done consistently and to reduce errors.
Right, like that 2 blood pressure rule. Takes the guesswork out of it.
Exactly. But on the other hand, paramedics can't be robots just following a script. They need to be able to think on their feet.
Yeah, because every patient's different. Every situation's unique.
Exactly. Sometimes a textbook answer, it just doesn't apply.
And that's where the real skill comes in. That's the art of paramedicine.
It is. It's not just knowing the protocols, it's knowing when to apply them and when you might need to do something different.
To think outside the box.
Yes. That ability to think critically, to assess a situation and make a judgment call, even when you don't have all the information. That's what makes a great paramedic.
It's a combination of knowledge, experience, and just gut instinct.
It is. And that's why ongoing training is so important in this field.
Oh, absolutely.
It's not enough to just learn the protocols once. You have to
Yeah.
keep learning, keep up with the research, and really think about your own practices.
It's a commitment to lifelong learning, to always striving to provide the best possible care.
It is. And, going through these protocols, it really highlights how much knowledge paramedics need to have.
It's remarkable. I mean, they have to understand complex medical conditions, administer medications and treatments,
Yeah.
communicate effectively with patients and their families,
Yeah.
all under pressure.
It's a lot. And, I think it's a profession that often gets overlooked.
Yeah, I agree.
People think of them as just ambulance drivers, but they're so much more than that. They're highly skilled medical professionals, often the first ones on the scene in an emergency.
They save lives every day.
They do. And they do it with incredible courage and compassion, often under incredibly difficult circumstances.
Yeah, they deal with trauma, illness, emotional distress, the unpredictable, long hours, risks to their own safety.
It's a job that demands a lot, not just intelligence and skill, but resilience, empathy, and a real dedication to helping others.
Absolutely. And, as we've been going through these protocols, one thing that has really stood out to me is that focus on patient-centered care.
Oh, it's everywhere, isn't it?
Yes, from the ideal mnemonic to the emphasis on communication, informed consent, respecting patient autonomy.
Even in those high-pressure moments, when every second counts, paramedics are trained to treat patients with dignity and respect.
To involve them in decisions whenever possible, and to make sure their voices are heard.
Exactly. It's a good reminder that healthcare isn't just about following rules or achieving outcomes.
It's about caring for people, treating them with compassion and empathy, recognizing their value and dignity.
Couldn't have said it better myself. And that's something we can all take away from this no matter what we do. We can all try to bring that same level of care and compassion to our interactions with others.
Absolutely. So, as we wrap up this deep dive into the world of paramedics, I want to leave you with one final thought.
All right, lay it on me.
We've seen how complex their work is, the challenges they face, and the incredible commitment they bring to their profession. So what can we do as individuals, as a society, to better support our paramedics?
That's the question, isn't it? How can we make sure they have the resources, the recognition, the respect they deserve? Their work is essential, often thankless, and always demanding. It's up to all of us to acknowledge their contributions, advocate for their well-being, and make sure they have what they need to continue saving lives.
Beautifully said. Thanks for joining us on this deep dive into the world of pre-hospital care. Until next time, stay curious and keep exploring.
Welcome back, everybody, for another deep dive. This time, we're really going behind the scenes. Behind the scenes of emergency medicine. We see paramedics rushing to the rescue all the time. But have you ever wondered what's guiding their actions in those critical moments?
Absolutely.
Well, we're about to find out. We're going to be exploring the latest medical directives for primary care paramedics. Kind of think of it as their playbook for handling emergencies.
It's like we get to see how these highly trained professionals think. You know what I mean?
Yeah.
These directors go way beyond just telling them what to do.
Yeah.
They actually explain the why
Yeah.
behind those actions, which is super crucial when you're dealing with life or death situation.
Absolutely. And the more I looked into these directives, the more I realized just how much has actually changed even in the past few years.
Oh, for sure.
So let's just jump right in. Let's start with cardiac arrest. Probably one of the most intense scenarios a paramedic can face.
Absolutely. The first thing that really stood out to me was the clear distinction between medical and trauma cardiac arrest.
Yeah.
They both require a slightly different approach, but they both emphasize early defibrillation and continuous compressions, those high-quality compressions.
Yeah, they even talk about minimizing those interruptions during the charge cycle. I never really realized, how every second counts in those situations.
Oh, yeah. It's all about maximizing the chances of getting that normal heart rhythm back.
Right.
So that means we want to minimize any delays in delivering those shocks. And speaking of time, the directives outline this thing called a 20-minute mandatory patch point.
Mm.
It's kind of like a built-in checkpoint where the paramedics on scene connect with the base hospital to reassess the situation and get further guidance.
Makes a lot of sense to have that kind of structured communication, yeah, especially in such a high pressure situation. But what happens if, like, the patient starts showing signs of improvement before that 20-minute mark?
Well, that's where the concept of early transport comes in.
Okay.
The directives actually outline specific situations where it might be more beneficial to get the patient to the hospital as soon as possible, even if the full 20 minutes hasn't quite elapsed.
Right.
For instance, if the arrest was caused by something that's reversible, like severe blood loss or maybe like a collapsed lung,
Yeah.
getting to a hospital quickly could make all the difference.
So it's really a balancing act
Yeah.
between providing that immediate care right there on the scene and then getting the patient to a higher level of care, as fast as possible.
Yeah, for sure.
Now, another thing that kind of surprised me was the shift in priority when it comes to airway management.
Oh, yeah, you're right.
I always thought that was like the top priority in cardiac arrest, but I guess those 2015 AHA guidelines really changed that.
Yeah, they kind of shifted that focus. I mean, ensuring a clear airway is obviously still important, but that initial emphasis is really on those high-quality compressions and defibrillation.
Wow. It's fascinating how those priorities have evolved based on the latest research. Speaking of fascinating, let's move on to something that's both heartwarming and, a bit nerve-wracking.
Oh, yeah.
Newborn resuscitation.
It's amazing how paramedics are trained to handle such a diverse range of situations. Thankfully, only a small percentage of newborns actually require extensive resuscitation.
Right.
We're talking about 1%.
Wow.
But when they do, knowing exactly what to do is absolutely crucial.
Yeah, and the directives use this handy acronym, MR-SOPA, to kind of guide paramedics through those assessment and intervention steps. I mean, it covers everything from simple measures like adjusting the mask, repositioning the airway, to more advanced techniques like suctioning and even considering alternative airways.
It's a great example of how these directives try to make these complex procedures as clear and actionable as possible.
Right.
Even those like really, really stressful moments. But one thing that has changed is that routine suctioning of meconium, that sticky substance sometimes present at birth, is no longer necessary.
Oh, that's right. I remember reading about that. What prompted that change?
Well, research showed that routine suctioning wasn't really all that beneficial and could even cause some complications.
Oh, wow.
It highlights how important evidence-based medicine is and how these directives are constantly being updated to reflect those findings.
It's reassuring to know that those guidelines are based on the best available evidence. Now, let's say we have a positive outcome.
Okay.
The patient's heart starts beating again on its own. What happens then?
Well, that's where the ROSC directive kicks in. It's all about maintaining those oxygen levels within a specific range.
Okay.
Between 94% and 98%. Might seem a little counterintuitive, but aiming for 100% saturation isn't always the best approach.
I guess too much oxygen can actually be harmful in certain situations.
Exactly. It's all about finding that delicate balance.
Right.
And another key aspect of the ROSC directive is this thing called monitoring EtCO2 levels. It basically tells us how well the patient is breathing off carbon dioxide.
Oh.
This helps make sure that the patient is neither hyperventilating nor hypoventilating.
It's incredible how many factors paramedics need to consider even after that immediate crisis has passed.
Oh, yeah.
And they also have to decide whether or not to give fluids.
Yes. The directives are very specific about fluid therapy, recommending it only under certain conditions. Like if the patient's chest sounds are clear and there's concern about low blood pressure,
Right.
the goal is to support circulation without overloading the heart.
It's like a carefully choreographed dance, making sure each step is taken at the right time, in the right sequence.
Yeah.
Now let's shift gears to something a bit more specific. Cardiac ischemia and acute cardiogenic pulmonary edema.
Okay.
These conditions can be really serious, right?
They certainly can be, and the directives have undergone a pretty significant change in this area.
Okay.
The emphasis is now on acquiring a 12-lead ECG before even considering nitroglycerin.
So they're really prioritizing getting a clear picture of what's happening in the heart before administering any medication.
Precisely. The ECG helps determine if the patient is experiencing a STEMA, a particular type of heart attack, which can drastically impact treatment decisions. And they specifically call out the importance of manual interpretation over computer-generated readings.
So it's not just about relying on technology, but also using those critical thinking skills to really interpret the data.
Absolutely. Technology is a powerful tool,
Right.
but it's the paramedics' expertise that ultimately guides the best course of action. And speaking of specific details, the directives even highlight the importance of V4R lead placement in cases of inferior STEMI.
I have to admit, I'm not familiar with that term. What's the significance of that particular lead?
Well, it helps rule out a right ventricular infarction, which can significantly affect how a patient responds to nitroglycerin. It's like a puzzle, where each piece of information, even a specific ECG lid, can change the entire picture.
So it's all about gathering as much information as possible to make the most informed decisions. Now, I'm curious about nitroglycerin itself. The directives seem to be quite cautious about its use.
And there's good reason for that. While nitroglycerin is effective for relieving chest pain, it doesn't actually impact long-term outcomes like morbidity or mortality.
And there are very specific rules about when it can be given to someone suspected of having cardiac ischemia for the first time.
Exactly, and one of those rules
Right.
is that the patient must have an established IV line. This ensures a route for rapid intervention if needed.
Yeah.
Minimizes the risk of complications.
So it's all about maximizing benefit while minimizing risk.
Yeah.
Now let's move on to another common medical emergency. Hypoglycemia, or low blood sugar.
Okay.
This is where the directives get very practical, focusing on proper blood sampling techniques. They emphasize that paramedics should only draw blood from approved sites like the fingertips or the heel of the foot for infants who haven't started walking.
Right.
And they specifically state that drawing blood from an IV catheter is a no-go. Why is that?
It's simply not safe or accurate.
Okay.
The blood in an IV catheter can be diluted or contaminated,
Right.
leading to inaccurate readings and potentially inappropriate treatment.
That makes sense. And once they've confirmed hypoglycemia, what options do paramedics have for treatment?
Well, they now have the choice of using either D10W or D50W,
Okay.
two different concentrations of dextrose solution depending on the severity of the hypoglycemia and the patient's overall condition.
And they stress the importance of administering that dextrose gradually to avoid overshooting and causing the blood sugar to spike too high.
Right. It's about finding that sweet spot, so to speak,
No,
to bring the blood sugar levels back to normal without creating new problems. The directives also address situations where a patient might have already received glucagon, a hormone that raises blood sugar.
Right.
If they're still hypoglycemic, paramedics can administer dextrose regardless of the elapsed time since the glucagon was given.
So it's not a one-size-fits-all approach. They really emphasize that flexibility and adapting to the individual patient's needs. And for conscious patients who can safely swallow, they even introduced the 15-15 rule for treating hypoglycemia.
Oh yeah, that's a good one. It's a simple but effective method. It really empowers patients to manage their own condition.
Yeah.
They consume 15 grams of simple carbs, like glucose tabs or juice, and then check their blood sugar again after 15 minutes.
Okay.
If it's still low, they can just repeat the process.
I love that it gives patients some control over their own care. Now let's shift gears to a condition that affects the respiratory system.
Okay.
Bronchoconstriction.
This is a pretty broad directive that encompasses a wide range of conditions, from asthma and COPD to other causes of airway narrowing.
And in severe cases, they actually recommend administering epinephrine intramuscularly, even before trying salbutamol.
Yeah.
The typical first-line treatment for bronchospasm.
That's because in a life-threatening situation, the priority is to open up that airway as quickly as possible.
Okay.
And in those cases, epinephrine can be more effective than salbutamol.
So it's about choosing the most appropriate treatment based on the severity of the situation, not just following a rigid protocol. And they also highlight the preference for using a metered dose inhaler, or MDI, to administer that salbutamol over nebulization.
Right. There's a couple of reasons for that. Firstly, MDI administration is generally faster and more efficient,
Okay.
allowing for quicker relief.
Makes sense.
Secondly, it minimizes the risk of spreading contagious particles through the air,
Right.
which is especially important in certain environments.
Absolutely. And here's a little detail I found interesting.
Okay.
MDI and spacer devices are now considered single-patient use.
Absolutely. Infection control is a top priority in healthcare, and this change really helps reduce the risk of spreading germs.
Now, another important medication mentioned in that bronchoconstriction directive is dexamethasone.
Mm-hmm.
Isn't that a steroid?
It is.
Okay.
And while steroids are often associated with long-term treatment,
Right.
in this context, dexamethasone can actually be given orally for short-term relief of bronchospasm.
So it's not just for those severe cases.
That's right. And what's really interesting is that they include dexamethasone in the COPD protocol, even for patients who haven't been formally diagnosed with the condition.
How do they make that determination?
It's based on smoking history.
Okay.
Given the high prevalence of undiagnosed COPD among smokers, the directives recommend considering dexamethasone as a potential benefit, even if a formal diagnosis hasn't been made.
That's a great example of how these directives take into account those real-world scenarios and the challenges that paramedics face in making decisions with limited information.
Yeah.
Now, I'm curious about moderate to severe allergic reactions.
This directive is all about recognizing and responding to the full spectrum of allergic reactions, from mild itching and hives to life-threatening anaphylaxis.
And they really emphasize the urgency of administering epinephrine in cases of anaphylaxis.
Absolutely. Delays in epinephrine administration are directly linked to higher mortality rates.
Right.
It's a life-saving intervention that cannot be delayed.
They also address a common misconception
Okay.
that skin findings are always present in anaphylaxis.
That's a crucial point. Anaphylaxis can manifest in many different ways, and paramedics are trained to assess all body systems,
Right.
not just rely on visible signs like hives or swelling.
Right. And they even provide a really helpful table that differentiates those localized reactions from true anaphylaxis.
That's a really valuable tool for paramedics to quickly assess the situation and make informed decisions about treatment.
Well, we've covered a lot of ground in just this first part of our deep dive, but there's still so much more to explore in these directives.
Absolutely. We've only just scratched the surface of the vast knowledge and expertise that paramedics bring to the table.
I'm already eager to see what other insights we uncover in part 2.
Me too. Welcome back. I'm excited to kind of delve deeper into some of these more, specialized directives.
Me too. These directives seem to cover just about every situation imaginable. Where do we go next?
Well, let's look at croup. It's a respiratory condition that often affects young children.
Oh yeah, I remember having croup as a kid. That Birkin cough is pretty distinctive.
It certainly is. And while it is more common in children, the directives actually point out that croup can affect adults too.
Really?
Yeah.
I had no idea adults could even get croup.
Yeah, it's becoming more and more recognized in older patients. And what's interesting is that for severe cases, they recommend using nebulized epinephrine to help open up the airways.
Huh. Isn't epinephrine usually given as an injection?
It can be, but in this case, delivering it as a mist directly into the airways can be very effective. The directives also mention, trying moist or cold air if available as a way to kind of ease the symptoms.
So sometimes those simple home remedies can actually make a difference.
Yeah.
Now what about pain management? I'm sure paramedics encounter a lot of patients in pain.
Absolutely. And the analgesia directive is all about providing relief while minimizing risks. They strongly emphasize non-opioid options whenever possible.
So acetaminophen and ibuprofen are at the top of the list.
Exactly. They're considered first-line treatments, especially for patients who can take oral medication. And whenever possible, they recommend combining the two for better pain control.
Makes sense. They also mentioned ketorolac as an option. What's the advantage of using that one?
Well, ketorolac is another type of pain reliever, and like ibuprofen, it belongs to a class of drugs called NSAIDs. It's often given intravenously,
Okay.
which can be beneficial for patients who are vomiting or unable to take medication by mouth.
So it kind of bypasses the stomach altogether.
Yeah.
That's helpful in those situations. Now let's talk about a really serious issue that paramedics often encounter.
Okay.
Opioid toxicity.
It's a major concern these days, and the directives are very clear about the priorities in these situations. Airway management is absolutely paramount. Naloxone, the medication that reverses the effects of opioids, is obviously the key intervention.
But it's not just about waking the person up, right?
No, the primary goal is to restore their breathing. Opioid overdose causes respiratory depression, which can be fatal if not addressed quickly. They've also updated the age limit for naloxone administration.
Oh, okay.
It can now be given to patients who are 24 hours old or older.
Why was that change made?
Previously, there was concern about giving naloxone to newborns because it could trigger severe withdrawal symptoms. But research has shown that the benefits of reversing the overdose outweigh the risks of withdrawal in most cases.
So it's a risk-benefit analysis like with so many things in medicine.
Right.
And even after giving naloxone, the patient still needs to go to the hospital, right?
Absolutely. Naloxone is shorter acting than many opioids.
Okay.
So there's a risk that the overdose symptoms could return. Plus, there's always the possibility of other drugs being involved.
Yeah, it's a good reminder that things are not always as straightforward as they seem. Now, this next directive is one I hadn't even thought about.
Oh, yeah?
Home dialysis emergency disconnect.
It's a very specific situation,
Wow.
but one that paramedics need to be prepared for. Imagine encountering a patient who's having a medical emergency while connected to their home dialysis machine.
Yeah, I can see how that would be a challenge. What do the directives say about handling that?
Well, the key is to disconnect the patient safely and quickly
Okay.
without causing further harm. Ideally, there's a disconnect kit included with the dialysis machine that makes this process fairly straightforward. But if that kit isn't available, the directives outline a specific clamping procedure
Okay.
to prevent bleeding and other complications.
It's amazing how these directives anticipate such a wide range of scenarios, even ones that are relatively rare.
Yeah.
Now, speaking of rare, what about suspected adrenal crisis?
This is a condition where the adrenal glands, which produce essential hormones, aren't functioning properly. It can be life-threatening if not treated promptly.
So what's the paramedics' role in this situation?
Well, the directives allow them to administer hydrocortisone,
Okay.
a synthetic form of cortisol, if the patient has their own medication on hand and meets specific criteria.
It's like bridging the gap until the patient can get to the hospital for more definitive care.
Exactly. Now let's move on to a situation that's always a bit exciting and potentially challenging. Emergency childbirth.
This is one where I imagine those cool heads under pressure are absolutely essential.
You're right. The directives emphasize that paramedics are not authorized to perform internal vaginal exams,
Okay.
but they do need to be able to assess the situation and determine if birth is imminent.
So what are some of the signs they're looking for?
They're trained to recognize the frequency and intensity of contractions,
Right.
the mother's urge to push,
Okay.
and whether the baby's head or other presenting part is visible.
And I'm sure they're prepared for complications like shoulder dystocia, where the baby's shoulder gets stuck.
Absolutely. The directives outline specific maneuvers, like the McRoberts and Gaskin maneuvers, which are designed to help dislodge the baby's shoulder and facilitate delivery.
And what about breech deliveries, where the baby is feet first?
For breech deliveries, they advocate for a hands-off approach until the baby's umbilicus is reached. This minimizes interventions that could potentially harm the baby while still providing necessary support to the mother.
Yeah, I can see why that would be so important. And once the baby's delivered, there's still the umbilical cord to manage.
Right. The directives recommend clamping and cutting the cord only after pulsations have ceased,
Okay.
unless there are other factors like multiple births or the need for resuscitation.
It's all about ensuring a safe and smooth transition for both the mother and baby. But sometimes things don't go perfectly smoothly,
Right.
and there can be excessive bleeding after delivery.
That's where external uterine massage comes in.
Okay.
It's a technique used to help control postpartum hemorrhage.
And they emphasize that it needs to be done with firm pressure, which I imagine can be uncomfortable for the mother.
It can be,
Mm.
but it's crucial for stopping the bleeding and preventing potentially life-threatening complications. They also mention oxytocin, a medication that can be given to help the uterus contract and reduce bleeding.
It's amazing how much paramedics are trained to do in such a wide range of situations.
Yes.
What other procedures are covered in these directives?
Let's look at the directive for endotracheal and tracheostomy suctioning and reinsertion.
Those sound pretty technical. What's the main focus there?
Well, it's about maintaining a clear airway in patients who need help breathing
Okay.
and have either an endotracheal tube or a tracheostomy tube in place.
So these are patients who can't breathe on their own.
Exactly.
Okay.
The directives outline techniques for suctioning out secretions to prevent blockages and ensure proper airflow. They emphasize not suctioning too frequently or with excessive pressure,
Right.
as that can cause trauma to the delicate tissues of the airway.
It's a delicate balance between keeping the airway clear and avoiding further harm. And they also cover what to do if the tracheostomy tube accidentally comes out.
That's a critical situation,
Mm-hmm.
and the directives provide step-by-step instructions for reinserting the tube or managing the airway until more advanced help arrives.
It's a good reminder that even though these procedures are common, they still carry risks. And paramedics need to be prepared for anything. Now let's talk about another airway-related directive, the Supraglottic Airway Medical Directive.
A supraglottic airway is a device that sits above the vocal cords, helping to maintain an open airway without going as deep as an endotracheal tube.
So it's like a less invasive way to assist someone's breathing.
That's right. The directives outline specific situations where a supraglottic airway would be appropriate, as well as situations where it should not be used. And they stress the importance of confirming correct placement.
Oh, they do that.
The gold standard is using capnography, which measures carbon dioxide levels in the exhaled breath.
Okay.
But if that's not available, they recommend using at least 2 other methods to verify placement.
Right.
It's all about making sure the device is working properly and the patient is getting enough oxygen.
Now let's shift gears to something a bit more common.
Okay.
Nausea and vomiting.
Oh, I can't imagine there are too many ambulance rides where that doesn't come up at some point. You're probably right. The directives emphasize that not all cases of nausea and vomiting require treatment.
Right.
Sometimes this is just a matter of letting things run their course. But if treatment is necessary, they outline 2 main options: dimenhydrinate and ondansetron.
I've heard of dimenhydrinate. Isn't that used for motion sickness?
It is, but can also be used for other causes of nausea and vomiting.
And what about ondansetron?
Ondansetron is often preferred for nausea and vomiting related to certain medications like chemotherapy.
Okay.
It works in a different way than dimenhydrinate.
So paramedics can choose the medication based on the suspected cause of the nausea and vomiting.
Exactly. And of course, they're always mindful of any contraindications or potential side effects.
Right.
Now let's wrap up this part of our deep dive with a look at procedural sedation.
Procedural sedation, what is that exactly?
Well, it's basically using medication to help patients relax
Okay.
and tolerate uncomfortable or painful procedures, like setting a broken bone or stitching up a wound.
So it's kind of like twilight sleep?
It's similar, but procedural sedation is usually lighter,
Okay.
allowing the patient to remain conscious and responsive while still being comfortable. The directives outline the medications that can be used, as well as the monitoring requirements to ensure patient safety.
I can see how that would be crucial, especially in an emergency setting.
Absolutely. Even though these procedures are common, they still carry risks, and paramedics need to be prepared to manage any complications that might arise.
Well, we've covered a lot of ground in this second part of our deep dive. I'm amazed by the breadth of knowledge and skills that paramedics possess.
Me too. It's truly remarkable how they're able to handle such a diverse range of situations.
I'm already looking forward to uncovering more insights in the final part of our deep dive. And we're back for the final part of our deep dive into the world of paramedic practice. It's been quite a journey.
It really has. From cardiac arrest to childbirth,
I know.
the complexity of these directives is pretty impressive.
Speaking of complexity, I'm curious how they've adapted to the whole, COVID-19 pandemic.
That's a good question. There's a specific directive dedicated to the assessment of patients with possible COVID-19, and it really highlights the importance of protecting both the paramedics and the patients.
So all about PPE, right? All those protocols we've all become so familiar with.
Exactly. Wearing the right PPE like masks, gloves, gowns
Yeah.
to minimize that risk of transmission. But it goes beyond just PPE.
Right.
The directives also guide paramedics in assessing patients for, potential COVID-19 symptoms and determining what level of care is actually required.
So it's like a triage system, figuring out who needs to go to the hospital like right away versus who can maybe recover safely at home.
Precisely. And they also stress the importance of communicating with the receiving hospitals,
Right.
providing them with all the necessary information about the patient's condition and potential exposure to COVID-19.
It's a good reminder that even as the pandemic has evolved, those protocols are still super important for protecting public health. Now let's shift gears to something a bit less intense. Situations where a patient might not need a full ambulance transport,
Right.
but still requires some level of medical attention.
That's where the treat and discharge directives come in. They cover a whole range of minor conditions that paramedics can manage on scene, allowing patients to avoid unnecessary trips to the hospital.
So we're talking about like everyday bumps and bruises, sniffles that don't necessarily warrant a full-blown emergency response.
Exactly. Things like minor abrasions, mild allergic reactions, musculoskeletal pain headaches, that sort of thing. But even for these seemingly minor issues, the directives outline clear assessment and treatment protocols.
It's all about ensuring that consistent, high-quality care, regardless of the severity of the condition.
Yeah.
Now, as we wrap up our deep dive, is there anything else that really stood out to you in these directives? Anything particularly surprising or thought-provoking?
What really impressed me was how these directives are constantly evolving. They're not static documents. They're living guidelines that are regularly updated based on the latest medical evidence and best practices.
It's like they're breathing right along with the advancements in medical knowledge and technology.
Exactly. And this constant evolution really underscores the importance of ongoing education and training for paramedics.
Yeah.
They need to stay up to date on these changes to provide the best possible care.
It's clear that being a paramedic is not just a job, it's a commitment to lifelong learning. Well, I have to say this deep dive has been truly eye-opening. We've covered so much ground from, life-threatening emergencies to those more routine situations, and I've gained a whole new appreciation for the complexity of paramedic practice. What's your final takeaway for our listeners?
I think the biggest takeaway is the incredible responsibility that paramedics shoulder every single day. They're on the front lines making those critical decisions in often chaotic and high-pressure environments. And these directives really provide them with the knowledge and guidance they need to navigate those challenges and provide the best possible care to their patients.
It's a testament to their dedication, their skill, their unwavering commitment to saving lives. So the next time you see a paramedic, just remember the depth of their knowledge and the complexity of their role. They are truly everyday heroes making a difference in countless lives.
And if you're interested in learning more about the world of paramedic practice, we encourage you to check out the show notes for links to some fantastic resources.
That's right. There's always more to explore. Thanks for joining us on this incredible deep dive.
Okay, so today we're going deep into something.
Deep.
Yeah, we're going to dive deep into a world.
Deep. Yeah.
Into the depths.
Into the depths, exactly. It's a world most people probably don't even think about, but it's absolutely crucial. We're talking about what happens after someone's heart starts beating again. After cardiac arrest. Like, you see it on TV. It's like the big moment. Exactly. And they call this return of spontaneous circulation.
ROSC.
ROSC. Yes, exactly.
Catchy.
Super catchy. And luckily for us, we've got a great source today, the Ontario Ministry of Health. They have this whole thing laid out. It's their Advanced Life Support Patient Care Standards.
Oh, yeah, that's a good one.
Yeah, it's really fascinating. It's like we're getting a sneak peek behind the curtain at how these amazing first responders actually use this guide to make these huge life-saving decisions, under pressure.
Yeah, it's like having a roadmap for those really critical...
A roadmap.
Yeah, those first few minutes. Yes.
Oh, I love a good roadmap.
So let's zero in on a specific part of this guide.
Okay.
The return of spontaneous circulation. ROSC, medical directive.
ROSC.
ROSC.
Yeah.
This is like the playbook for primary care paramedics.
The PCPs?
Yeah, the PCPs, the ones you see first on scene.
Exactly.
Lights and sirens.
Yep.
So important. And think about it. These directives, it's like a guarantee.
Oh, yeah.
That no matter which paramedic shows up.
Right.
They're all following the same procedures, the same high-quality procedures.
Yeah.
Consistency is key.
Yeah.
These situations.
Totally. Absolutely.
Yeah, you don't want someone just winging it.
Oh, no.
No. And something that really stood out to me in this is that this directive only kicks in IF.
Okay.
Resuscitation was already started.
Oh, wow.
So, it really makes you realize we're talking about people who were in a seriously life-threatening situation.
For sure.
It's not like they just, had a little...
fainted or something.
Yeah. Exactly. But even once the heart is beating again,
right,
it's not like everything's just magically back to normal.
Nope.
Right. What happens then?
Well, the indications and conditions section really digs into that.
Okay.
And it's fascinating. It's not just about a pulse. It's a whole checklist of vital signs, blood pressure, breathing rate. They even make sure that there are clear sounds in the chest when they listen with a stethoscope.
Oh.
Yeah, so they're getting a really detailed picture of what's happening with the patient.
Yeah, you need to make sure the heart's actually functioning well enough to circulate the blood.
Exactly.
Okay, so they've confirmed ROSC.
ROSC.
What happens next? What do they actually do?
That's where the treatment part comes in.
Okay.
And it gets really interesting. One of the key things they do is a 0.9% NaCl fluid bolus.
What?
Right, it sounds complicated.
It does.
But it's basically a very carefully measured dose of saline solution.
Oh, well.
And it's given intravenously.
Through an IV.
Exactly. And the dosage is different depending on the patient's age and weight.
I noticed that. Why the difference?
Well, it's kind of about body size, but there's more to it.
Okay.
So after a cardiac event, the body can be really dehydrated.
Oh, right.
And blood volume drops. So that fluid bolus, it's like a rapid rehydration. It helps stabilize blood pressure, get things flowing again.
Okay.
But you don't want to overload the system either.
Right, especially with kids.
Especially with younger patients. Yeah, they have much smaller blood volumes.
So it's about finding that sweet spot
Yeah.
Enough fluid to help, but not too much.
Exactly. Not too much where you cause harm.
That makes sense. And I saw there's a whole contraindications section
Yes.
where they talk about, like, when you shouldn't use a fluid bolus.
Exactly. So like if there's evidence of heart failure
Oh,
or
yeah.
fluid in the lungs.
So it's really about balancing that rapid action with careful observation.
Absolutely.
It's amazing. And even the reassessment intervals are different.
Oh, yeah.
Like every 100 milliliter for younger patients, every 250 for adults. It's so tailored to the individual.
It's very personalized.
Wow. Okay, so what else?
Well, one of the most crucial steps is getting a 12-lead ECG.
A 12 lead.
Yeah, you know those basic heart rhythm monitors?
Mhm.
This one's like way more advanced.
Okay.
It uses 12 different leads. Those are basically electrical sensors.
Uh-huh.
And they're placed on the chest, arms, and legs.
Wow. All over.
Yeah, to give them like a 3D
Yeah.
view.
3.
Yeah, of the heart's electrical activity.
That's incredible. So much more detail. Why is that so important in this particular situation?
It helps them figure out what actually caused the cardiac arrest in the first place.
Oh, okay.
Like, is there a blockage in an artery, damage to the heart muscle, an irregular heartbeat?
Got it.
And that information is crucial for figuring out what treatment to give next.
It's incredible how much they can figure out right there on scene.
It is.
And speaking of treatment, I saw there's some limits on who can actually give that IV fluid bolus.
Yeah.
Like not just any PCP can do it.
Right. Only PCPs with a specific authorization for something called PCT Autonomous OV.
What is that?
So basically, IV access and fluid management.
Uh-huh.
It can be tricky.
Oh, okay.
Requires a higher level of training.
I see.
Yeah, you need a deeper understanding of how different conditions can affect the fluid balance in the body.
Wow. It's like another level of expertise on top of everything else.
Exactly.
Okay, so we've talked about all the checks they do,
Right.
the treatment, but then what? I imagine getting to a hospital is still like
Oh, absolutely.
priority number one.
The top priority.
So how do they balance that with everything else they're doing?
Well, the clinical considerations section is all about that.
Okay.
That balance. It really emphasizes starting transport ASAP,
Mm-hmm.
but also continuing that post-resuscitation care.
So it's like a dance.
It is. It's a carefully choreographed dance between stabilizing the patient and then getting them to a higher level of care as fast as possible.
Wow, that's a great way to put it. So what have we learned today? I mean, it's just incredible. That even in those crazy intense moments after someone's heart restarts,
Right.
there's this super detailed system in place
Yep.
to guide the paramedics. And it's
Yeah.
not just one size fits all. It's
Gross.
personalized.
Yeah, it's incredible. And it really makes you think, now that you've seen the guidelines and you kind of understand the initial steps,
Yeah.
what other things could influence how successful that post-resuscitation care is?
Oh, that's a good question.
Right. Like, think about the emotional impact on the patient,
Oh, yeah.
on their family,
Of course.
the technology that's available at different hospitals, even something as simple as traffic
Wow, yeah.
on the way to the hospital.
That's crazy.
So there's a whole world beyond just these initial
Right
steps
there.
that determine someone's long-term recovery.
It really makes you appreciate all the factors that go into
Yeah,
saving someone's life.
it's pretty amazing.
On that note,
Uh-huh.
we'll leave it there for today. But thanks for taking us deep into the world of ROSC.
RSC, haha. My pleasure.
And as always, thanks to you all for listening. We'll catch you next time.
See you then.
You hear those sirens, right?
Yeah,
Wailing past.
all the time.
Ever make you wonder what's going on in there?
In those speeding ambulances.
Yeah, exactly.
Oh,
I mean,
yeah.
we all know they're rushing to save lives, but what's actually happening inside? What can they actually, DO?
Well, there's a whole system, a hierarchy of care.
Really?
Oh, yeah.
Yeah.
Levels of paramedics with different skills and authorizations. Makes you think, right?
It really does.
So that's what we're diving deep into today.
Awesome.
The world of paramedics in Ontario.
Perfect.
Specifically, the different levels and what they're allowed to do.
I'm ready.
We're using a section from the Advanced Life Support Patient Care Standards,
Okay.
a key document from the Ontario government, by the way.
So official stuff.
Oh, yeah. This is what guides paramedics in the field.
Wow. It's like we're getting a peek behind the curtain of a world we all rely on, but maybe don't fully understand.
Yeah. And this knowledge, it could come in handy someday. You never know.
Right. Okay, let's start with the basics. How many types of paramedics are there in Ontario? Like, what are we talking about here?
Okay. So in Ontario, we've got 3 levels of paramedics.
3.
3.
Okay.
Primary care paramedic.
PC.
That's the one. Then advanced care paramedic.
ACP.
Yep. And finally, critical care paramedic.
CCP.
Exactly. And Each level is a step up
Makes sense.
in terms of training, and what they can actually DO medically, like what they're authorized to perform.
Authorized. So you're telling me it's not just like finish school and boom, you're a paramedic?
Nope. Paramedics need specific authorization to perform certain medical procedures.
Like a special license or something?
You could say that. It's like a license to heal from a base hospital medical director.
Oh, wow. Okay, so what kind of procedures are we talking about?
Well, these procedures, they're called controlled acts, and they're carefully regulated. We're talking about things like starting an IV, administering certain medications, intubating a patient.
Wow, that's serious stuff.
Exactly. These actions, they can seriously impact a patient,
Of course.
So it's really, really important that only properly trained and authorized paramedics are the ones doing them.
Okay, that makes a lot of sense.
Right.
So how do paramedics get these authorizations? Is there like a secret paramedic handbook or something?
No, not a secret handbook, haha. But there is a system, a very structured one.
Okay.
It involves something called schedules.
Schedules.
Yeah, schedules 1, 2, and 3.
So 3 different schedules.
Exactly. And each one lists out very specifically the controlled acts that a paramedic at that level is allowed to perform.
That's so smart. No room for guessing.
Right.
The patient gets the right care from the right person every time.
That's the goal. Absolutely.
Okay, this is fascinating. I'm seeing now how much structure there is behind the scenes.
Oh, yeah.
But what about the guiding principles,
Yeah.
the rules of the road for paramedics?
Ah, well, that's where the document we're looking at today comes in.
Okay, yeah.
The Advanced Life Support Patient Care Standards.
It's a mouthful.
It is.
ALSPCS.
There you go. ALSPCS. That's our guiding light for paramedics here in Ontario.
So the ALSPCS, lays it all out. All the rules, guidelines,
Pretty much.
what paramedics need to follow.
Yep.
Okay, that makes sense. But what about basic life support? Doesn't that play a role too?
Oh, absolutely.
Because sometimes that's all that's needed, right?
Right. And it's important to remember that even when more advanced procedures are needed,
Mm-hmm.
the basic life support patient care standards, or BLS-PCS,
Got it.
they're still followed.
Oh, interesting.
Think of it like a continuum of care,
Okay.
where basic life support is like the foundation for everything else.
I like that. That's a good way to think about it. So this system, it's super thorough.
It tries to be.
But what about real-world situations? Like, what if things don't go exactly according to plan?
Oh, that happens all the time.
Right?
Emergencies rarely unfold like a textbook example. So the system, it acknowledges that.
Oh.
Paramedics can actually deviate from the ALS PCS
What?
if the circumstances demand it, yeah.
Wow. So they do have some flexibility.
They do. But it's not just like a free-for-all, right?
Right.
If a paramedic decides to deviate from that standard procedure, they got to document their reasons why they did it.
Oh, I see.
That documentation keeps everyone accountable.
Makes sense.
Helps ensure patient safety, even in the most, challenging situations.
Right. It's about balancing flexibility with responsibility.
Actually.
Okay. Now, what about those really specialized cases, like the ones we see on the news sometimes? Air ambulances,
Yeah.
specialized teams.
Ah, that's a whole other level of expertise.
It is.
That's the world of critical care paramedics and flight paramedics.
Wow.
Highly trained individuals operating under a slightly different set of rules. They actually follow separate directives.
Really?
Issued by the Orange Base Hospital. And they handle, the most complex medical situations out there.
It's amazing how much expertise goes into making sure that every patient, no matter the situation, gets the best possible care.
It's a testament to the paramedics,
It is.
Their dedication, their skill.
Absolutely.
And it makes you wonder,
What?
with technology always changing, healthcare systems under pressure, how are the roles of paramedics going to evolve in the future?
That's such a good question. What new skills will they need, right? Are we going to see even more specialized roles? Makes you think.
It does.
Well, for our listeners who are just as fascinated by this world as we are, I highly recommend checking out the full Advanced Life Support Patient Care Standards document.
Yeah.
It's truly an eye-opening journey into a system that, let's be honest, saves lives every single day.
Every single day.
Amazing.
It is.